Good morning, everyone. Welcome to our final public health hearing for this session, this short session. We are so thrilled and honored to be here together with you, our fellow committee members, members of the public. And we have, as you often hear me say, we have a number of people here to testify before us today and a number of officials, more than we normally have. So I expect that we will have lengthy conversation. So I will just encourage folks to, members of the committee to continue to ask direct questions and to keep those questions limited and on topic. And we do have a few of the folks who are signed up first on our list are not quite here yet. So unless Commissioner Navarrete, oh, excuse me, before we begin, I am remiss. Senator Anwar.
Thank you, Madam Co-Chair. Let's begin.
Representative Claridis Detria. Ditto. All right, let's get to business. If Commissioner Navarrete is not here in the room, I believe Dr. Gifford is the first one on our list. Dr. Gifford, welcome. It's nice to see you.
Good morning, Representative. Nice to see you as well. Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claridis Detria, and distinguished members of the Public Health Committee. I'm Deidre Gifford, and I'm the Executive Director of the Office of Health Strategy. Very pleased to have the opportunity this morning to comment on two bills before you, Senate Bill 440 and House Bill 5316, the agency's bill on CON. First of all, concerning Senate Bill 440, the Office of Health Strategy appreciates the overall intent of this bill, and we share the overarching goal of ensuring the adequacy and stability of our healthcare system. We also agree that the regulatory process should be efficient, transparent, and effective, and we look forward to continuing to collaborate with the committee and with stakeholders to making continued improvements in the Certificate of Need program. With that said, there are several provisions in this bill that would significantly undermine the intent of the CON program, and others where OHS has concerns about overly broad language and a lack of clear definition of terms that would make implementation problematic. Those concerns are spelled out in great detail in our written testimony, and we'd be happy to discuss them further with the committee. Generally speaking, the bill adds new areas of CON review, specifically the relocation of certain services and the review of private equity. We note for the committee that we already review terminations of service and would like to discuss further the intent of adding relocation to this section. And we also agree with expanding reviews of transfer of ownership and assets, including to private equity, and the governor's bill SB 9 would focus not specifically on private equity, but on expanded reviews of transfers of ownership that under current statute do not receive review. However, Section 2 of this bill goes on to severely limit the timeframes that OHS has to review and act on the applications. We do not agree that the severely shortened timeframes and automatic approvals contemplated here are appropriate and believe that they could significantly harm not only applicants and the public, but might undermine the intent of the CON program. We agree that the process should be efficient and transparent, and note that the prolonged timeframes experienced during the pandemic have been decreased by up to 60%, and we are committed to further streamlining the program. The second major concern in the bill is that it would remove the requirement for CON for a large number of significant transactions. The purpose of the CON program is to work with healthcare providers to ensure that the system is adequate to meet the needs of the population. When evaluating an application, OHS looks at the expected need for a service in the particular service area and compares that to what is being proposed in the application.
Excuse
I-
me, Ms. Deirdre, your time is up. Thank you.
Thank you, Dr. Gifford. If you could finish that
I will
sentence,
wrap
and
up.
we'll have a number of questions for you as well.
By eliminating CON for significant segments of the healthcare system, the risk is that we have large numbers of underutilized services in some areas and a lack of services in others. This could drive up demand and cost and risks a maldistribution of services that would exacerbate issues of access and quality.
Thank you, Dr. Gifford. I know you have much more to say on this topic, and I believe that a lot of those points will probably come out in conversation and questions among members. I would just like to begin with one question, and then I'll turn it over to Senator Anwar, and we'll hear from members of the committee. The CON process is certainly one that we have talked about quite a bit in this committee and other places, just in terms of our access, equity, affordability, safety, all of those issues. At this point, some of the concerns that you're talking about are timeline from the Office of Health Strategy, and certainly some of the concern is about timeline on the part of those healthcare providers who are seeking to be able to put services in place. So if you could just speak kind of briefly overall, there are a number of bills. You referenced Senate Bill 9. We have 440. And in terms of all of those bills, your overall philosophy and thought about the CON process, and just from a large scale or 30,000 foot level, what is your office's hope and your hope as you look at the CON process and how we generally need to move forward?
Thank you, Representative. I would summarize by saying that we agree with members of this committee and others, stakeholders that we've spoken to, that it's very important for the CON process to be transparent, efficient, and effective. And the bills that are before you, some of the bills that are before you today and SB 9 are working towards that end. And we are very interested in continuing those conversations. We think that some of the approaches contained in this morning's bill 440, excuse me, get the number right, 440, would be detrimental to the program and actually undermine it. But that's not to say that we disagree with continuing to work on where appropriate, thinking about shortening some timelines, lowering some of the opportunities for extensions, for example, and thinking about how to further streamline the program. I will mention in terms of transparency that OHS, for the first time, has put information about the timelines for approval on our website. That was just published last week or the week before. We are more appropriately staffed than we have been for a number of years. And those statistics demonstrate that there's been a 60% reduction in some of the key timelines. So we are making very good progress towards shortening the approval timeframes and look forward to continuing that, but without undermining the underlying intent of the program.
Thank you, Dr. Gifford. Senator Anwar.
Thank you, Madam Co-Chair. Thank you, Dr. Gifford, for your testimony, and thank you for the work that you and your team do. Number of questions for the bill that is the Office of Health Strategies bill on CON. There is no healthcare system, and majority of them that have testified or at least have submitted their written testimony are in support of it. Even the ones, so I can understand that if a private equity is against it, I can understand that, but the ones who are not for profit, they're also against it. If I've been reading the testimonies of the private medical groups, they are also, at least in the written testimonies, have been opposed to it. I want to try to understand, why do you think that healthcare systems and the people providing care are opposed to the Office of Health Strategies bill?
You're referencing 5316,
Correct.
Senator. That deals with, and I didn't get to my comments on that bill, but that deals with transfer of ownership of large group practices and changing some definitions around large group practice. I will say, Senator, that there is a diversity of views on the topic. Much of what is contained in that bill comes from recommendations from our physician practice work group that was set up at the behest of the legislature in 2022. That membership was physician practices. And we worked with them over a number of months, produced a report for this body, which we'd be happy to reshare with you. But they were generally concerned about a lack of understanding, knowledge, insight of what was happening in the physician practice landscape in Connecticut, because our definitions were unclear and in some cases inconsistent, which we address in the bill, because many, many transactions did not undergo any scrutiny because the definitions were extremely narrow and there were presumptions of approvability in the statute. So we've taken those recommendations and the result is 5316.
Thank you. And if we were to look at 440, one of the parts in 440 is trying to have very strict guidelines on the timeline for response for Office of Health Strategies. And then that's after listening to the process issues and the efficiency of or lack of efficiency in the process. Do you think Office of Health Strategies need more personnel to be able to take care of the current needs to be able to address these issues in a timely fashion? Because the delay is associated with delay in providing healthcare. And in this body, we have been hearing about the delay in healthcare, the access to healthcare. And then amongst the various causes of that, at times it feels that the process within the Office of Health Strategies is part of the problem too. Could you explain how we can help the Office of Health Strategies to have enough personnel to get into the timelines that have been suggested in 440?
Senator, let me start by saying, as I said before this committee last session, we understand the frustration on the part of entities that had applications before us during a period of time, 2020, 2021, and parts of 2022, when the office was severely understaffed and applications took longer than they normally would have. That staffing issue has largely been addressed thanks to you. The governor's budgets in the past couple of years have substantially increased the number of attorneys and the number of analysts that are available to work on the CON program. I will tell you, Senator, 4 times this year in 2023, I have been asked by applicants for additional time in the CON process. In other words, OHS was ready to move forward to the next stage, and the applicant said, may I please have an extension? So we have, in some instances, turned the tables to the extent that OHS is ready to move when an applicant is asking for more time. In addition to that, I think we can continue to consider ways to further streamline the process. So, for example, we do something called completeness letters, where we mail a letter to an applicant asking for additional information to be sure we have complete information in the docket before rendering a decision. We could consider limiting those transactions. And we also are willing to talk about, the number of extensions that OHS grants to the agency when contemplating an application. But some of the timeframes, severely shortened timeframes that appear in 440, really wouldn't give the office sufficient time to do the work that's required to review sometimes very complex applications. They would limit the time that the public has to review and make input on an application, and we think could potentially lead to fewer agreed settlements or more denials, and so could potentially also disfavor applicants.
Thank you for your response. And my last question in the first round, I wanted to ask, as I read the bill of Office of Health Strategies, the 5316, it's quite clear that the broader strategy or the thought process is that Office of Health Strategies has studied how the private equity come into a state, buy a healthcare system, and then start to slice and dice it and then try to sell properties, try to sell parts of the entire system to try to make money on the backs of our healthcare system, but also our patients and our citizens in our state. So the broader vision is from 5316 is to have a communication system, data collection and information that is going to allow the Office of Health Strategies to be able to be part of that process to make sure that the historical abuse and the abuse that's happening in the rest of the country does not happen further in our state. Is that a better understanding?
Senator, I would say that in general, we've all are reading and have read about transformations in the healthcare system that are of concern. In particular, things that maybe disfavor local operation of the healthcare system, that disfavor patients and providers. And none of us wants to see damage to quality or access as a result of some of those practices. So in general, the goal of 5316 is to provide further transparency by looking at different levels of ownership. Right now, things can be sort of couched in different corporate structures. And the intent is to make sure that no matter what the level of ownership, when transactions are happening, they're reviewed, and making sure that there aren't structures put in place that completely avoid the calling something a group practice because of who owns it or what the corporate structure is. So in general, I think we agree, Senator, that making sure that the system continues to focus on access, equity, and quality is the intent behind 5316.
Thank you so much, Dr. Gifford. Back to
Thank you, Senator Anwar. Representative Clara DeStitria, to be followed by Senator Gordon.
Thank you, Madam Chair. Thank you, Dr. Gifford, for being here today. And just to dig in a little bit deeper to what the senator mentioned, I think a lot of people, the big issue with CON is the time frame. And you've heard, and that's what we're constantly talking about. That's one of the biggest issues. And from what I'm hearing you say, that the backlog was more in 2022, and you seem to have rectified that and streamlined. Can you just, again, tell people what you've done to hopefully make those transitions much, because that's the one I know.
Thank you for the
With our
question.
CON process. Thank you.
So unfortunately, there were periods of time during 2020 and 2021 where the agency had 1 or 0 attorneys. These transactions require an attorney to their complicated legal analyses, and we take them very seriously. So that was an unfortunate, there was an illness and a death, unfortunately, that limited our staff. Since that time, we now have multiple staff attorneys, a new director of legislation and regulation, and a general counsel. So as I mentioned, and we included as an appendix to our testimony, our timeframes from the time an application is filed until final action have reduced in those applications that are done, have reduced by about 60%. We have instituted new processes for reviewing applications to make them more efficient, and completely worked down the backlog. That there were a few cases when I took over in January of 2023, there were still a few lingering cases. Those have all been resolved, and we're dealing right now in a timely fashion with new applications and determinations as they come in.
Thank you for that explanation. And maybe it would be beneficial for this committee to get something from your office just to show us the time frame of, obviously without names, but you're getting one. This is how long it's taken to go through the process, so we could see exactly how long these CON approvals or disapprovals are taking.
We would be happy to do that. And as I mentioned, we believe the process should be transparent. It's why we've posted our statistics for the first time on the website. So there is an appendix with our testimony that will show you some of that, but if there's more you'd like to talk about, we're happy to.
Okay. And did you, you submitted your testimony? Just looking for it.
Still under review. Thank you.
Thank you, Representative. Senator Gordon.
Thank you, Madam Chairwoman. I have many, many questions, but I'll only ask a couple. And I know, Dr. Gifford, it's nice to see you. I know I do owe you a letter with many of my other questions, so I will try to get to that and send it to you. And If you haven't submitted your testimony, I look forward to seeing it soon so we can see in writing, all of your ideas and concerns. One question I have is about the timelines. I know your office has heard from me about the serious concerns there are with what's happening with the certificate of need review relative to Rockville Hospital, which is in my district, and that bigger issue that's going on. But my question is, what type of timelines would you be thinking of? I come from a world where I used to be a town official, and we would follow very clear statutory timelines on a planning and zoning commission when we review things, different steps along the way, very clear for land use applicants, very clear for town government and for the public. If you have concerns about 440 and the timelines there, and there's a lot in 440 that I do like, and there's a lot in 5316 I do not like, what type of reasonable timelines would you suggest, or would that be in your written testimony?
There are comments to that effect in our written testimony. Senator, I think one thing to think about, and this goes to Representative Claridis Detria's comment, is to look actually about where in the process the excessive time has taken. And I'm not sure that it's in the places that are actually addressed in 440. We might talk some more, as I mentioned, about completeness letters. There's a time frame between the time the application is submitted and the application is what's called deemed complete by the agency. We could talk about making sure that that timeline is as appropriate as possible. That process benefits the applicants in many ways because it gives them the opportunity to make sure they have all the relevant information in the docket before a decision is rendered, but we could certainly talk about that. And then I think the number of extensions that are granted of that current 90-day period is also something that we should consider further.
Thank you. And my last question, if I may, Madam Chairwoman, is I had asked this prior of you at a public hearing relative to, and this is in 5316, about an automatic approval of large groups. And I had cited a state law 19A-638A3, and I didn't want to put you on the spot at the time, so I had asked at a public hearing if your office could get back to me. And I still have not heard about if that law conflicts with the proposal in 5316. There's been a concern that it might, maybe it doesn't conflict, but there's been a concern raised. Have you looked into that?
We have, Senator, and I'm going to invite our director of, with your permission, Madam Chair, our Director of Legislation and Regulation, Boyd Jackson, to join me. But I will say in general, Senator, just to be very clear, because the language in the statute is complex. To be very clear, all of the transactions around large group practices that are currently reviewed under existing statute would continue to be reviewed under CON. There would be no automatic approvals of things that are currently reviewed by OHS. Our bill contemplates expanding the number of reviews of large group practice transfers of ownership, but we don't have, to the previous conversation, we don't know how many there would be because we don't currently have a window into them. And we don't know, consequently, how many new staff might be in order if we were to review all of those new transactions. So the bill defines what the new transactions would be and delays them for a year. That automatic approval just refers to the fact that we would need an applicant to tell us that the transaction is happening so we could count them. It would be approved, and then the new CON review would be delayed by a year. So currently reviewed transfers of ownership of large group practices would still be reviewed. New ones would be counted for a year and then reviewed once we knew what to expect in terms of resources. With respect to the statutory conflict, I'll ask Boyd if you could introduce yourself and answer.
Hi, I'm Boyd Jackson. I'm the Director of Legislation and Regulation. this bill amends that section, proposes to amend that section. I believe that's that is the requirement that a CON be obtained for a large group practice, unless it is to certain exempted individual entity types. So this proposes to amend that, and then grants automatic approval to a subset of those. So we don't believe that this has a conflict. We just believe that it grants a subset of those on a temporary basis, and read in conjunction with the Governor's Senate Bill 9 would alleviate those concerns. But we also heard from the chairwoman that there might be input from the committee's legal advisors. And so we're certainly happy to continue those conversations to make sure that our intent is accomplished in a clear way.
Thank you, Madam Chairwoman, and I'll just close by thank you for the answers. And I am very concerned that we don't have written testimony for a public hearing for us to see and for the public to see relative to what you're testifying on. So I just want to state for the record, I'm very disappointed in that.
Understood, Senator. Thank you.
Thank you, Senator Gordon. Senator Amor.
Thank you so much, Madam Co-Chair. Thank you, Dr. Gifford, second time around. 440 talks about some of the disease areas to be able to see as you had mentioned about access. And one of the components with the access is that there's a supply-demand equation. Right now, mental health, substance use, cardiac care, all of those things are, of course, all across the state of Connecticut. But the support system for outpatient treatment as well as inpatient treatment is somewhat limited. And I'll start with an example where cardiac care in the entire eastern part of the state of Connecticut, if somebody needs a cardiac intervention, their access is very poor. There's no cath lab to be able to do emergency catheterizations, but also do diagnostic catheterization. So everybody in the eastern part has to go to a bigger center, which is limiting the access quite a bit. And you're dependent on emergencies for the EMS, which is dwindling down, and that's another conversation separate. But because of the lack of enough EMS and the physical distance, and it is really impacting the outcomes. And then the bill is asking for not to have some of that care that our citizens need to go through the CON process, because the barrier to entry for anybody is so significant that, and the previous decisions have resulted in nobody being interested to provide that care. And subsequently, it's our citizens who are paying the price for it with their lives. Are you open to having some of those areas have opportunities of no CON for a certain amount of time so we can provide access to our citizens?
Senator, I understand your concern, and I can't comment on the specifics of the prior applications around cardiac services. But nothing has come before the office in my tenure in the last 15 months or so with respect to expanding those services. I would note with respect to behavioral health that there are already significant exemptions for facilities that have a contract with either DCF or DMIS. So there's no barrier to entry for facilities that are working with the state to provide services through our public contracts. It's the private facilities that do not have a contract with the state to provide those services that require, in some cases, CON. In some cases, they submit a determination and no CON is required. School-based health centers, for example, don't require a CON. For-profit substance use disorder treatment facilities do require a CON, as do not-for-profits that don't work with the state. We've had a number of those in my tenure. I think the applications have been approved in a very timely fashion in most cases, or there's been an agreed settlement. I would note, Senator, that a number of these facilities, when they submit their application, propose that they will not accept Medicaid. And the CON process has offered us an opportunity to reach an agreed settlement in a number of cases that would said the CON is approved on the condition that you will see our Husky members, and they've been agreeable to that. So to us, it's a very important opportunity to set a condition on some of these CONs That increases access, to your point. And it also will allow us to have an understanding whether some of these for-profit centers are being built only in areas of high income and not in areas of low income. Therefore, potentially at some point having an oversupply in some areas and a severe undersupply in other areas. That's the whole point of CON. So while I understand, Senator, your concern, I think to address it, we should go back to what we were talking about, which is making sure that the system is transparent, efficient, and effective. But I don't think that we would agree that eliminating CON altogether for some of these services is the right step at this point.
So that's more of a policy question too, in some respects, because I think Representative Zupkus has a question, so I'm not going to touch on that because I know she will ask this part based on my understanding. I can read minds too, right? But I think from a cardiac point of view, going forward, let's forget about the past. Going forward, recognizing that time is life for patients who are having acute coronary events. The best case scenario for somebody in Ashford or other parts, eastern part of Connecticut, to get to a cath lab, a good case scenario is 1 hour. The probability of surviving by that time with the EMS timelines and so on decreases very rapidly. So I would, there are our citizens. I don't like the idea that we have two systems of care for people who are in the farthest rural parts of our state and the ones who are closer to the cities. Because for heart attacks, which is still the #1 cause of death, the quality of care, the difference of care for intervention in acute event is very different. So I would urge you to consider, the Office of Health Strategies to consider improving the access in a timely fashion so that everyone, they should live healthy, but if they are unable to have interventions done in a timely fashion and a diagnostic management done in a timely fashion, the outcomes are poor, and we need to address that now rather than later.
Understood, Senator. The implication is that the CON process is what's preventing an expansion of services. That's the part that I'm not able to comment on. I have not seen an application in my time in the last 15 months at OHS to expand cardiac services in an area where you're describing a need. So I can't comment on prior applications, but I haven't seen an application for those services in the last year and a half. So if there's a need and an application comes before us, it would be evaluated in that way.
Thank you so much,
You're
Madam
welcome.
Chair.
Thank you, Mr. Chair. Representative Zupkus.
Thank you, Madam Chair. Good morning. Thank you for coming, Commissioner. As you know, I think you know how I feel about the CON process from the last time you were here. I represent part of Waterbury, and that is a huge concern, as the other hospitals that Senator Anwar talked about and Senator Gordon. But with that being said, last year there was a bill that passed, and to what you were just talking about the underserved and Medicaid and those kinds of things. Last year, there was a bill passed for birthing centers, and it skirted the CON process. They did not have to have a CON process, and the reason was it's so cumbersome. So I would just like your thoughts on that, because to me, I did not like that. I think either it's a CON process or it's not. Let's fix the process or do away with it. So I would just like your thoughts on that, please.
I think I would not necessarily agree that the reason CON, there was a temporary ability to not seek a CON for birthing centers. I'm not sure I agree it was because that's cumbersome. The impetus there was we don't currently have birthing centers in place. And so there was an opportunity for new entrants into the market under that new statute to come in and establish birthing centers in places where there was an opportunity. So it was about having a service that doesn't currently exist in the state, knowing that we have an issue with maternal health, that we have some rural areas that are looking to expand or need potentially new services around childbirth and maternal care. So that was the impetus around the CON provisions in that bill.
So are you, and I don't want to put words in your mouth, are you saying if there is a new medical facility or something that hasn't happened before, it's new, that they would not have to do? Are you in agreement? They wouldn't have to have a CON process?
No, I think this was specific to birthing centers. It was, if you recall, last year, part of a suite of legislation around improving maternal and infant health and decreasing disparities. So no, I wouldn't agree. And in fact, we have part of our statute that requires for new technologies coming into the state that they undergo a CON review because the need is not equivalent. I think the reason was very specific to birthing centers in the context of a maternal health crisis and the potential need in certain areas of the state.
So will they have to, will they have to eventually do a CON to stay open?
Yeah, no, not if they open under the law, they would not need to do a CON to continue to operate. But after, I think it's 5 years in the statute, after a certain number of years, that part of the statute sunsets and then new entrants into the market would need to come in for CON.
Thank you. I appreciate your answers. And I don't understand. I can't understand in my head how we pick winners and losers. And I think that it needs to either be fixed or done away with, because I don't believe that somebody or some facility should not have to go through that process while others are collapsing and possibly going out of business to wait on the CON. So thank you. I appreciate your comments.
Thank you, Representative Zupkis. Representative Cook.
Thank you, Madam Chairman, and nice to see you, Dr. Gifford. Thank you for being here. I had a question, but I'm really glad that you just said something that I would like to just piggyback on for a second. And you said that we have a huge maternal health issue in the state of Connecticut. Or you said a maternal health issue. I added the huge. So my question to that is, so we've also seen that hospitals have skirted around that issue and eliminated their maternal wards or birthing centers. Is that something that you believe we need to perfect in that CON process? And I know that we have guidelines for that, but yet we have people that are removing their services to the point where if you look at Sharon Hospital specifically, which is 45 to 50 minutes to my west, their center has eliminated much of their maternal health services. And so the only place for a woman to go if they're having a child would be to go to Torrington, Charlotte, Hungerford, or to Waterbury, or across the border. So we'd be sending our services to New York or Massachusetts, depending on where you live. Within those parameters, there is also a lag in cell service connectivity, you fill in the blank. And so if we don't have the connectivity, we don't have the service, when we talk about these processes, all of that be a factor as well? Because if I eliminate maternal health completely out of Sharon Hospital, we're 45 to 50 minutes, and that could be the matter of life or death if we have a high-risk pregnancy and something happens. Or if a woman is told you need to get to the nearest hospital and something goes wrong between point A and point B, you're sitting in a very dormant area with no cell service. So you can't get a hold of anybody. Is there thought in that when we talk about the CON?
Thank you, Representative. Yes, and in the decision that was rendered in that particular situation, all of those factors were part of the consideration. So in general, OHS considers what's called the primary service area in looking at an application, whether it's to add services or to discontinue services, and looks at the need, the projected need, and the supply. And that's how the evaluation is carried out. And then part of that looks at access We look at transportation. If you look at any of our decisions around OBGYN and some of the more rural hospitals, we strongly considered transportation issues. We considered the volume of services that were delivered in the years prior to the application. We consider the other providers that are available in the area, the wraparound services that are available. So all of that is part of the consideration, which is why we have such significant concerns about some of the language in 440, because it would really shortchange the opportunity to do some of that detailed evaluation. Yes, those are considerations. Last session or the session before, the legislature also granted OHS the ability to render civil penalties when a decision is not being, or a condition is not being followed by a provider. And we had not had that ability in the past.
And I appreciate that. And I think that, so we realigned PSAs many years ago here for first responders when we talk about ambulance service and things like that. But I also know that a lot of those have not always been followed through. That is not what we're talking about here in this. So I can't question you on that. And so I don't want to be yelled at from my right. And my final question is, could you compare our CON process to our surrounding states? Do we do it differently? Are we more laxed? Are we more stringent? What does that look like? Because I don't often see that other states are having this CON battle like we are. Thank you. Thank you, ma'am.
They may not be having it at this moment, Representative, but I can assure you that CON is a popular topic of conversation. Most states have a CON program. I think it's 35 is the current number, but they are very variable. To your question about comparing, some of them look at, for example, imaging, and others don't. Some of them look at nursing homes and not hospitals. Some of them look at hospitals and nursing homes like our statute does. So Connecticut on the spectrum probably reviews a few more things for CON than other states, but we are not identical to any state, and each state's program has sort of evolved over the several decades that they've been in existence.
Thank you. I appreciate that. But I do believe that we need to see consistency across the board. And if we're talking about healthcare, it shouldn't vary from one area or another. I think it needs to be consistent, because then that way, and to the point of my colleague before, if we don't have consistency, then nobody knows what the rules are. And if people have a way to skirt around the rules, then that means that we don't have consistent rules. And at the end of the day, the people that suffer from that are our residents. And it is the healthcare of those residents. So as we move forward, I really hope that that consistency becomes straight across. And there is no exception to the rule. If we need to expedite something, I think that we gather to expedite it, especially when we talk about the lag in women's healthcare. And that doesn't seem to be a hit on that, and that should be expedited, but it shouldn't skirt the rules. And then to the good senator's point, testimony ahead of time really helps us be able to question things that are there. So I would hope that in future that we have that as well, because as I sit here and try to ask questions of things that are really relevant, we don't know what your testimony is going to be, so we don't know how to ask those. So thank you. Thank you.
Understood.
Thank you, Representative. So to that end, Dr. Gifford, you did have a few other comments on 5316, and I know we've had some discussion today about that. Were there a few brief remarks that you wanted to add to the conversation related to that bill, which is a bill that you have proposed?
Very brief, and thank you for the opportunity, Representative. HB 5316 does three things. I'll try to summarize them briefly. First, it expands the definition of large group or group practices to include practices owned by a public company or entity. Right now, we have a fairly restrictive definition of what is a group practice. So this would align with other definitions of healthcare ownership. Second, the bill reconciles data reporting requirements in terms of the size of the group practice. We have two different numbers in statute. One place it says 8 is a large group practice, and another place it says 30. So the bill would streamline that and use a common definition of 8 or more providers in a large group practice. And then third, it removes certain exemptions that are in the current statute for CON review. Right now, we review very few transfers of ownership for large group practices. And the reason is that there are 3 exemptions in the statute, which are very easy to overcome merely by a legal structure that doesn't necessarily reflect the actual operational structure of the practice. So the bill would also eliminate those exceptions so that we would have the opportunity to understand, to have transparency into the number and type of transfers of ownership of large group practices that are occurring.
Thank you. And one final question, I believe, before we let you go, and we know we'll be continuing the conversation as we often say here. Some people say we shouldn't have CON at all, that having the certificate of need process doesn't necessarily help us with those issues of access and affordability and equity, and that the market will help us get there on its own. And I guess just final closing comments and thoughts from you. When we all in this state, in particular this year, given the situation with some of our hospitals, are looking at who is investing in healthcare, where, and for what purposes, that's where we're weighing how the certificate of need process works for us or doesn't work for us, to Senator Anwar's comments. This is the balance that we're trying to achieve. So when you look at this conversation in its entirety and think about that statement, the market will really help us address what we need. How would you respond to that?
Representative, you use the word balance, and I completely endorse the spirit of that term, right? We need to balance the need for efficient, transparent, and effective review with the need to understand what's happening in the healthcare market. For many, many, many reasons, the healthcare system in the United States is not a regular market. There are all kinds of reasons why the usual shopping for a car, or shopping for eggs or groceries, the usual kind of market forces do not apply to healthcare. And I think we all kind of understand and appreciate that. The payment is different, the transparency is different, the understanding and transparency around quality, cost, et cetera. So the reason that most states continue to have a CON program is because most states agree that in order to balance the market with the needs of the population, some degree of oversight is appropriate. What I see working with my colleagues around the country on these issues, particularly around different types of investment in healthcare, what I see is actually states taking more oversight of transfers of ownership and transactions. I see many states looking to understand and catch up with what's been happening in the market, not retreating. And I think it would be a mistake for Connecticut to retreat in this effort to understand, have a window into, and potentially have some input into these types of transactions, which, to your point, could be very detrimental to the healthcare system as a whole.
Thank you, Dr. Gifford. And we thank you for your time with us today. I will just note in terms of our birthing centers legislation that certificate of need words for those centers who would, the pass for those centers who would be providing Medicaid services and availability. But thank you so much for being here with us today. We are going to go
Thank you.
next to Senator Looney and Attorney General Tong, who are number 1 and 2 on our list, and will be coming up together. Since they are both signed up separately, we will give them their 6 minutes, 3 minutes each, and then we'll have questions for you. I expect you will have many questions, and we are so happy to have you both here with us today.
Thank you, Madam
Welcome.
Chair, and good morning to you and to Senator Anwar and to all of the distinguished members of the Committee on Public Health. I will yield at the beginning to Attorney General Tong because I believe we have testimony that is somewhat duplicative on several bills that we are both strongly supporting, and then I have separate testimony on another bill, Senate Bill 1. So I'll yield to the Attorney General.
Thank you, Mr. President. This is a rare treat. It's not every day I get to testify with the Senate President and also get yielded to by the Senate President. So thank you. Thank you, Madam Chair and Mr. Chairman and ranking members and members of the Public Health Committee. It's good to be home here in the legislature. And to submit, we've submitted testimony, maybe not as quickly as the chairs would have liked, but you have it now. I apologize for the delay, but I'm here primarily to offer testimony on Senate Bill 440 that we've been working with the Senate President on together. And thank you, Mr. President, for allowing us to be a part of this effort. I want to note, if it's okay with the chairs, I have 2 members of my staff in case I get out too far over my skis. I have the Chief of Staff, Kara Passero, in my office, and Nicole Demers, who's Chief of our Antitrust section. So I'm really here to talk about 2 things. I'm here to talk about the Certificate of Need process, but really in a larger sense to talk about the Notice of Material Change process. And the way I would frame it is the Certificate of Need process is really the responsibility and province of the Office of Health Strategy and Dr. Gifford. Whereas we and the Attorney General's office have responsibility for larger questions about antitrust and about competitiveness, and in that way about access and consolidation. And I think the reason why we're all here, it's no secret, is that there's an overall concern about access and the way in which access and quality and price is impacted by consolidation. By fewer and fewer providers, or many providers being controlled by fewer and fewer major players. And in particular, we're concerned about one player, a private equity-backed operation, Prospect Medical, that controls a number of hospitals here in Connecticut, Waterbury and Eastern Connecticut Health Network, including Manchester and Rockville. And we're all very concerned, it's obvious, about the state of those hospitals and their ability to provide services. And not a day goes by that people look to Senator Looney and me and others and ask us to do more and to do something to help the patients, really, and the workers, the doctors, the nurses, the providers, the actual people that do the work at Waterbury and ECHN and Manchester and Rockville, and to step in where we can. And I think what we've found is that the statutes need to be more clear and more robust in giving us the ability to step in and to help this situation, but prevent a future occurrence of something like we're seeing with Prospect, and to be much more critical with respect to consolidations and transactions. So let me just say, in broad terms, and I'm happy to answer questions afterwards, but there's been a lot of discussion about private equity. And I think that's not a well understood area of healthcare investment. And it's a very broad term. And if it's too broad so as to not mean anything. And what we're talking about are companies, firms that invest in healthcare, right, as investors. And so in the finance industry, in private equity broadly, in mergers and acquisitions, there are financial buyers and there are strategic buyers, okay? And strategic buyers are other providers, right? Hospitals, other healthcare providers that come in and want to combine with another organization to provide healthcare, okay? So strategic buyers, on the one hand, are existing providers. I guess you would call Northwell a strategic buyer of Nuvance, for example. Prospect is a financial buyer, okay? They may argue with that, but we all know that they are, which means they come in to make money, right? They're taking over to maximize the asset and draw as much cash as they can out of that entity. And so what this bill would do, 440, would give us more authority. It does call for the cost and market impact review to be transferred from OHS to the Office of the Attorney General, We are prepared to do that work. It would be a heavy lift, to be honest. And I recognize that there may be some concerns about such a big move. So in the alternative, if that is not something that can be accomplished in this bill, I would say that we have to strengthen our notice of material change statute. And what we're really looking for is more transparency into who the buyers are and on what terms, what their identity is, and what their track record is, and all of the various cost and market points and data points that we need to make an assessment as to whether this is fair, as to whether it's competitive, and whether it's good for patients, and whether it's good for Connecticut. That's a big piece of what we're asking for here, and additional information that we need to make an effective assessment as to whether or not a transaction makes sense for Connecticut. The other thing that this bill asks for, which I think is incredibly important, is to give us explicit authority when we do our review of a transaction to require the transacting parties, right, the acquirer and the target, to do certain things, right, to do things that make sense for patients, for doctors and nurses, and for providers, and for healthcare here in Connecticut. Essentially, to put requirements and conditions on any merger or transaction. We can probably do that now, but it would help greatly the work of the Office of the Attorney General and OHS to make that more explicit. Those are the principal parts of 440 in which we're engaged and focused on. And with that, I'll turn it over to the Senate President.
Thank you, Mr. Attorney General. And again, good morning to the committee chairs and ranking members. I'm Martin Looney, State Senator of the 11th District, and here to testify on bills that the Attorney General mentioned in addition to those 5316, 5488, and also Senate Bill 1. Back in 2015, then Republican leader Senator Fasano in the Senate, and then the House Chair of the Public Health Committee, Representative Ritter, now Speaker, of course, and I worked on SB 811 that became Senate Bill, or became Public Act 15146. And among its provisions were increasing oversight of hospital and physician practice acquisitions and mergers, as well as creating a task force that ultimately led to the creation of the Office of Health Strategy. And now, not surprising that 9 years later, we need to update those provisions in several ways. And among the issues that have arisen since 146 is the increase in private equity and other corporate ownership of hospitals and physician practices, as the Attorney General pointed out. Our suggestions would also remove the presumption in favor of approval for practice acquisitions, which would create better oversight of these transactions. There should not be a presumption going in. It ought to be neutral and then the case to be made. House Bill 5488 contains a number of other significant provisions. The bill would add infusion and injection services to the list of outpatient procedures for which hospitals cannot charge facility fees. We've also grappled with facility fees in the past, limited those facility fees. In general, infusions at a hospital-owned infusion center costs about twice as much as the same infusion at a non-hospital owned infusion center. Those disparities really can't be justified. And prohibiting these facility fees would lessen this disparity. 5488 would also restore a penalty section regarding facility fees that was inadvertently removed in the bill last year. And the bill would increase patient protections against balanced billing, which we have also. Senate Bill 1, an act concerning the health and safety of Connecticut residents. One of the major provisions of that bill deals with the health and safety of visiting nurses and home health aides. And we saw the tragic instance of two people killed in the line of performing their work. Joyce Grayson and Otigli Moru killed recently. We believe that under Senate Bill 1, it would require home health agencies and home health aid healthcare agencies to do a risk assessment of clients, which includes background history on the patient, information on other people that may be present in the home or location where the home healthcare worker may be doing their jobs. Because according to the U.S. Bureau of Labor Statistics, healthcare workers are 5 times more likely to experience violence compared to people working in other sectors. And we just cannot ignore that risk. The Nurses Foundation 2022 workplace survey also revealed that 60% of respondents had experienced violence, bullying, or incivility at work. And Senate Bill 1 also creates grant programs to help agencies who are trying to protect their workers by establishing a working group to study staff safety issues and affecting home health care and home health side agencies, and would also provide some funding to help those who believe that hiring escorts would be necessary in certain circumstances for their employees. And the escort services could also be reimbursed by Medicare, a very significant expansion. The bill does a variety of other things, including requiring the Department of Public Health to create educational materials on gun safety, and also would create a study on prescription drug shortages that our state faces so that all of our residents can access the prescriptions they need. And the bill also establishes multiple working groups, including one that studies the health issues experienced by nail salon workers because of exposure to health hazards in nail salons and high risk of infections being acquired there. And also Senate Bill 1 addresses cybersecurity threats to our healthcare system with the ever-changing cyber world. It's an extremely pertinent issue that needs to be addressed and prepared for. So there is
Excuse me, Senator, but your time is up. Thank you.
We'll stop at that point, and there are a few other components I may get to address during questions. Thank you all so much.
Thank you, Senator Looney. Did you want to finish your sentence there? You were mid-sentence.
Yes. Oh, thank you. Yes. Yeah, I'll also mention that Senate Bill 1 also would establish a healthy brain initiative through the Department of Public Health to help develop a plan to address the health conditions affecting the brain, such as Alzheimer's, dementia, Parkinson's disease, stroke, and epilepsy.
Thank you. I appreciate you adding those important pieces to the
Thank you.
conversation. Are there questions from members of the committee? I have a question from Representative Cook.
Thank you, Madam Chairman, and thank both of you for being here and your continuous advocacy for our state. My question is to the Attorney General. You were talking about switching the responsibility from one department to the other. Are other states doing that? What does it look like in our surrounding areas?
I think there's a different mix. Not all of us are created equal. I can tell you there are attorneys general, like in Rhode Island, who have much more robust authority in this area as part of their antitrust review and also as part of the CON process. So transferring that authority or beefing up our authority without a transfer would be in step with what other states are doing.
And then my last question would be, is that going to require extra staff to go into your department, or is the staff that are there ready to go just for what's going to come down the pipe for clarification?
Yes, of course, it would require more resources and more staff. OHS already does a great job with limited resources and limited staff. And so if we were to replicate that, we would need some muscle behind that.
Thank you. Thank you for your questions and for being here. Thank you.
Thank you very much. It seems this group is a little bit quiet today. Senator Anwar, as we all know, many of us are back and forth between a number of meetings and events and hearings, so I believe he will have some questions when he returns. But in the meantime, just a question for you, which Attorney General Tong, which I perhaps was remiss in not asking Dr. Gifford. In terms of working, the work transferring from OHS to the Office of the Attorney General, when I think about the certificate of need process, I do think there are a number of us as stakeholders who are involved in this conversation. And certainly the Public Health Committee has been over time. We've seen the Insurance Committee involved in this conversation, your office, the Office of Health Strategy, and others. Who are some of the other stakeholders who you would see deeply engaged in this conversation? And how do you think these conversations should continue in terms of working together with the Office of Health Strategy as you look at this proposal?
Well, that's a big question. And I think when we talk about the cost and market impact review and transferring that authority to us, I think if that were to happen, that would really be about competition. And it would really be about our ability as antitrust lawyers and practitioners to do an antitrust review of a particular transaction and how it affects competitiveness and access. I would not for a second purport to step in front of Dr. Gifford and other public health professionals in making judgments about healthcare. That's their role. And I don't even play a doctor on TV. I may play the attorney general, but I would not presume for a second to substitute my judgment for hers and for her team and whoever sits in that role going forward. But I do think the more healthcare providers that we have as part of that discussion, more healthcare, public health professionals who have a piece of that, I think the better. And so to the extent that DSS or DDS or any other state agencies are affected or impacted, they should be a part of the conversation. And the legislature should be a part of the conversation going forward.
Thank you for that answer. I know, Senator Looney, you've done so much over the years, certainly prior to my being in this seat, which just began last year, to bringing together groups of people to talk about access and affordability. And as we continue to look at changes in this session for the certificate of need, it strikes me that it might be helpful for us to sit around a table. Hearing is one thing where we're able to hear testimony and ask questions. It's another to be able to have a conversation. So that may be something that we may be looking to achieve in the near future, not to impede the progress that we have now, that we have in conversation now, but to continue that. Another question, and whether this is for you, Senator Looney, or for you, Attorney General Tong, thinking about the antitrust lawyers and our medical providers taking a look at the certificates of need. To your point in testimony, Attorney General, there are financial interests. So right now, I believe it's the Office of Health Strategy who really does contract out and look at this from a financial perspective. And is there something more that you think we should be doing in terms of having those financial experts? For example, REITs. That's probably not a term that many of us in this building are familiar with, yet it's having a tremendous impact on the conversation related to our hospitals right now.
So in a very real way, we need more economists and more people who are expert in this complex financial and corporate web of that is now our healthcare system, to unpack it and to understand who the players are and who's making money. And one of the things that we're particularly attuned to and concerned about when we look at these issues is who the players are, and are they only on one side of the transaction, or are they on multiple sides of a transaction, right? Are they the buyer, and then are they also providing services through another entity to a hospital or a provider? And so are they both the investor, and then are they hiring a service provider that they own and control to provide services? And that is obviously could be potentially a conflict of interest and a form of self-dealing. And just so we're clear, there's no end to the financial ingenuity and engineering of these big players. This is the biggest of big business, and it's extremely complicated. And we speak some of that language candidly, but there are people that have even more strength as economists and analysts who could help us do this work in a more effective way.
Thank you for that. I do think there is a lot of translation needed. Senator Looney, was there something you wanted to add to that?
Yes, if I might, Madam Chair. I think the Attorney General is exactly right. When I referred to the bill that we passed in 2015, that then Chair Representative Ritter and I worked on along with Senator Fasano, our concern at the time was hospital acquisition of physician practices, whether it be nonprofit hospitals, primarily some for-profit hospitals. That was the grave concern. And also now at that point, the idea of of corporate private equity entering into into hospital acquisition or entering into physician practice acquisition just as another business acquisition was not something in our contemplation at the time. So the world is very different now than it was 8 or 9 years ago. In addition, one of the concerns at that time also was trying to help preserve relatively small physician practices because at that time hospitals were developing the practice of hiring more and more hospitalists who would take care away from the community physician, who would no longer basically follow up and have us spend as much time visiting patients in the hospital as prior to that. And that was a grave concern also because often the hospitalist did not have knowledge of the patient's history and background and what was appropriate treatment as the community physician did. And there was an active discouragement from some hospitals from the continuing involvement of the community physician once the patient was hospitalized. So those were some of the issues that we were concerned about then. But now, 9 years later, it's to quote Aldous Huxley, a brave new world of more changes, more threatening changes, and more changes that are so complex, it's hard to even understand them at this point.
If I may, Madam Chair,
Please.
just to pick up on that, I didn't offer testimony on Senate Bill 1, but what Senator Looney just said raises the issues in Senate Bill 1 around cybersecurity and around data privacy, particularly for patients. And we strongly support Senate Bill 1 and its requirement that DPH be part of the state's cybersecurity preparedness plan because we're in a brave new world. And every day, all of us are under attack. This building, your email, my email, right, by scammers and bad actors who want to penetrate our cybersecurity defenses and get access to information. Who's got more information about people than hospitals and government? And so that's why we're prime targets and beefing up our ability to respond to those cyber attacks in the face of what appears to be a fairly catastrophic breach at Change Healthcare, which is a subsidiary of United Healthcare. We're involved in that. My privacy folks aren't here, but they're leading the way on that nationwide in responding to that data breach, which now is impairing insurance reimbursement for about 50% of U.S. medical claims right now. Think about that. Half of the medical claims in this country have been compromised by a massive breach. And so that's why we need to strengthen our defenses everywhere we can.
Thank you for that and noting that portion of Senate Bill 1 and important conversations we've had with DPH and DES, which we hope to continue. And we know what's happened here in Connecticut. I know there's a question from Senator Marks.
Thank you both so much for being here. And this goes to Senator Looney. I thank you so much for your leadership in lifting up the home healthcare workers of Connecticut and putting them in Senate Bill 1. We've been waiting a long time to be the important people that deserve a safe working environment and deserve what everybody else, when they go to work, the same thing that they receive. So I think it's going to be hard for people to understand that when we go to somebody's home to care for them, that it might be their home, but it's our workplace. That is our workplace, and we deserve to feel safe. So I do think we're going to get pushback from people when it with that problem. My question to you, and it's really, I just wanted to thank you and thank you for also mentioning Joyce Grayson, but also Otto Morulane, who was not, OSHA was not called when he died in a fire as a caregiver. And to me, that just shows what society feels the importance of home care workers are. We're pretty low on the food chain, and he was an amazing, kind man. I had the fortune of meeting him. So I've been here 1.5 years. You've been here many more than I. Do you see a big change in, obviously we all know the big change in home care, but do you feel that this Senate Bill 1 is going to be able to give us some kind of increased safety when we go to work every day?
Yes, thank you, Senator Marks, and thank you for your leadership in bringing this to our attention, highlighting it. We are going to have to pay increasing attention to the safety of home healthcare workers, visiting nurses, and others, just because of the demographic change in our society. More and more people are going to need those services. As we know, people are desperately anxious to stay out of nursing homes if they can. So people infinitely prefer being cared for at home. And if you look at the baby boom generation, the oldest members of the baby boom generation are going to be 78 this year. The youngest members are 60. So it is like for all of the history of baby boomers, it's been like a pig moving through the python, this huge generation of people. They had to build more schools for us when we were kids. They had to expand college enrollments for us when we were old enough to go to college. So now the impact is going to be at the aging end. So more services are going to be needed because more people are going to be opting for that kind of care because they're desperate to avoid nursing homes in any way they can. So the number of home care workers working today is going to be far exceeded, I would imagine, 5 years ago, just because demand is going to be there, and therefore we have to provide protections.
Thank you so much.
Thank you, Senator Marks. Representative D'Amico.
Thank you, Madam Chair. Thank you both for coming to testify and for all the good work that you do. I certainly appreciate it. I wanted to turn your attention to another section of Senate Bill 1, Senator in particular. Sections 10 through 18 have to do with allowing graduate physicians to enter into collaborative practice agreements with licensed physicians. It looks like the impetus for this is to deal with the shortage of primary care physicians in Connecticut. Just wondering have other states done this, and what has been their experience, or if you would have some knowledge of that.
Thank you. I don't have any direct statistics in that. I know other states are contemplating it because of the same challenge that we're facing here in terms of shortage of physicians and the need to, especially in the category of community physicians and primary healthcare and primary health fields.
So this would be this would be a new thing for Connecticut, and probably a new thing for lots of states if we were to do this.
I think so. Well, as I said, I haven't done a 50-state survey, and there are probably some that provide models in this, but I think it's something that's going to be looked at on a larger scale by many states, just because we're all facing the same problems.
Okay, and I didn't see any negative testimony about this, but I guess we'll wait and see what people have to say.
Right.
But thank you for bringing it forward. Appreciate it.
Sure. Thank you.
Thank you very much. Senator Looney, thank you for referencing your work. It seems like just yesterday, but a number of years ago now with Senator Fasano, and you really did bring a lot of people together. And as I referenced earlier in talking with those various stakeholders, when I was asking that question of the Attorney General, I would love to connect with you to talk about having that roundtable type of conversation, because I think we are in that kind of moment now where it would be helpful for those of us who are having these very serious conversations that are impacting people's lives and health to sit down and have some conversation together. And I'm sure that you would be an important voice in that conversation, Attorney General, Dr. Gifford, and others, including the governor's office. I believe Senator Anwar has some questions. Senator Anwar.
Thank you so much, Attorney General and Senator Looney. I'm sorry I had to go out and be with the EMS providers as they're struggling with their funding, and so I had to just be there for a short time. First of all, thank you for your testimony and for your leadership. And I'd start with you, Attorney General Tong. I know a number of people had approached you about what's happening in Rhode Island, and the conversation was that as our Attorney General, you have been at the forefront trying to protect our citizens, but our legislations had some weakness that did not empower you to be able to protect us from this recent situation with the 3 hospitals in our state. And I think at that time you said that, look, empower me and I will make sure that I can protect you. And then that's part of the challenge that we have. Could you speak to that a little bit too, please? Thank you.
Thank you, Mr. Chairman. Yeah, so the Rhode Island statutes are very different. They have Prospect Medical in Rhode Island, and the Attorney General is taking action there. A couple of features that they have that we don't have here, that's in Senate Bill 440, are explicit power and authority to require merging parties to do something, specific authority to assess conditions when hospitals or combine, or when a hospital acquires another provider of some kind. And so they have explicit authority under their statutes to condition the approval of a merger. They have specific authority then to take action to enforce those conditions. And to go even further, they have authority in Rhode Island to place hospitals into a receivership type posture, where essentially the state or a board steps in because a healthcare institution, a hospital, is being run so poorly. And so those are some examples. There's more to General Norona's powers that I can digest for you after this hearing, more technical aspects, but he has more robust enforcement authority at his disposal than I do.
Thank you so much. And Senator Looney, I wanted to thank you for your leadership in Senate Bill 1 for making sure that our healthcare workers in the state are protected, and you wanted Senate Bill 1 to be the bill to look at how we can protect our healthcare workers, especially the home healthcare workers during this session. And I also wanted to thank you because many of the bills that you have proposed 10 years ago, 8 years ago, were all about trying to protect healthcare in so many ways, even from private equity, way ahead of anybody else had. And you had predicted that this is going to be a challenge going forward. I cannot thank you enough for having that vision, but also trying to propose bills on a regular basis to try and improve some of those components. I wanted to ask you specifically because there is going to be some cost associated with Senate Bill 1, and with the tightness of the budget, this is such an important priority. We just wanted to ask you to make sure that this bill gets funded.
Well, thank you, Mr. Chairman. Thank you for your work on this and your insight. And certainly that is going to be part of the ongoing budget discussion, because there are pressing needs here that do need attention and need to be addressed fiscally.
Thank you so much, Senator Looney. Thank you, Attorney General. Thank you, Senator Looney, for your leadership and your work.
Thank you, Mr. Chair. And I appreciate the reference to private equity. And I think there are quite a few different financial instruments and means, as the Attorney General referenced earlier. Senator Rahman.
Thank you, Madam Chair. Thank you, Attorney General Tonks and our President here today. We are very lucky to have you today here. Question for Attorney General. I know you said there is a reimbursement claim compromise, but we want to know compromise by provider or outsource, and what kind of compromise?
So compromise because there's been a massive data breach. And when that happens, organizations basically go into lockdown because they need to assess how the breach happened, how much has been lost, right? Who's affected, is patient information, medical records, social security numbers, biometric information, is that now out on the dark web? By the way, this also happened not just at Change Healthcare, but at Prospect Medical. And when that happened, that was catastrophic for Prospect. I would argue that they should have been better prepared, and that they did not respond effectively. But suffice it to say, when a massive breach happens like this, everything grinds to a halt. And that's why 50% of claims are now impacted in this country, not in the state, in this country.
Thank you. Thank you, Madam Chair.
Thank you very much. That's a pretty powerful and scary statement,
Yeah.
and speaks to the need for some of this work that we're doing. Seeing and hearing. Oh, excuse me, Senator Marks. Yes, Senator
Yes,
Marks.
I just wanted to say one more thing after what Senator Anwar, Chair Anwar said, is I do believe that there is a cost to Senate Bill 1 and that it's very important. I will also say that it's the cost of doing business, and it is up to the businesses to keep their workers safe. We don't pay for hard hats. I don't believe we do on construction sites. And when we find out as parents that we need the newest, best car seat for our children, we have to keep our kids safe. So we go out and buy the best car seat. So I will always say that it is the cost of doing business, and that is the responsibility of our employer and the workforce to find the money to keep their workers safe. So I hope we can find money in the budget, but if we don't, I certainly hope that that won't be a reason why this does not pass.
Thank you, Senator Marks. Senator Gordon.
Thank you, Madam Chairwoman. Senator Looney, Attorney General Tong, it's great to see you again. I don't want to put you on the spot after you've been testifying for a while, but I certainly have a perspective, having been working as a doctor in healthcare for more than 30 years, to see the changes that have gone on. Some of them are good, some of them not always good. Do you feel, one question I have is, do you feel that the proposed legislation relative to, the private equity, the for-profits wanting to come in more and buy physician practices, buy hospitals, do you feel the proposed legislation would really, in a meaningful way, help hold their feet to the fire? You mentioned about conditions, because as you know, they view things, for lack of a better term, financially. And in the real world, looking at it financially many times conflicts with looking at it from a patient care point of view. And sometimes they conflict terribly. Do you feel that this is enough to try to hold their feet to the fire, or do you feel there's more that should be considered?
Yes, this would be a meaningful set of reforms, and it would empower the state more to protect patients and protect access and enhance competitiveness. But no, it won't solve all of these problems. And there is more that we can do. It's not in this bill here today, and I don't have a laundry list of proposals to add to 440, but we have a long way to go. And let me just sort of step back and make a philosophical statement, and that is, in Connecticut, in this country, we honor and value investment and financial innovation. And when in a capitalist system, which I support and I'm a part of, and do everything to ensure functions well and fairly and competitively. Generally, we want to encourage people to invest in Connecticut and to buy and sell businesses and to invest in the physical plan of a hospital, and to improve healthcare delivery and to provide new products and services. All of that is great and wonderful, and it drives our economy. There's a dark side to all of that. Okay. And it was legal, right, for Prospect to engineer the transaction that it did. It's legal for, in general terms, for private equity funds to invest in healthcare. And there are a lot of people making a lot of money in private equity and healthcare, and many of those people live here in Connecticut, and we honor them as neighbors and as taxpayers. But there's a dark side to that. And what I would also say is there's a lot of frustration around, and Senator Anwar and I have had conversations about this. There's been a lot of frustration around the way that Prospect Medical does business, right? But the hard truth about that is it's not illegal to invest in a healthcare institution. It's not illegal to run a business poorly. It's not illegal, frankly, in some instances, not to pay your bills. It can result in a lawsuit. And if you're in breach of contract, as lawyers, you can litigate that in court. But many of these things they get away with because they can get away with it, right? And they come up really close to the line without stepping over it. And when they step over it briefly and we whack them, they just jump back over the line so that they don't suffer, further enforcement. So this is the difficult dance that we're doing with investment broadly and corporate ownership and private equity in healthcare. But at the end of the day, right, while all of that in some universe is legal and in some universe it is supported and honored as part of innovation, it has real consequences to patients. and to healthcare. And at some point, somebody has to do something to protect patients. And that's what this is about.
If I might add to that, Senator, that's exactly the concern. 9 years ago, we were concerned about the role of larger nonprofits, buying small practices and the things of that. And that seemed rather benign compared to what we're looking at now. And because now we're talking about entities whose only motivation is profit. Now, perhaps intervening between patients and their care by owning physician practices. It's we're concerned about, we've seen already the bad practices engaged in by insurance companies when they try to take over, in effect, the practice of medicine and intervene between patients and physicians. Now you've got somebody driven by exclusively a profit motive doing the same thing. We know the practice of private equity firms in other areas sometimes is to buy an entity and then strip it down and sell off its assets. That's happened in a lot of ways. We don't want to see that happen in terms of healthcare and service provision. So I think this is certainly a first step, but may not be the last thing we have to do in order to get a handle on vigilance in this area as this whole new area of ownership opens up.
Thank you, Madam Chairwoman. And I do agree that it is a balancing act. But certainly what Prospect's done and created issues for patient care, and also what we see what's now happening across the border in Massachusetts with Steward Health, which is a whole nother mess. I think this certainly is a wake-up call to see what we can do to try to balance these interests. Thank you.
If I might add, Senator, one other thing, in terms of what we've seen of Prospect now leaving a lot of creditors holding the bag, apparently, is that one of the things we've seen Rhode Island do in some other places and would certainly recommend is that we set up a requirement for a reserve fund when entities like Prospect come into Connecticut to provide a resource at the end if they're looking to bail, leaving entities in Connecticut holding the bag. At least there would be a reserve fund to go after. And I would certainly urge the committee to include that as a portion of the bill.
Thank you, Senator, and thank you, Senator Gordon. I would underscore that any step we take will certainly not be the last. As those marketplaces continue to evolve, we will need to continue to evolve to assure protections for our residents. Senator Rahman for the second time.
Well, thank you, Madam Chair. I just want to echo my good Senator Gordon about the Prospect. This question, actually, not question, I just want to explain the Attorney General. So under the Prospect, care, 3 hospitals in Connecticut are really bad situation, Manchester, Rockville, and Waterbury. Am I right? So financially, also cyber attack, they took $1 billion loan out, and then they rented out their land, not the property, to the, who knows, maybe their own company rented out. So $1 billion they rented, took out loan, $600 million they paid themselves.
Yes.
Their executives and the shareholders. Would the hospital really jeopardize financially and service-wise? You think it's appropriate to your office to open the investigation that is the quality care compromise and bring them to the justice to prosecute those people, because put our community, public health is nuts and bolt our community, am I right? Backbone. So you think you can bring them to the justice? Thank you.
So as I've stated before publicly, we have an open investigation, and I can't speak to the contents of that investigation, except suffice it to say, a number of sections in our office are focused on Prospect and what's happening at Prospect, and we will not hesitate to use any of our authority to hold them accountable and protect patients. It's complicated, and we're working closely with the governor to figure out what the best course forward is to protect patients and ensure access, but we're doing everything we can.
This is why Connecticut need you. Thank you, Attorney General.
Thank you, Senator. Seeing and hearing no further questions, we'd like to thank both of you for being here with us and for your ongoing advocacy. We
Thank you.
appreciate it. We have now.
Thank you so much.
You're welcome. We have now gone past our first hour, so we'll be alternating between members of the public and officials on our list. So next is Bryce Chenault. Thank you. So then you can come, then you come back. I mean, I wouldn't, just, yeah, that'll be able to fix. Welcome.
Sorry, I wasn't anticipating the shift over to the general public. Thank you. My name is Bryce Chenault, and I'm the Director of External Affairs for Yankee Institute, a nonprofit public policy think tank here in Hartford. There's already been much discussion on some of the particular concerns addressed in House Bill 5316 and Senate Bill 440 on the certificate of need process in the state. And I'd like to zoom out from those and actually recommend that the bills and other bills related to it strive to eliminate the certificate of need process in Connecticut. I make this recommendation because these programs are not leading to better health outcomes for more people at a lower cost year after year, like I think our healthcare policies should do. As probably no surprise to members of this committee and others here, New York was the first state to implement a CON process back in 1964, under the same auspices as the Office of Health Strategy spoke about earlier, trying to lower costs, not duplicate services, and hopefully improve outcomes for residents. After New York, the federal government began incentivizing CON adoption by tying funding to their implementation, and nearly every state adopted some form of a CON law. After reviewing the outcomes of the policy, though, the federal government recognized its failure to curtail costs and improve outcomes. They decided to rescind those federal tax dollars in 1986. States have subsequently been repealing them. And the findings make a clear case for repeal. CON laws are associated with lower quality hospital care, higher hospital and non-hospital expenditures, increased Medicaid and Medicare costs, and they also cause people to travel further for care because the supply of a regulated item decreases. Even when we turn to concerns over equity in healthcare, studies have found that CONs lead to greater disparities against minority groups and no increase in care for the indigent. CON laws are also associated with access to less care in rural areas. The Antitrust Division and the U.S. Department of Justice, in the U.S. Department of Justice and the Federal Trade Commission have stated very clearly that by their very nature, CON laws create barriers to entry and expansion to the detriment of healthcare competition and consumers. And here in Connecticut, we've seen some of those effects with the proton therapy location that was discussed earlier, and other issues. Nobody would support this anti-competitive policy in abstract, but we are doing so in healthcare. The General Assembly correctly noted this negative effect during the pandemic when Connecticut, like other states, suspended parts of our CON program. I think we do well to expand on that temporary change and make those changes permanent. Thank you.
Thank you. Thank you for testifying within your 3 minutes. We appreciate that. Are there questions from members of the committee? Seeing and hearing none, we appreciate your being here with us and your perspective. And we are going to go next to Representative Gary Turco.
State Representative Gary Turco, the 27th District from Newington and New Britain. And I'm here with Mitch Page, who was on the list, number 45, but we're going to join our testimony together, if that's okay with the chairs. And I will just start out, co-chairs McCarthy Vahey and Senator Anwar and ranking members Somers and Claridis Ditra and vice chairs and members of the committee. We are here today to testify for House Bill 5488 concerning various revisions to the public health statutes, but specifically lines 178 to 187 that I thank the chairs very much for introducing in this bill to help our colleges and universities with their social worker programs. And now I'm going to turn it over to my constituent, Mitch Page, who is also a social worker and also a professor at Connecticut State University, to explain why.
Thank you, State Rep Gary Turco. Thank you, sir. And thank you, distinguished members of this body. Appreciate you having me here today. My name is Mitch Page, and I live in Newington. Thank you for giving me this opportunity to speak with you today about House Bill 5488. I have been a social worker in Connecticut for 38 years, licensed for 36. I teach social work at Central Connecticut State University, Central, where we have had a social work program for over 30 years, an undergraduate program. We strongly urge you to vote yes on House Bill 5488, an act concerning various revisions to the public health statutes. Specifically, Central in New Britain is working towards full Council on Social Work Education, CSWE accreditation of our new clinical Master of Social Work program with a specialization in trauma-informed healthcare. This program will offer a traditional 2-year track and an advanced standing 1-year option for students applying with a bachelor's degree in social work. We will also offer part-time and full-time options for maximum student flexibility. A large majority of our students commute, work part-time, and remain in Connecticut to contribute to our economy and our quality of life. According to a July 15, 2023 Hartford Courant article, the state of Connecticut is experiencing a chronic shortage of clinical social workers. Hospitals, clinics, nonprofits, and communities across the state have tremendous difficulty filling their social work ranks, while Connecticut residents suffer ongoing stresses related to the aftermath of the COVID pandemic, lack of affordable housing, the fentanyl crisis, and more. Our state continues to have an increased demand for treatment of depression, anxiety, substance use disorders, intimate partner violence, and trauma. According to the Health Services and Resource Administration, HSRA, the demand for social workers in the United States is increasing significantly. They project, based on demand, we will grow as a profession over 114% from 239,410 social workers in 2017 to 513,370 social workers by 2030. From our experience, CSWE will move forward with full accreditation of the Clinical Master of Social Work program at Central once the accreditation process moves forward. We have complete confidence in the ability of our faculty and staff at Central to make this MSW program a high-quality solution to meet the ongoing and growing serious needs of our communities. With your support, our social work graduates will be allowed to attain licensure upon graduation and get to work providing engaging, effective, collaborative, and sustainable solutions to some of our state's grandest challenges and most wicked problems. Thank you very much.
Thank you very much. From one social worker to another, I'm very grateful for the work that you do. And I want to thank you, Representative Turco, for championing this and really bringing forward to the committee how important this really is for us to be able to improve and expand our workforce and help our grads be prepared to serve the needs of the state. Are there questions from members of the committee? Seeing and hearing none, thank you Representative Belton.
Well, I don't have a question, but I also want to say thank you for the work that you're doing. I'm also a social worker, and my daughter just graduated from Central in December as another social worker and looking for a clinical social work program because Central didn't offer one. So I just want to thank you for all your hard work.
Thank you very much. Appreciate it.
Thank you. I'll just add, I mean, this legislation only being 3 lines is just so important to allow Central Connecticut State University to be able to get their social work master's program up and running, which as Town Councilor Mitch Page, social worker Mitch Page said, we desperately need in the state of Connecticut. So I hope this legislation, this language being embedded into a much larger bill doesn't get overlooked at some point in session. You want to take it out of here, put it in a budget implementer or something, that's fine too. But we need it for to grow our social workers and for our university. So thank you.
Thank you, Representative Turco. Hedging his bets there, but thank you, Rep Belton, for your comments. We appreciate it and certainly understand the importance of those 3 lines. And as we know, sometimes in this building, 1 word can make all the difference. Thank you for being here with us today. Next, we will go to Jason Sunby to be followed by Representative Tammy Exum. Is Mr. Sunby here with us? No. Is Olivia Rinks? And Thomas Burr? Okay, I think I'm looking at Anna Stouffer. I believe that she needs to, and I will take this opportunity to remind those who are online with us to accept your promotion once you receive it, if you are testifying via Zoom. And I see Ms. Stouffer, you have joined. Welcome, please proceed.
Hi, thank you for having me today. Honorable Senator Saud Anwar, Representative Kristen McCarthy, Ranking Members Heather Sommers and Nicole Clarides Dietra, and distinguished members of the Public Health Committee. My name is Anna Stauffer. I'm a resident of New Haven, and I'm currently an MPH student at the Yale School of Public Health. I'm here today to testify in support of Senate Bill 1, specifically Section 1, requiring home healthcare employers to provide information to any employee providing services to a client, such as the client's psychiatric history, history of violence, history of substance use, history of domestic abuse, and any current infections. I work at a community healthcare service in New Haven. We offer free physical and mental health care services, and we also operate as a syringe service program, or an SSP. An SSP is a place where people who use intravenous drugs can exchange used needles for sterile ones. I often witness our clients fish uncapped used needles out of their pockets, purses, or shopping bags. My behavior in handling the belongings of an intravenous substance user is very different from my behavior around a friend who I believe not to use intravenous substances. If a friend asked me to grab something from their purse, I would reach in without a second thought. With a client, however, I would take great care, wear proper PPE, and move slowly. If a friend asked me to hold their jacket, I would take no precautions. If a client, however, asks me to hold their jackets, I take many cautions to avoid a potential needle stick. Because I have information, I can protect myself. My point is this: it's very hard to protect yourself from a threat you aren't suspecting, and something that may pose a great threat to one's health may easily be mitigated simply by the availability of information. Home healthcare workers cannot protect themselves from threats they do not have knowledge of. Information on clients' psychiatric history, history of violence, history of substance use, history of domestic abuse, and current infections is free and can make all the difference in the well-being of an employee. This is an important bill, and I am in full support of it. Home healthcare workers need protection. They need information to ensure protection. And the question I want to leave you with is this: if we don't provide home healthcare workers with this information on their patients, can we really say that we're doing everything we can to keep our workforce safe?
Thank you very much for your powerful testimony here today. I see a question from Senator Marks.
Thank you so much for coming and testifying, and for not being a home care worker, and for being a voice for us. We're going to get some pushback from some people today on whether or not home care workers should receive the kind of information about somebody's psychiatric history or their substance use history. I, as a very, very, very seasoned nurse, often can tell that from just the meds people are taking. But I have been in many a home where I didn't know some of their past violence behavior. And that is something I feel is very important. I also think it's very important that we have a flag put on their chart, which is not part of SB1 right now. Right now, if you have an infection, there's a yellow line across your EPIC charts that says you have an infection. Underneath it will say if it's MRSA, influenza 1, COVID. If you need your MSPQ profile done, because God forbid we don't have the MSPQ profile filled out, there's an orange line saying that you have to have that filled out. And so I think that if somebody has threatened healthcare workers or had a history of violence, that too needs to be a flag for not only home care workers, but for all workers, all healthcare workers, especially if they've threatened another home care worker. So I'm just curious if, is she still there with us? I'm just curious as getting your MPH at Yale. Good for you. Congratulations. What your thoughts are on those questions that I think we need to make SB1 just a little bit stronger.
Yeah, thank you. I don't have much experience in the field of domestic abuse and domestic violence. In theory, I would hope that that information would certainly be made available to an individual going into somebody's home. I know that I would definitely like to know if somebody had history of any kind of violence or lived with or was related to someone with any kind of history of violence before entering their home, certainly if I was entering their home alone.
Yeah, thank you, because it doesn't happen now. And I do hope that we, by the end of this bill, that we will be able to have some added protections in there for the home care staff, for all home care workers. Thank you so much for your testimony.
Thank you, Senator Marks. Thank you. Seeing and hearing no other questions, we thank you for being here with us today. Next, we will go to Representative Tammy Exum. Welcome, Representative Exum. And take your time and don't forget to press the button in front of you. We're so happy to see you.
It's good to see you. Thank you. Co-chairs, Representative McCarty-Vaight and Senator Saud Anwar. Vice chairs, John Michael Parker, Senator Joey Kushner, and Senator Martha Marks. Ranking members, Representative Nicole Claire DeStitria and Senator Heather Summers, and distinguished members of the Health Committee. Thank you for raising Senate Bill 1 and for the opportunity to speak here today. I strongly support this broad and comprehensive legislation, but I am here today to speak specifically on sections 29 and 30 of this bill. These sections seek insurance coverage of coronary calcium scans for high deductible individual and group health insurance policies. Now, the first time that I ever heard of a coronary calcium scan was approximately 5 months ago. And I heard it at the time when our chief medical examiner performed an autopsy on my husband, Earl Exum, who at the time was 55 years old. We've been married 28 years. And Earl, I have to just say, was an amazing and wonderful man. And he was an incredibly healthy man. And when I received this phone call, the pathologist said to me, he's a beautiful specimen. And that was the way he started the conversation. And I said, I mean, I agree, but can you tell me more? And he said, he should not have died. He said, this is absolutely tragic. And he is such a healthy man. And I said, well, how did he die? And he said he had a heart attack. It was called the Widowmaker. And it was a cardiac event in which he had a full blockage, of which we were completely unaware. And I was just shocked to hear this information. And I said, you know, I know exactly what you mean. 5 years ago, Earl had a diagnosis of colon cancer, stage 1, removed. And at that point, he began to eat a Mediterranean diet. He did not drink. He did not smoke. He didn't ever really drink much. He did not use drugs. He did not even drink caffeine. He exercised and had a body that was a model for many of us around him. And he really worked hard to turn around his life. So to hear that this took place was shocking to us. And he explained to me, because I was trying to understand, absorb the information. He says, you know, you think about a water hose, right? And if the hose is full and it's clogged and nothing can get through, that's essentially what happened to your husband. And the blood could not get to his heart. And the only saving grace is that he likely never knew what hit him, that he dropped and that he died. And I listened to this information and I said, well, how could we not know? And I had to go back in time a little bit. And his situation was really unique. About 2 weeks before, we were eating dinner and Earl said that he had indigestion. And I said, okay. And we were eating dinner. So he took Tums. That happened maybe 2 other times. And the only other thing, he exercises all the time. He came in and was like, wow, my shoulder is sore. And I said, oh, I've heard somewhere shoulder and GI can mean heart. You need to get checked out.
Excuse me, Representative Exum, but your time is up. Thank you.
So he went in, and when he went in, he went and had an EKG the week that this happened, and it came back as normal, which gave him a false sense of security. And then he had a stress test planned. The stress test I moved up for that Monday. I flew out of town Thursday. He went out of town Saturday. He died on Sunday. He never had it. One of the things that this pathologist told me that was critically important is that this is a very inexpensive test. This test costs about $100 to $150. It literally can give the information about the status of the heart. It could have been a deal breaker. He was incredibly frustrated that we don't know it as consumers. So 2 things that I think are really important. One, what this bill is trying to do around insurance coverage. It is a preventative tool and it will save lives. 2 is to have the information that we need as consumers until this happens, that we hear from our primary care physicians that such a test exists, that we can spend our $100. We don't even have to go to a PCP. According to the pathologist, we can go see a radiologist and say, here, I want to pay for this. I want to have this scan. A score of 0 is what we're looking for. That information could have changed and saved his life. He needed a stent. That's all we needed. That's all we needed. So I am speaking today because it will be my mission in life to make sure people are aware of what they need to do to take care of their hearts. But in particular, these are low hanging fruit ways to prevent death. I don't ever want another person to go through what I'm experiencing and what my family is experiencing at this time. I do think if it's covered by insurance, though, that PCPs are more likely to mention it to patients. So that is an important piece of this as well. I know I've spoken longer than my 3 minutes, but I think that I've earned the right to do that at this point in time. And I do want to say that I thank you so much for listening to me, and I will support this and do all that I can to make sure that we push this through. Thank you very much.
Thank you, Representative Exum. Senator Anwar just has a word to say.
Thank you so much for your testimony. Thank you for your courage. And when we spoke about this bill, I said to you that this part of the bill is in honor of Earl. So thank you for this. And I also wanted you to know that Medicaid in our state covers this.
Yes.
Many insurances cover this, Medicare does not, and some of the insurances do not. And we are hoping through this to raise the awareness, but also push the insurance industry to cover this very basic test, which is a lifesaver. Thank you.
Thank you.
Thank you, Representative Exum. Next, we will go back to Jason Sunby to be followed by Commissioner Navarrete. Welcome. If you could kindly press the button so that your microphone is on and we can all hear you, including online and on TV. Thank you,
I
sir.
apologize. I'll get to what I want to say. It just takes me a minute. I apologize. So co-chairs and honorable members of the Public Health Committee, good morning. I am Jason Sunby. I'm president and CEO of Verity Environmental Technologies, the maker of Deterra, which is an at-home drug deactivation and disposal technology. And I'm here to support the passing of Senate Bill 1. Thank you for granting me the opportunity to come and speak to you today on an issue of critical importance to our communities, the prevention of drug misuse, abuse, and diversion through safe drug deactivation and disposal. The misuse of prescription drugs, in which in too many cases leads to the use of even more deadly illicit drugs, is a growing crisis that not only affects individuals, but also their families and our communities at large. In Connecticut, like many other states, you have been seeing the devastating impact of opioid abuse and other prescription drug misuse. However, there is a proactive step we can take to mitigate this issue, ensuring the safe deactivation and disposal of unused or expired medications. Safe drug disposal is a straightforward yet powerful tool in preventing drug misuse. When medications are disposed of safely, they are rendered permanently unusable and irretrievable, significantly reducing the risk of accidental or intentional misuse. By implementing robust education and promoting the use of drug deactivation tools, we can ensure that these potent substances do not end up in the wrong hands. Deterra's steadfast commitment to Connecticut, exemplified through its involvement with the Governor's Prevention Partnership and Wheeler Clinic, demonstrates a profound dedication to the state's well-being. Our commitment is so strong that one of our employees was asked to join the GPP board, and we actively participate in local initiatives. Deterra's system has become an integral part of Connecticut's strategy to combat drug misuse. Their approach not only addresses the current crisis, but also sets a precedent for nationwide application, underscoring the potential to replicate this model across the United States. Our evidence-based product was developed under contract to the National Institute on Drug Abuse, part of NIH, endorsed by letter by the DEA Educational Foundation, the not-for-profit entity of the DEA, and the Community Anti-Drug Coalitions of America, CADCA. Usability studies have been independently published by the University of Michigan and JAMA Surgery, where University of Michigan authors noted that patients were 43 times more likely to safely dispose of leftover and unneeded medications when given a pouch than even told where their next nearest take-back box was. The Ohio State University also published an independent study in JAMA Pediatric Surgery where they found that 32% more parents disposed of the medications using the pouch than those who were instructed to follow the FDA recommendations. Our product has also been published and co-dispensed by Mayo Clinic and Twin City Orthopedics for the past 10 years. These are just a few examples of the credibility of at-home drug deactivation by using Deterra. By advocating for and facilitating proper drug disposal, we are taking a stand for public health and environmental protection. To this end, I urge the Connecticut Public Health Committee to support legislation that promotes and facilitates the deactivation and disposal of drugs. This could include funding for primary prevention activities, including mandates for providing drug deactivation pouches and expanding public awareness campaigns about the importance of safe disposal. In conclusion, Deterra's initiatives in Connecticut exemplify a proactive and science-backed approach in tackling the opioid crisis. By adopting and expanding these measures, Connecticut can lead by example, demonstrate the tangible benefits investing in preventive solutions to address this critical public health issue. I thank you for your attention and commitment to the health and well-being of your residents, and I'm happy to answer any questions you may have.
Thank you very much. I think one thing that you are saying without saying is do not flush your drugs down the toilet, period.
I would like to publicly say that, yes.
Thank you.
Putting them in the sink, flushing them, or throwing them unmitigated into the trash is terrible for the environment. And in fact, our product, I know that wasn't a question, but I'll throw this in anyway. Our pouch material is actually made out of, the majority of it is made out of sugar cane. We looked long and hard to find a sustainable means to make these pouches, and it's made in a plant in, appropriately enough, Sugar Land, Texas. that runs on nothing but wind power. So it's very green, as well as getting these abusable drugs out of people's homes.
Thank you. As members of this committee know, and those who join us regularly, I love my PSA. So Senator Anwar.
Thank you, Mr. Sunby, for your testimony, and thank you for the work you're doing and in partnership with Governor's Prevention Partnership. So that's a important connection that you have. I just wanted to know, you're nationwide, you're actually trying to get this word out to the entire country. And what are the payment models for co-prescription that you have studied or your company has studied?
Yeah, there are two models that we're seeing. New York is looking at having pharmacies co-dispense this. California has dropped legislation that also looks at that approach, but there's also a third, and that is direct mailing to households. The cost is actually extremely low in doing such, but those are really the ways, whether it's pharmacies or direct mailing, that takes the pharmacy out of it and doesn't put the burden on them. It's very, very simple to do.
Because the current Section 26 in the bill, we do touch on the payment opportunity, but creating some sustainability on the payment side is where some conversations may happen. So these two models would be helpful. So is there a way to learn more about these models?
Absolutely.
Probably we can reach out to you after this test.
Absolutely.
Okay.
More than happy to help.
Sure. Thank you so much, and thank you for the work you do.
Thank you.
Thank you, Madam Chair.
Thank you, Senator, and I appreciate you pointing out the partnership with the Governor's Prevention Partnership. That is so important and such an important group in our state. We have this question from Senator Marks.
Yes.
Hi, thank you so much. So fentanyl patches, I mean, you know, back in the old days where that's the only time you ever heard of fentanyl was
Right.
when you have clients that have terrible pain and they need their fentanyl patch. And when I did have a patient that had it, I would look it up because I know that there were a lot of instances where even when you take the patch off after 72 hours, it still does have active drug ingredient in it, and children and dogs would get into the garbage and overdose. So that was the one drug that it was to cut it up and flush it down the toilet.
Right.
Because that always blew my mind. And now that I'm thinking like that there's probably a lot of other people flushing a lot of fentanyl down the toilet,
Right.
that I wonder what it is in our water system. So are we still supposed to, next time I have a patient, I'll still look it up because I always look it up, but is that still what we're supposed to do with a fentanyl patch if we don't have your system to dispose of medications?
It's a great question. And fentanyl patches, our initial product was designed to deactivate fentanyl patches. I mean, there are 8 to 10 lethal doses of fentanyl left in that patch after its usage time. It does still work. You put it in the pouch. We say put tissue paper on it that helps it draw it out when it contacts the carbon and the water. FDA, there are certain RCRA listed drugs, immediate death drugs, like nicotine, like fentanyl. But our product works on any organic compound, right? So the basis of this is activated carbon, and it will adsorb and render inert any organic compound that it comes in contact with. So whether it's a prescription drug, like those fentanyl patches are, or opioids or benzodiazepines, it will work on illicit drugs too, like illicit fentanyl, carfentanil, heroin, cocaine. It works on all of those. You can and should, it's much safer to use our product than it is to flush those drugs. But the FDA still says those are immediate death drugs. You should flush them. We give an alternative to that truly works.
Thank you. It is fascinating, isn't it?
It is.
It is. Yeah. Thank you.
Thank you.
Thank you very much. The bottom line is that safe disposal so that we are assuring life safety. There is another question. Representative Parker.
Thank you, Madam Chair. Thank you for being here with us. I have 2 questions. First, what's the price of your product and how does it compare to your competitors?
So that's really kind of 2 questions.
Busted.
Yeah. Our pricing is subject to volume discounts, right? If you were to mail one of these, if you mailed 100, the price would be probably in the $5 range, but that comes with an educational card, 4-sided card, and an overwrap that would include postage. It would go down from there. Our competitors, in some cases, in one case for sure, is much less costly. It's less expensive. However, it doesn't deactivate or destroy the drug. It suspends it in a gel. It's a good product if that's what you're trying to accomplish, but it can and will leach out. It is still an abusable form. The gel itself is non-toxic. You can dig it out, or if you add household lemon juice, it turns it back into a liquid and the drugs come pouring out. So I'm not here to, talk poorly of them, but it's a bit like buying a car that doesn't have an engine. It's still a car, but if you want it to do this, if you want to safeguard your families, then you need to do it where it permanently renders the drugs unabusable and irretrievable.
Thank you for that. That was very helpful. So then this won't even be a question, just a request. In your submitted testimony, it looked like there were hyperlinks intended, but I couldn't click them. So I'm wondering if you could just resend that as a PDF to the committee so we could review the studies that you shared about the effectiveness. I was really interested in those and looking forward to learning more.
Yeah.
Thank you, Madam Chair. Thank you, sir.
Thank you, Representative Parker. Seeing and hearing no other questions, we will go on to Commissioner Nancy Navarrete, and we thank you, Commissioner, for your patience with us today. It's much appreciated. Welcome.
Thank you. Good afternoon. Good afternoon, distinguished members of the Public Health Committee. As you know, I'm Nancy Navarrete. I'm Commissioner of the Department of Mental Health and Addiction Services. My written testimony will be submitted to the committee for review. In the interest of time, I'd like to summarize some key points from my testimony. So while Senate Bill 1 has various provisions, I will be focusing my testimony on 3 concepts included in the bill: worker safety, drug deactivation and disposal systems, and first episode psychosis, or FEP. Both SB 369 and Section 1 of SB 1 require home health care and home health aid agencies to collect and provide employees with information for not only the clients, which they will be providing service, but also for any person present or anticipated to be at the location where services will be provided. So first and foremost, and you've all heard me say this before, I want to express that I cannot overstate how serious I take the safety of our service providers and the people that they serve. Community-based treatment, meeting people where they are, is a core tenet of the work that we do, and we cannot do it without acknowledging any type of community-based service needs have to have rigorous practices in place to promote safety for workers and for clients alike. We appreciate the underlying intent of this proposal and the important conversation about risk assessment, but must express that we have serious concerns about the suggested method, specifically with the information proposed to be collected and disseminated. The required disclosure of psychiatric history and history of substance use can not only further stigmatize individuals with behavioral health disorders, potentially impacting the major strides that have been made by this legislature to ensure people are receiving the care they need, but also has serious legal and operational considerations. For example, it will be quite difficult to implement Section 1 as written for individuals living in multi-generational homes. So you're living with your parents or a child or other family members, or congregate living settings, which can have a number of people in the location where services will be provided. Additionally, there may be other service providers in the home. So home health care may be in the home, DCF may be in the home, DMIS may be in the home with their own workers. And this bill, as written, would require them to also disclose their behavioral health history. For the new proposed language regarding the drug deactivation pouches in SB 1, We provided similar testimony in the Insurance Committee on February 27th, describing our support of the concept and our partnership with Governor's Prevention Partnership, distributing 50,000 of these pouches statewide. But we would like to have further conversations about the proposed funding mechanism and what is allowable under current state law and the settlement decree. Finally, I want to highlight the amazing work that's being done on addressing first episode psychosis, also known as FEP. FEP refers to the first time an individual experienced psychotic symptoms, which may include things like hallucinations, delusions, difficulty thinking, drastic changes in emotional state or behavior. With its creation in 2006 and recent statewide expansion of the STEP program, which stands for Specialized Treatment in Early Psychosis, and a successful Mind Map public education campaign on FEP, Connecticut is a national leader in providing early intervention for these episodes, which are estimated to impact 3 in every 100 people at least once during their lifetime. By spreading awareness about the signs and symptoms and having access to 5 early detection centers as a resource to services, DEMIS, along with our partners at Yale and DCF, hope to significantly improve outcomes. SB1 appears to codify the
Excuse
current.
me, Commissioner, but your time is up. Thank you.
Thank you.
Commissioner, if you could summarize that, that would be
Yes.
great.
So this SB1 seems to codify what we're currently doing, and we would just suggest one minor language change related to not being specific to a hospital site, which is not reflecting current practice. Thank you so much.
Thank you very much, Commissioner. And just want to go first to the question about the drug deactivation bags that we were just talking about, and the opioid settlement limitations or guidelines. Actually, the settlement itself provides pretty clear guidance. So if you could just speak a little bit more specifically to that and the interplay with the opioid settlement advisory committee.
Sure. So legislation already exists that sets up the OSAC, as we call it, Opioid Settlement Advisory Committee. That committee has voted on, created, approved a process for vetting of recommendations that may come forward. Exhibit E, which is part of the settlement itself, explains what is allowable and allowable expenditure under the settlement. And I believe that the bags would actually qualify to be a recommendation, but we'd like to keep intact the process that we already have that vets each recommendation that is put forward.
Thank you, Commissioner. To follow up on that, do you think that the language in the bill precludes the process from occurring?
It sounds like it might, and we're happy to work with you on that language. And I don't think we need to state each and every allowable remediation. This would qualify as harm reduction or prevention. And so it's an eligible expense. It just would need to, and I'm not a voting member, so it would need to go through, as you know, it would need to go through the process so that the voting members can bring it forward and qualify it as something that is a priority.
Thank you. And just to clarify, you are saying that this is something that could be an important tool in our toolbox. It's more a process question for you. Are there questions, Senator Anwar?
Thank you. Thank you, Commissioner, for your testimony and the work that you and your department do. I'll start with the last comment that you made in your testimony about the first episode psychosis. I want to congratulate your department and the work that you're doing, because this is one of the best in the country that we have shown with this model, where the first episode psychosis is associated, if a comprehensive strategy is instituted to manage those episodes, the entire trajectory of those individuals will be changed for the rest of their lives. So this collaboration with Yale and this program is one of a kind in the country. Now, this bill is trying to codify this, and then we will address the language change. But for the record, I just wanted also to say that we're not asking through this bill for new money. The money is already there and it's being used, so it's not going to be, so for the Office of Fiscal Analysis may not get confused and put more questions on it. So if you can clarify that for us, please.
Yes, we believe that as written, it is codifying what we're already doing.
And there's no new money that's being asked from that part of the bill.
Correct.
Okay, this is very helpful. And the hope is that if we can make this part of the state process, and I think that the rest of the country is going to follow some of the things that we are doing, because in our previous bills that we have passed, we have looked at mental health comprehensively, but this part of mental health was quite complex and that was not addressed. And then this is actually continuation of the bills that we passed about 2 years ago. But we are trying to increase our capacity to look at some areas that needed a little bit more attention. So thank you for this part. The first part is something I wanted to clarify further with you. The reason behind the language is that this language is primarily from the prism of protection of healthcare workers. And then that's important to make sure that the healthcare workers, wherever they go, we have to be able to promise them that the state will do everything to take care of our healthcare workers. And then we know from listening to the various healthcare workers, they have been assaulted by not only the patient themselves, but also by the family member. And it's only fair to have a risk assessment. We don't want in-depth data, but somebody to be able to pick up the phone in advance and say, can we ask you these questions? These are questions that we are supposed to be asking by law. And then check mark what are the risks that are there to be able to ask. And then I think it is going to be beyond the capacity of a healthcare facility to do in-depth background checks. That's not the intent of the bill. It is just to be able to get more information so that the person, when they step into the house, they are informed what the risks are. If that was the intent and we change the language, how would you feel?
I think we can certainly work on the language, because I agree that the safety is really important and we want to make sure people know what they're stepping into. It would be just very hard to operationalize as written, and folks have to give their consent to release their psychiatric and substance use history, as you know. So I would also be concerned, depending how in-depth that is. I think a risk assessment is a good idea. If you're requiring medical records or any backup, that could take so long. Or people could say, no, I choose not to release that. The mom, my adult child is in need of care. I don't want my personal health care records released to the nursing agency. And we don't want that person to be denied care either, or have it delayed so long because of the time it takes to collect released information.
Right. I think the intent is to get more information through a phone call or a communication in advance, rather than dig everybody's medical records. However, the person providing care that's relevant to those medical records, that information should be shared, because what we have heard from many of our home health workers, and we are very blessed to have Senator Marks, who actually has been very insightful to share some of her experience and her colleagues' experiences. When it's relevant, it's going to be necessary to have that information rather than going blind. So that part, I think, makes perfect sense if you're taking care of somebody for a specific need. Wouldn't you agree with that?
Yes, as long as folks understand that it would be with the person's permission.
Yes.
That they would have to release them.
And that's part of their healthcare. The other part is the intent is not for the other healthcare workers visiting the site to get background on them, because we recognize, because this body has already passed laws that your workers, DCF workers, have already had the background check. So we recognize that when we are our workers are going to be interacting with the other workers from other groups, they would have already had their background check. So I don't think that was the intent at all. So I want to clarify that.
Okay, so we can work on language
Yeah.
to make sure that's clear.
Thank you. And the third part on the drug deactivation, I look at it as a harm reduction strategy. Would you classify that as a harm reduction too?
Harm reduction, prevention, yes.
Okay, thank you. Thank you so much, Madam.
Thank you very much, Senator Anwar. Yes, harm reduction and prevention. We love those things here in public health. Senator Marks.
Thank you so much for your patience and for your testimony. And I too agree with you. When I read the first part, I immediately thought of HIPAA and that we weren't going to be able to get that kind of in-depth information. But I will say right now, we don't even get that information on the clients that we are going to care for. It happened to me in December. This bill, was already started to be written. It was quite known in Southeastern Connecticut that Senator Marks was, gonna really work hard on home care safety. And I went out and saw a client. It's funny, you get it says try to stay 6 feet from a client. Well, when you have an occlusive dressing that had been on there for 10 days, it was like gorilla glued on, that it took me 25 minutes to get it off of, sitting on the edge of his bed. I don't think everybody really understands the environment that we are in when we're with these patients. And I could tell that this patient was escalating. I could tell that he wanted more medication, and he had been on Suboxone. So, he needed the opioids, but definitely there was some concern there. And then when I was doing the medication reconciliation, which is number one of the things we're supposed to do, he did not have any of his psych meds in the home. When we get his diagnoses, we get diabetes, hypertension, thyroid disorder. Very rarely are there psych diagnoses part of the quick diagnoses that we get when we look in the chart. And I just think that's wrong. And I think we need to know just to be a good nurse. So when I left and I went back to the office to find out what physician I should call in order to get his psych meds called into a pharmacy, I saw that there had been an ED visit just a few months before in which he had been in the ED and he had to be medication restrained. He had bit the security guard, and he had threatened to shoot up everyone in the emergency room and all of the workers that left the home. And I was like, all right, you just sent a sitting senator who is drafting legislation for home care safety into this house. This is happening to me. It is happening to a lot of us. We are just going into homes where we don't know anything. We're going into sober houses and congregate living houses, which I love all my patients. I don't love my patients, but I'm going to take great care of all of my patients. But we need to know that we're going into a congregate living house. We need to yes, there are people here that have been in prison for violent behavior. And so then it's just how we perform that visit is going to be very different than if there's a safety assessment and we don't get any of that information. So I think we have to be really careful when we definitely have to change the language. I agree with you, but that we have to make sure that the employers, I don't want this to be the flavor of the month, and that sounds very insulting, but I do fear that it will become the flavor of the month and that employers will do a really good safety assessment and then just stop doing it when we're not talking about it anymore. So I thank you, and I know that you know the homes we go into and what we do as your workers do too, right? I mean, we're all doing this together, and I don't ever not want anybody to not get the care that they deserve. I just really feel we need to be safer out there.
I really like what you said, Senator Marks, about having some information will help us decide how to deliver the service. And so I just don't want any unintended consequences that folks that may have a history of substance use or mental health, it's assumed that there is some kind of violent behavior or that these folks are excluded from the treatment that they deserve, because those kinds of services are so important for people being able to remain in the community. And I wouldn't want it to be construed as a way to exclude them from services. So
I
thank you.
agree. And you know, I have thought of a really great way, although I'm not getting a lot of excitement from management behind me, but we have a lot of LPNs working for us now. And so I think sending an LPN with the RN to that initial visit where, you know, the RN, you know, you do the visit, it takes an hour to an hour and a half, then you have 3 hours of paperwork to do afterwards. The LPN could start the documentation in the home with you just to have somebody else there. Birth to 3 always goes out with 2 clinicians to their initial visit. I'm not saying it has to happen all the time, but I think that is a way that it would actually save money in that the RN, who's making a lot more than the LPN, is going to have less paperwork to do afterwards. So I do think there's lots of different ways that we can figure out how to have safer care. And if the end result of SB1 is that there are people in our community who are not getting care, I will be very sad, and I will make sure that my next charge will be to make sure that that's not happening.
Thank you.
Thank you, Senator Marks. I think your commitment and the commissioner's commitment are one and the same to assure safe and proper care for all who need it in our state. Representative Clara DeStitria.
Thank you, Madam Chair. Thank you, Commissioner, for being here today. And to go off a little bit of what Senator Marks said, we want to protect our healthcare workers and the general public as much as we can, because it's a public safety issue as well. And I don't think any of us are trying to say that anybody with mental health issues or domestic violence issues is automatically going to be violent. It's just a matter of giving them the heads up. My question, and to the general public, right now, Senator Marks is talking about in the history of the patient, it may say they have a diabetes issue or if they have a thyroid issue. So it's not required for it to say in their history right now if they have any mental health conditions or issues.
Oh, I would defer to Senator Marks to say what is included in your assessment.
So it should be representative, but it's not. And it's really who the chain of command. You're in the hospital for something, and you're in the hospital for, you broke a hip and you weren't in the hospital because of your bipolar or your psychotic episode. So when you come out, it's how they bill. And so they're billing for these medical issues and the psych issues. Let's say you have 15 diagnoses, the psych issues and substance abuse issues weren't billed for while you were in the hospital. So those don't rise to the top. And so you kind of get those top 5 diagnoses. It's all about billing. It's all about billing. So no, they're not part of it unless they were in the hospital for a mental health exacerbation.
Okay. Thank you for being here and thank you for the clarification.
Thank you.
Thank you.
I appreciate the team effort. Commissioner, thank you again for being with us today and again for your patience. We're very grateful for that. Next, we will go to Lynn Repsilber, who I believe is here in person, and my apologies for missing you earlier. I was looking for you online and didn't find you there, so we're very happy to have you here with us in person. Welcome.
Thank you so much. It's certainly better to be here at 1:30 in the afternoon than 1:30 in the morning. Thank you so much for having me. Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Clarice DeStitria, and esteemed members of the Public Health Committee. I am here testifying on House Bill 5488 and primarily on 3 segments of the bill. My name is Dr. Lynn Repsilber, and I am a nurse practitioner. I have been involved in health policy in Connecticut and nationally since 1998. I sat on and facilitated the scope of practice review where 42 entities were around the table. And in 2013, this became Public Act 14-12, allowing APRNs to practice without a written collaborative agreement after physician collaboration, 2,000 hours in 3 years. I am going to address first Section 10 regarding APRNs and fluoroscopy. APRNs have practiced in radiology space, providing quality care, cost-effective care with an emphasis on patient safety. In May of 2013, the Iowa Supreme Court ruled that the supervision of fluoroscopy by licensed providers was within the scope of practice for the advanced registered nurse practitioner. Additionally, training was also recommended, which resulted in decreased radiation exposure to patients. I think the language in this bill will bring APRNs in alignment with our physician colleagues. And I also want to thank them for also supporting us in being added to this bill. My next section was on section 11 regarding facility fees, and I'll allow you to read that at your leisure. But lastly, I wanted to talk about section 20, and I wanted to thank Senator Anwar for the reciprocity he addressed last session. But I do want to say that this subsection here, which talks about collaboration when an APRN comes from another state and they have met the 2,000 hours in 3 years of physician collaboration, that time will be counted towards their licensure. This was to solve the reciprocity issue, but unfortunately it did not do anything to do that, especially the way it's written. For example, an APRN that is from Washington State, they have not had physician collaboration ever. And this would allow them to come to the state, but they would still have to fulfill the 2003 years of collaboration, which they're not required for their state. Furthermore, in an APRN in Massachusetts under APRN collaboration, which is allowed by their state, fails to meet the litmus test for Connecticut. So an APRN that's in Massachusetts that has worked under collaboration with an APRN for 2,000 hours in 3 years could not register here because they have not had physician collaboration. APRNs are independent licensed providers who assess, diagnose, treat, order tests, prescribe medications, and evaluate patients within our scope of practice. In 2014, Public Act 14-12 was passed to allow us to practice without a collaborative agreement after 2,000 hours in 3 years. The 2,000 hours in 3 years was negotiated by Representative Peggy Sayers and the Connecticut State Medical Society and not discussed with the APRNs prior. Now, we were told that this would get fixed in a year or two. APRNs have been unyielding in trying to get this change forward. We've had opportunities, but we're denied forward movement. Over the past several years, APRNs cannot even get a bill raised for discussion. So I'm happy to be here today to talk about this. 10 years have passed since we had full practice authority, and unfortunately we are now last. So we went from hero to zero in 10 years. We do not allow APRNs as an addition to a collaborator, which our sister states of Vermont, Maine, and Massachusetts do. This impedes our ability to attract APRN educators from other states to train the next generation of APRNs by this imposed barrier to practice, especially if they hail from a state that's never required physician collaboration. And we fail to attract much needed APRNs on bordering states who are willing and eager to help us out with primary care and mental health access issues, but are not doing it for the same reasons.
Excuse me, Ms. Rapspeller, your time is up. Thank you.
Thank you.
If you could summarize, that would be wonderful.
Sure. Physician collaborators are also difficult to find. Many physicians are aligned with organizations which forbid them to allow collaboration. And this is impacting our independent practice owners in the state who have great APRNs that they want to hire and they can't for that reason. And I just wanted to bring up the term collaboration because this is a term that has a lot of confusion. There's two forms of collaboration. There is collaboration for the benefit of the patient, which is inherent in practice. That collaboration might be with a nutritionist or a physical therapist or a pharmacist or another specialist, but to whom the provider deems engagement in for the benefit of the patient. So we do not practice in isolation. Then there is collaboration for permission to practice. The collaboration agreement is a contract the APRN must engage with a physician fulfilling a regulatory requirement by the state, giving us permission to practice. And I'll end with that. Thank you.
Thank you very much. We have a few questions. Representative Denning. I think Representative Denning was there with his hand up, but I do not see him now. Any other questions from members of the committee? Representative Cook?
I'll give Representative Denning a time to connect. Lynn, thank you for being here. I'm sorry I missed the beginning of your testimony. We're bouncing between committees. And so I just wanted to give, and I know that your testimony is very thorough in regards to where we are. But I wanted to give you just a brief opportunity to ask you, so in the time of crisis where we are now with healthcare and the lack of coverages that we have and the partnerships that we're trying to build, the hurdles of collaboration for APRNs, I know that hospitals are charging for collaboration, which also puts a burden on APRNs. I would like to dispel the myths on education, collaboration, and time served, if you will, in comparison to other professions, because we know that that's been a pushback across the board.
Yes, thank you for that question. We're nurses first. So we're trained as RNs before we ever go to become an APRN. So all that education and training comes with us. And then we bring that to our APRN education where we have certification that we have to meet. We have standards of care, competencies that we must meet, and also hours of practice that we have to maintain before we can sit for our certification exam. Once we're certified, then we can go into practice.
And then with collaboration, I know that it's been challenging here in the state of Connecticut. And I know that other states do it a little bit differently. Can you explain that to us, please?
So our sister states, and I did put in my testimony, the specific requirements for Vermont, Massachusetts, and Maine. They allow only 24 months of certification or collaboration or 2 years. We're more stringent than that. We have 2,000 hours and 3 years. And APRNs, we're not asking to change that. We're not asking to take physician out of the equation. What we are asking for is to add APRN in because these other states do allow it. And nationally, there's 27 states plus the District of Columbia that have full practice authority.
And because of your national work, could you at all speak to the amount of APRNs, especially on our borders, that we might be losing going to other states because they're much more cooperative with the collaboration than we are?
Yeah, I'm not familiar with the exact totals of APRNs in the other states. I just know that in Connecticut, since we passed full practice authority in 2014, our APRN ranks have doubled. So we're increasing as a workforce and we need to take advantage of that. And reducing any barriers is really going to help us a long way. And there already is a system in place. So if there's any question about who should be an APRN collaborator, through Department of Public Health, we have to attest when we do the 2,000 hours in 3 years so that way we are listed separately on the Department of Public Health's licensing for APRNs. So right now, out of 8,500 APRNs, about 1,400 or a little short of that are listed as practicing without a collaborative agreement.
Which creates?
Yeah, a stress because now we have to find APRNs that are willing or physicians who are willing to collaborate with us. Many of our APRN colleagues are starting practices. A lot of them are niche practices, meeting the needs and service the communities. And this is hard because there's no linkage between them and physicians once the 2,000 hours and 3 years is gone. And then these are the ones that are training the next generation of APRNs to work in these environments, and they can't hire these APRNs to fulfill those roles because it's an additional financial burden to hire a physician to be a collaborator. And then not only that, trying to find somebody that's like-minded. And I know some of my colleagues are actually trying to tap people out of state because there's just such a shortage of trying to find collaborating physicians.
Thank you. And I think it warrants the statement that we're not trying to lessen safety. We're not trying to lessen healthcare. We're trying to ensure that we have enough coverage for all people, and we are raising the bar.
Absolutely. We still, even if you added APRN, we still have higher conditions and higher standards for that collaborative agreement than our surrounding states. So we're not lowering that threshold at all. But we're expanding the opportunity for APRNs to provide the care that we desperately need in this state, especially mental health and primary care.
And we're definitely not talking about lessening the training because I know that that's been an argument around this table as well. And that is not anything that we're discussing either.
No.
Thank you.
That was thoroughly reviewed during the scope of practice review.
And you have gone through the scope of practice.
Yes.
Thank you, Madam Chair. Thank you, Mr. Chairman.
Thank you, Representative Cook. Representative Denning.
Thank you, Madam Chair, and thank you, Representative Cook, for doing wonderful at covering most of the topics that I wanted to cover. Dr. Nurse, I'm glad you could be here. Can you talk to me just a little bit about what you would tell a patient who came to see you when, as the primary care or the person who was their first entry into healthcare instead of a doctor? What would you give them as a reassurance that you are trained and educated to manage them?
That's a great question. Thank you for asking that. When I approach a patient, I always tell them that I am an APRN, a nurse practitioner, that I like to call myself a maxi nurse when I take care of patients because I went to school and got my doctorate. Once I think patients experience a care from a nurse practitioner, they are forever changed because our focus is different. We are not focused on the medical model, which is specifically tailored to taking care of diseases. The nursing model is a holistic approach to healthcare where we look at that whole person. So we may look at, yes, they might have diabetes, but can they afford their medication? Do they have food in their fridge? Who's there to help them to monitor their blood sugar levels? Do they understand how to work their equipment? All those things that we do encompassing our whole person care is really important. And that's, I think, something that nursing brings to the table. That's a different model. And yes, there's overlap between medicine and frankly, some of the doctors are trying to become nurses too by having better patient relationships. So I think we just bring a different lens to the table.
And do you think this helps or hinders our ability to provide care in the state of Connecticut by bringing in more reciprocal agreements as well as advancing nursing practice?
I think the more opportunity we have to reduce the barriers that allow more APRNs to come into the state to provide care is only going to be a benefit to the residents of Connecticut. I know I belong to a CEO and co-founder of the National Nurse Practitioner Entrepreneur Network, and we actually did a survey of those 1,400 APRNs who practice without a collaborative agreement, wanting to really see where they're practicing. And out of the 75 that completed the survey, it was 50-50 between primary care and mental health. So we are a nursing workforce that really is trying to tackle that issue head on. So it really becomes important. And I do think that if we can reduce the barriers for other bordering states, those APRNs will also gravitate to our state to provide mental health care, especially along with primary care.
Thank you very much for your testimony, and thank you, Madam Chair.
Thank you.
Thank you. Madam Chair stepped out, so almost Madam Chair. But she's going to be back in a little bit, I mean. So thank you for your testimony. I see no other questions. So I'm going to ask some of the clarifying questions just to understand. So you referred yourself to as a doctor. Tell me more what you mean by that.
I always say I'm Dr. Lynn Rapsilber, nurse practitioner. That is the statement that I state whenever I see a patient. And they'll ask me, oh, did you go to medical school? I say, no, I'm a maxi nurse, not a junior doctor, a maxi.
Can I just clarify? Have you heard of Mary Midinger?
Yes.
Okay.
Columbia. Yeah.
How well?
I know of her, yes.
And how do you know of her?
She was one of the architects of some of the training for APRNs, and she designed the Doctor of Science program.
And do you know when she had mentioned that she was saddened because of the fact that this has become a diploma giving institution rather than training and education institution? Did you hear her speak about that concern?
I have not heard her speak recently, no.
She published a paper on that. So it's worthy to look at it because that's what was spoken at that time. Speaking of that component, do you know what percentage of the programs, the DNP programs, are administrative and what percent are clinical?
I'm not sure I understand your question.
So they're pathways for the training. And one pathway said it's administrative and the other said it's clinical.
So there's different types of advanced degrees an APRN can get. There is the Doctor of Nursing Practice, which I have, which is a clinical degree and leadership. There is a PhD, which is research driven. There is a Doctor of Science, which is research also, and then a Doctor of Education. And that is more curriculum based and education focused. So
let me clarify that. The DNP part that has been spoken of, 85% is administrative, 85%, and 15% is clinical. And when the program was started, the 15% were examined every year to be able to see if they would be safe in clinical practice. Even after 5 years, the people who had been through the programs, 1/3 passed. Only 1/3 passed. And at that time, the APRN organization said, we're going to take the exam away and we'll make our own exam. And so, I mean, these are facts about the history that it's worthy to know. Now, the collaborative agreement, the program for the training for an APRN, historically, it was when somebody became an RN, they would not be able to become an APRN right away. Now, because there's a pressure, people can actually complete the RN and next day go online to become an APRN or start to become an APRN online. Can you speak to that change?
So all of the programs require clinical practice, clinical hours. So we're not without that. We also bring to the table all of our RN experiences, even on the job. That is counted towards our clinical experience. So we're not coming in not knowing anything into our DMP track.
Let me rephrase my question. Can an RN, without a single day of practice, become and enroll into an APRN program?
No, because as a nurse, they have to work as an RN. Then they can apply to be an APRN.
So right now, the APRN programs on your website do say that you can actually, as soon as you're an RN, you can apply. So you're saying that that's inaccurate.
Most of the nurses that graduate are already working. That's what they do. And then they go on and get their APRN.
And
But
what is the requirement? How long do they have to work before they can apply?
It depends. I mean, there's no standard that says you have to do X amount of hours, but we did actually provide you with a detailed report of our education
So
prior to our work group meeting, which we never had our second meeting.
So requirement that you have, from the looks of it, the APRN, the clinical or the clinical studies that you're saying, it's 500. It was supposed to go to 750 hours. 500 is what it's being used right now. And that is even less than the PAs at this point from the APRN training program. I'm talking about the training program. People can do 30 years of RN work or 10 years or 5 years and they can become APRN, but I'm talking about the training and the education part. So it's important for that it's 500 hours. And when it was asked to be increased to 750, it was not increased yet at university. I think that's part of the challenge that may be worthy to look at. And
I think as far as the education and training, I mean, obviously, we're not going to solve any problems and solutions with that because the training is standardized nationwide. So I think for the purpose of our discussion today and talking about the collaborative agreement, I mean, I think we have to look at what the situation is at the moment. I do have to say, however, with COVID, all of the programs that teach anybody in healthcare and other programs faced traumatic problems with preceptor and clinical sites. So I think we have a subset of providers that are going to be at a disadvantage from their programs because of the effects of COVID. So there may be a window that's going to be the case. But again, we're not lowering the bar for APRN practice in the state of Connecticut by adding APRN. Because we're not changing the 2,000 hours in 3 years. So that is still staying in place, and that is still a standard that's higher than the rest of the other states that allow us to practice.
so if there's no structured program in place, which is unfortunately the case with APRN, so what would happen is that theoretically speaking, that an APRN first an RN becomes an RN. He or she works as an RN and it's their choice. There's no standard to that. It could be 1 day or it could be 5 years. But if let's say it's 1 day, because that you're still allowed to apply, even if it's 1 day of working as an RN, and go online, whether it's online or not, but a lot of programs are online, and you can start to work in your examination or the diploma work, if you will. That's not my word. That's been said by the founder of the program. Or one of the founders of the programs. And as a result of that, that person would have 500 hours of clinical training, clinical experience. And according to the survey that was performed, many of them do not even have access to the medical records. They are in the presence of a patient, but they do not have access to the program, the medical records. Now, with that training, for them to subsequently have a collaborative agreement with a physician who may or may not have one specialty, but let's say primary care, because that's an area. In that primary care, and then after that training in the primary care, the person would be able to work for 3 years in the program. And after those 3 years, they can work independently. But what you're saying is that the person can work in any field under another APRN who has not had a formalized training. And I think that's where the problem is, that we are diluting after diluting after diluting the education. And it's our family and the family of the citizens in our state of Connecticut who are on the other end. And that's why it's worthy to ask the questions, because it's a change in the scope, it's a change in supervision, and as a result, it's worthy for anybody who's concerned as a public health committee about the safety and well-being to be able to ask those questions. And I think that's why it's important. But when your own founders are saying that these are diploma institutions, and their own are saying that the experience is of the 15% who actually were in the clinical part, and 1/3 of them after 5 years failed an exam, and then the exam was completely taken away, we have to start to ask these questions. So I'm sorry I asked these questions, but I wanted to clarify that. But thank you, and I think you have a question. Thank you.
Can I reply to that?
Sure.
I have the form that we sent to you regarding our APRN education and training. As a bachelor's prepared nurse, you get 750 clinical hours. And then each year that the RN works, they get additional 2,000 hours of credit in their work environment towards their education and training. And then when they're in their master's program, they get 750 hours of clinical training. And all of this is preceptorship. And then total is about 4,300 hours for a full-time APRN with 1 year of experience, and 6,500 hours for a APRN student that's doing it part-time. So there is a little bit of difference, but we take into consideration our nursing hours in clinical practice along with our APRN hours in clinical practice. So it's not 750 hours alone.
Let me clarify that and break that down. So what you're saying is, when an RN is working at their job, whatever that job could be, it could be emergency room, it could be ICU, it could be in an office, clinical office, you are saying that even before they have applied for the APRN program, that is being considered as a APRN training?
No, as clinical hours as a nurse, because we have to be nurses before we can be APRNs. And I don't think that that's been taken into consideration in the broadening and expanding of our educational program. That we start as nurses
So
first. and then we-
APRN is a different program.
Right.
And for using the clinical experience from something else that somebody's doing and putting that as an APRN experience, because APRNs are writing prescriptions, right? They're writing prescriptions for opioids and cannabis and
We're trying to do
other
that.
critical treatment. But as a result, what you're saying is that if somebody has been working in a pediatric clinic and then they become an APRN for adults, that pediatric experience is going to be counted for their training of the hours calculated for that adult APRN work?
No,
Okay, you just mentioned that earlier. That's why I wanted to clarify.
no, when they're working, they're getting out clinical hours as part of their job, not credited towards the APRN hours, but it's part of what they're learning as a nurse on the job. That's taken into consideration. The RN or so total number of hours that nurse practitioners get all together with all of their nursing training, not just APRN, is 4,600 or 4,300 hours or 6,500 hours, whether they do it full-time or part-time. But it's not 750 hours or 500 hours.
So the RN hours are being calculated.
Right, because we start with our RN experience. Remember, we're trained in the nursing model, not a medical model.
Right,
Which
but-
is a little different. And we utilize the training that we get from our RN and we build upon that. That's what we do.
Okay, I would not agree fully. Thank you, but thank you for that. Thank you, Madam Chair.
Thank you, Senator Anwar. Senator Gordon to be followed by Senator Marks.
Thank you for testifying today. I'll preface my remarks that I've been a doctor for more than 30 years. I'll get to my question, but I take strong exception to your comment that the nursing model is different from the physician model, that we don't, as doctors, look at patients holistically and build relationships with patients. If you want to spend time in my office, you'll see readily that's not the case. So I think you should be very careful saying that, because I know many doctors would disagree. I value working with nurses, APRNs, physician assistants, but we do very much share a lot of common goals in how we take care of patients as far as how we view our patients and our relationship. And I'm happy to talk offline with you about that comment. But my question to you is, this is a lot of looking at apples and oranges. Wouldn't you agree that the training for a doctor, and you stated that, you know, you're a nurse first, and then you go on to be an APRN, and I respect that pathway. And people who are APRNs have chosen to do that and not go to medical school and be a doctor. But wouldn't you agree that the years that doctors are required to do training, the tens of thousands of hours that go into our training, separate from what happens when we're an attending physician? Just because we get an MD, for me, I had to do 6 extra years after my MD to go to do what I do as a cancer doctor. But wouldn't you agree that, based upon all the different information that's out there, that all of those hours and years of training for a doctor is different than an APRN, is different from a physician assistant, for example?
First of all, I want to apologize if I offended you in any way about talking about your profession. Totally, APRNs respect the role that physicians play. We work collaboratively in our environments, taking care of patients. We always look at who's going to bring the best expertise to the table in making decisions regarding patients. And we also recognize that the APRN scope of practice is not like the physician scope of practice. They're 2 different lanes that we operate in. We're trained a little bit differently, and I'm not taking anything away from physicians. You are an important part of the medical community for sure, but I do think that APRNs have really been able to provide some of the care in mental health and primary care areas within a scope of their practice that has been very beneficial for the residents of Connecticut. And over the last 10 years, we've done a really great job of taking care of the residents. I don't see that there's been any issues that have been brought up regarding that practice arrangement that we've had for the last 10 years.
Well, thank you for the answer. Didn't actually answer the question, but that's okay. What I stated is factual, so I'll leave it at that. And the other question I have, and then I'll be done, Madam Chair, is a physician associate who's doing fluoroscopy now is not doing it under independent practice. Is he or she doing it under the collaboration or supervision of a physician?
I believe that the PAs are under a delegatory agreement for the state of Connecticut.
So
where
they are
APRNs are under a collaborative arrangement.
So they are being supervised, but if APRNs were to be granted this, and I don't see that this went through a scope review, would they then get that additional supervision, which is very helpful to build up knowledge and training, which would be what the physician assistants would be getting beyond whatever their minimum short number of hours and pass a test have to do? Would it just be completely independent for APRNs and none of that type of supervision collaboration? Is that what I'm hearing? Or I just want to make certain I'm clear on that.
So I'm going to defer comments regarding that because one of my colleagues who actually is an APRN in fluoroscopy and radiology will answer that question for you specifically.
Well, thank you. I was asking you since you're testifying here, but that's okay. I'll take that.
I mean,
as
it
is.
is
Thank you.
well, it is well within
Nope,
the
thank,
scope.
thank you for your for the answers that I got to my questions.
Thank you, Senator Gordon. Senator Marks.
Thank you, Chair. Thank you so much for testifying. Sometimes I feel like I want to put the physicians and the APRNs in the same room with the podiatrists and the orthopedic surgeons. That was a joke for the Public Health Committee, folks. I am a daughter of an OBGYN. My daughter is a pediatrician. I am the daughter of my mother was a nurse, and Auntie Helen was a nurse, and I'm a nurse. And I really think we have gotten to the point where we are forgetting it is 2 very different specialties. I could have been a doctor if I so chose. I liked the hands-on nursing part of it. And so I chose to be a nurse. I did not become an APRN, but that also wasn't very popular when I was younger. APRNs are the people that are going to be there I have a daughter with a cleft lip and palate. So there was a nurse who worked with cleft lip and palate kids, grew to love all of so many different parts of having a child with a cleft lip and palate. She became an APRN, and she is who you saw for all of the feeding techniques for the aftercare. She did so many things that the brilliant, brilliant doctors, Dr. Cutting and Dr. Grayson, the best in the world, oral surgeon and plastic surgeon, they would never, nobody would ever compete thinking that either of them were trying to step on each other's toes. They were part of this wonderful team. Now, if there was Pat Chamorro, who was the APRN, she's probably retired now, to have an APRN study with her for 3 years, if she chose to be an APRN that wanted to specialize in pediatric craniofacial problems, absolutely. She doesn't need to train with a physician. She needs to train with an APRN. I have uveitis scleritis. I have the best doctors in the world. I have 2 eye doctors. Like, who needs 2 eye doctors? Then I got glaucoma. They wanted to have me to have 3 eye doctors. I said, no, I'm not having 3 eye doctors. Give me more drops. But there's no APRN that could even come close to what those physicians who are taking care of me can do. But if I had a venous stasis ulcer or a diabetic wound, I can tell you that there's some APRNs at the wound center that have the absolute best outcomes when it comes to wound healing, really changing up the wound care orders every 2 weeks if something isn't working. So I think this isn't really the place for this discussion, as it's not in one of our bills. You guys wanted a platform. I think it's fantastic. I think we need to, like I've already said, I think we should do some field trips to see what some APRNs are doing. I'm being a little preachy here, and it's like I have my mom hat on because I don't like, doctors are very different than nurses. Doctors diagnose and they cure, nurses care. There is a very different, you go to school, it's very different to what happens when you're a nurse and when you're a physician. So I have sat here, I don't have a question for you. I've been very preachy, but I think my biggest thing is I respect all of you so much, and I love all the professions, and we have to figure out a way that we can make everybody happy. And we have to appreciate the APRNs that are out there and really giving so many of our patients care that if we didn't have you, they would never be able to get any care. So I hope I didn't step on anybody's toes. I just really think we need to take a few deep breaths and start meeting together and really try to collaborate and do what's best for the residents of Connecticut, not what's best for all of our egos.
Thank you so much for your kind words.
Thank you, Senator Marks. Representative Cook, to be followed by Senator Gordon.
Thank you. I just had one quick clarifying question. So you had briefly mentioned that we had a study group that we legislated out of this committee, I believe, last legislative session, that was supposed to meet to bring back recommendations for this session. Could you please discuss if that has happened and where we stand with that?
So it was recommended that we'd have an APRN work group, of which Senator Anwar and Representative Vahey convened. We had one meeting in September. It was attended by the Hospital Association, the Medical Society, CTAPRNs, the veterans, independent practice owners, and the VA. So there was great representation. We also had educators too from UConn and Fairfield that were part of the committee. We only had one meeting, so we didn't allow us to really discuss a lot about what the intent of the committee was to discuss adding APRN as collaborator. What it turned out to be is a discussion on our education and training, which we wanted to move to a further discussion at another meeting, which we never had another date set. So we're welcome to have the opportunity to continue those work groups if they're going to be beneficial to move legislation or this whole topic forward.
And you just said that you, for clarification, you said that you all went through the scope review.
Yes.
What was the outcome of that?
So in 2013, we did a scope of practice review. It is available through the DPH website. People can download all the information. We submitted over 100 studies that prove that we were safe, cost-effective healthcare providers. Everything was looked at in the scope review, from economic, previous legislation, education, impact to other professions, et cetera. It was voted out favorably by the Department of Public Health. We had hearings, and it finally resulted in passage of Public Act 14-12, which we know today to allow APRNs to have full practice authority after 2,000 hours and 3 years.
So why are we here?
We just want 4 letters added to this legislation, APRN. It's going to solve a lot of the problems that we're having today with access to care issues, finding collaborative physicians, being in alignment with other states, allowing our educational institutions to attract the best talent from out of state, and allow border states for those APRNs to come in and be a workforce in the state.
Thank you. And I'm going to take words out of your mouth, Senator, not to be preachy, but I believe that we have a responsibility for all residents of the state of Connecticut. And if we've already gone through the scope review, we know what we need to do, and we know that they've already been signed off on. I don't understand why we have a turf war. And I feel that that's really where we are, and this is a turf war. So, Madam Chair, as we move forward during this legislative process, I would really hope that we take our personal feelings aside and we really look at what the facts are in front of us. As we've heard from the Attorney General and a variety of other folks about certificate of need and scope of practice, that we really need to follow what we've already passed, and that was done 11 years ago. So thank you, Madam Chairman, and thank you.
Thank you. Just one point of clarification. There was no legislation for the working group last
Okay.
year. It was an agreement by the chairs. We did only have one meeting. I have actually discussed that before this committee previously during this session. And we certainly hope to remain in conversation on many different issues. So yes, we did not continue the conversation. We will, at what point exactly, I don't know when, but we certainly will be. Senator Gordon, for the second time.
Very, very quick, Madam Chairwoman. I just wanted to make a comment. I hope that my colleague, Senator Marks, was not at all implying that when she said about doctors treating or diagnosing and treating and nurses caring, that she didn't mean that doctors don't care. As I stated publicly, all of us care about patients, and we need to be careful of the words that are used. Thank you.
Thank you, Senator. I'm just going to hit pause. Of course, everyone cares for patients. I think the clarification, or I will not speak for the senator, but this is a very difficult issue, and it has continued to be a difficult issue around this circle and in other conversations. And it's a tricky dance. Care teams are an amazing thing. And those of us who are neither doctors nor nurses rely on all of you. And we know that you are all caring for us, and we know that you all have different and varied roles. We do have one clarification, one short clarification question from a good co-chair, Senator Anwar, about the scope. Thank you, Senator.
Thank you. It brings us back to the scope conversation. It's not a question, it's a statement and clarification. So because of the scope conversation, to give you an example, the orthopedic surgeons and the podiatrist had a scope 2006. And they have to have a scope every time there's an ask for a different scope. You have to have a scope review. It's not a blanket blank check once given. And I think so that's where I'm sorry Representative Cook is not here to listen to this, but perhaps she may later. When there was a scope review that was in 2013 that was happening. So it wasn't a blank check for a scope review for eternity. That's why it's important to know that whenever somebody asks for a new scope, there should be a scope review, and that's what the law says. And that's what may need to be considered with the DPH. So it's not like a scope review that was done once should be claimed as a scope review has been done already. So that's more for clarification. Thank you for your testimony.
Thank you, Senator. Thank you very much for your time and your dedication to your work and to being here with us to continue this conversation. We
Thank you.
appreciate
I
it.
look forward to continued dialogue regarding this issue. Thank you.
Thank you. And next, I am not sure if Senator Martin's in the room, and if he is not, we will come back. I know he was here. Oh, he's right here, right there in front of us. Senator Martin, I will acknowledge that we have other committees who are meeting and voting on amendments, and Senator Martin has been very adeptly juggling those commitments. And so we welcome you here today, Senator.
I got a great workout, so I think I'm all done running upstairs. So thank you, Madam Chair, Chairman Anwar and Chairwoman McCarthy Vahey, and the ranking members, Summers and Clara Desditra, the entire Health Committee as well. I want to thank you, the entire Leadership Committee of the Health Committee, in allowing to use SB1 as in order for us to testify on two proposed bills that were overlooked in screening. A few months ago, Kurt Barowitz, to my left here of Bristol Hospital, shared with me how Bristol Hospital was losing healthcare workforce to Yukon Health and its financial impact to Bristol Hospital specifically. Training these healthcare workers cost Bristol Hospital alone upwards of millions of dollars. To then have these workers leave for the Yukon system, which then does not need to invest in training these personnel, but puts Bristol Hospital and other small hospitals at a severe disadvantage. I do applaud Yukon in serving the residents of the state, but the unique structure of Yukon Health makes it almost impossible for other systems to compete. It's clear that an unlevel playing field exists where our small hospitals simply cannot offer the benefits that a state-owned hospital can. Because Bristol Hospitals is an important institution for the Bristol area, I must look at every option to protect the asset of the Bristol community. So I'd like to turn this over to a good friend, Kurt Barowitz.
Thank you. Thank you very much for this. I appreciate it. It is quite extraordinary the amount of time it takes for a new graduate to actually assimilate into and be trained into a ICU, into a labor and delivery area, or into the OR. It's as much as a year. And I'm aware that the police department has a similar provision where if you take a police officer because of the extensive costs and training, one municipality has to pay 50% of the cost to the other. So I think there is some precedent here in Connecticut. So that, that has been very problematic for us, as Senator Martin has said. And it's quite a strain, and it's really, there's a tremendous amount of costs associated with the professional development teams, et cetera, that go into this. Can I speak about the other legislation too? So the other thing that I put in, submitted for testimony on Saturday, that Senator Martin originally tried to get into screening, has to do with having hospitals and healthcare individuals in our state actually bill for prior authorization at zero charge. And the rationale behind that is that we don't really have a good sense or understanding of the costs associated with, the burden associated with prior authorization. And by simply using our finance systems to bill for prior authorizations at zero charge, we would be able to then cost that cost out. There's a tremendous burden placed on physician practices, and aside from the moral injury they have of having to struggle to get the patients the prior authorizations they need for the tests and procedures that doctors want them to have. This would enable us to have an accurate way of collecting how many times does it actually happen. And again, it's a zero charge. So the bill basically covers all those physician practices that have reporting responsibilities. It also asks for the Office of Healthcare Strategy to actually start providing reports. But the most important thing as a prior accountant and cost accountant for hospitals, I can tell you that once I have data in my billing system, so I know how many times I did it, I can now apply my cost accounting system and actually generate a legitimate cost. So if you can imagine every hospital in the state of Connecticut doing that, or every healthcare provider being able to actually cost out what this burden is, this burden that's really driving up costs of healthcare in our state. And it's not a cost that's being driven and costing, the insurance companies any money, or the people they're paying, because the vast majority of it is coming from Medicare, and Medicare is paying those premiums. So it's a shift of the burden onto the physician practices, the independent practices, which is part of the reason why we have consolidation of these practices, and hospitals and systems, I have 65, 70 people that are just processing these things. So all I'm asking for simply is that we start to track it. It doesn't matter what accounting system or financial system or clinical system you have. If you have Epic, you have Meditech, you have Cerner, it's easy to put in a zero cost charge and start to track this stuff. So thank you.
Thank you, Senator Martin. And Mr. Barbas, just for the record, if you could kindly identify yourself. I know Senator Martin introduced you, but that would be wonderful.
Thank you. I'm sorry. I apologize. I am Kurt Barwis. I'm the president and CEO of Bristol Health.
Thank you very much. And just to clarify, the hope or the idea would be to add on to the revisions, various revisions bill 5488 with that first ask that I do just want to clarify in terms of the workforce and training, what that, a little more specificity on the ask for that is.
So it would be great to move right to what we have for police officers, but I think really this is more of a study thing to see how it impacts. Because if one, as Senator Martin said, if one organization has extensive benefits in a region where you have significant significant number of players, it actually drives up the cost of healthcare because everyone has to compete with those benefits in some way, shape, or form. So I think some kind of a study to the impact of those benefits and the impact on the market itself, and potentially a work group to really come around and how do we solve this problem, especially with the shortage that we have.
Thank you. We certainly had much conversation earlier today about the marketplace and its role in healthcare. Are there any other questions? Senator Anwar.
Thank you so much for your testimony. Thank you, Senator Martin. Thank you, Mr. Barbas, for the work that you do at Bristol Hospital. Again, there was a conversation on the CON process as well, and how that process has made it very difficult for healthcare systems to be able to expand. Do you want to touch on that topic too while you're here?
Senator Anwar, wow. So we haven't really gone through a CON process for me to really officially comment on it, but I do think that when I process the environment that we're in right now and how difficult it is to survive, I would hope that when and if my organization were to come to the conclusion that it made more sense to be a part of a larger system, for all the right reasons, that process would be seamless and not too burdensome, and actually help us get to the place where we can sustain the healthcare in our community and sustain our mission.
Thank you. And the other question I wanted to ask you was, you have part of Bristol Healthcare. Do you have your own home health agency as well, linked with?
Yes, we do, sir.
And I know Bristol Hospital is special because of your leadership, that you're able to be much more focused on the well-being of all your workforce as well, like everybody is trying to do. But because it's not decentralized, it's very central. You're privy to getting access to the information from your workforce directly. What have you heard, and what are the things that are in place for protection of the home health workers within your system?
Senator Anwar, it's safety and security and the well-being of people in the hospital and the visitors is first and foremost on my mind. I serve on a national committee for the American Hospital Association. I'm actually on the board of the American Hospital Association. This is a conversation that happens every day. When I talk to, and I had a town hall meeting with my home care workers, I mean, they go through a pretty significant process of understanding the homes that they're going into. And there's a support system in place so that if there's any concern whatsoever, they don't go. If there's any feeling when they get to a home that something is not right, they leave. And that's the support structure that's there, and they're supported in that. So I know that in this bill, I haven't really read all of it, but they do have a remote system for their patient medical records. And I would say there's always opportunity for improvement in the safety of healthcare providers around us.
So you're already creating transparency that the healthcare workers know the home that they're getting into, the health issues, but also other risks as much as possible. And you're also tracking the safety, and if the person feels that they're uncomfortable, they're supported for not being able to visit, or at least finds enough support to be able to visit those sites.
That is correct, Senator Elmore.
This is very helpful because I think that's part of what we are working towards, and because not everyone is doing that. Thank you. Thank you, Madam Chair.
Thank you, Mr. Chair. Senator Marks.
Hi, thanks. Good to see you again this year, testifying. So if, put on my glasses. If, home care worker feels unsafe, you say then they don't go, but then does the client receive care?
So there would have to be a discussion about the why and what alternative approach there is for that person to receive their care.
Do you use escorts?
We do not use escorts.
Have you ever thought about using escorts?
We have that conversation, but of course, as you're very well aware, the reimbursement doesn't support those costs. And so really the alternative for us is to really try to reinforce if there's anything that feels wrong, don't go.
But then the patient doesn't get the care. So I know there's a cost to escorts. And so people will hear me say this many times today. It is the cost of doing business, and it is the cost of keeping your healthcare workers safe. In the hospital, you have to buy full PPE, or you have to, one thing, plugging in all the equipment, at one point you probably took all of the electrical sockets from the floor and put everything so that we're not all bending over and ripping out our backs when we plug in stuff, right? Well, in the home, you're ripping out your back all the time. So when that happened, you didn't have to get a grant to have to move all of the electrical sockets up because you were going to save money on workers' comp. So that was a good thing. So I will just say, and I'll say it many, many times, that keeping your home care force safe is the cost of doing business, and that every patient should receive home care. You might have to start with a contract, you might have to send 2 people out, but I think at the end, it shouldn't be too hard to be able to do both. Thanks.
Thank you, Senator Marks.
Thank you, Senator Marks. Senator Gordon.
Thank you, Madam Chairwoman. I'll be very, very brief. Senator Martin, Mr. Barros, it's good to see you.
Yeah.
A quick question about what you initially started with your testimony relative to training people and then they're going elsewhere.
Yes.
Do you see that as a problem that's just continued and not gotten better? Or do you see that as a problem that's actually getting worse, meaning it's becoming more of just not a personnel drain on your hospital system being able to provide the care, but also a financial strain as well, given the commitment that you make to help with the training?
Yeah, I mean, that's a great question. Thank you. Yeah, absolutely. Certainly. We're coming up on a new cohort of new graduates, right? And we are a magnet hospital for nursing, which only 7% of the hospitals in the world have that designation. We do very well in attracting new graduates, but the time to actually get out on the floor and be productive, and every person is unique. Every new nurse is unique in that, their comfort level is tested. They start maybe with 1 patient when they're at a certain point, and then they get 2 or 3. It is a significant challenge to do it the way we do it, which I think is very, very much engaged with the individual, so that they have to be really ready to be out there. They work on one shift, they may go to the night shift where the support structures aren't the same. And to your question, do I see it getting worse? I think overall, I think that the shortage has started to somewhat moderate. We don't see as many agency people on our floors anymore. But there's ebbs and flows, and every recruitment cycle brings a new dad for us. So I'm not sure I answered your question 100%, but I tried. So.
Thank you very much. Thank you, and appreciate the patience with the juggling today.
Thank you.
And for for you also, Senator Martin. Seeing and hearing no other questions, we will go next. Thank you for being with us. We will go next to Samantha Potch or Pack. I'm not sure if you will let me know when you come forward. To be followed by Representative Foster. Welcome.
Hi, it's Samantha Paw. Good afternoon. My name is Samantha Paw and I'm from Haddam. I represent the Youth Advisory Board for the Governor's Prevention Partnership. And I also work with Youth and Family Services of Haddam-Killingworth as a youth peer advocate. I'll be speaking on behalf of SB 1, Section 26, that is in regard to drug deactivation pouches. I know what it feels like to lose a family member to drug abuse and misuse. Addiction is not a joke, as most of us know, and one opioid prescription can change the rest of your life if not handled correctly. Having opioids available in your home, even if you're not using them, gives every single person that walks into your home access to them. And according to addictionhelp.com, in 2017, 1.7 million people in the United States were misusing prescription opioids. And they also said that 25% of patients prescribed prescription opioids for chronic pain misuse them, and 8 to 12% in the same group develop a disorder, an opioid use disorder. And then they go on to say that 72% of opioids are left after surgeries for people to become addicted to. Giving out drug deactivation pouches with prescriptions of opioids eliminates the availability to so many people to be able to misuse them. And being able to get rid of a drug after you use it can also help cut addiction. I've seen so many people struggle with addiction throughout my 17 years of life, which is not even a quarter of the way. And people have left us because they were in the hands of them when they shouldn't have been able to get them. While it may seem small and unimportant in this big bill, it has the ability to change so many people's lives. And please consider enacting this section of the bill so we can help the future prevention.
Samantha, thank you so much, not just for being here, but for being involved as a youth advocate and being a partner with the others who are doing this work. Your voice is so, so critical as we work to prevent this. And I loved what you said that it's upsetting, but it was very powerful. One opioid prescription can change your life if not handled correctly. Those are very powerful words. So we're really grateful for you being here today with us. Seeing and hearing no questions, thank you. We will go next to Representative Jamie Foster. Welcome back to Public Health, Rep. Foster. It's great to have you here.
Oh, it's such a pleasure to be back. Hello to the distinguished members, small but mighty, of the Public Health Committee, Chairs Anwar and McCarthy-Vahey, Ranking Members Clary DeStitria and Summers, Vice Chairs Kushner, Marks, and Parker. I want to first thank Speaker Ritter for the opportunity to lead this bill in collaboration with Rep. Kennedy. I'm testifying today in strong support of House Bill 5003, an act concerning child and family nutrition. This bill, amongst its namesake goal of improving child and family nutrition outcomes, is really at its core an effort to increase critical wellness promoting and life-saving holistic public health intervention. The core focus of this bill is to promote, streamline, and decrease barriers to WIC enrollment. WIC, which is also known as the Special Supplemental Nutrition Assistance Program for Women, Infants, and Children, is a time-tested, evidence-based intervention to promote health and well-being of pregnant mothers and young children. WIC serves as an important early intervention for nutrition, but in fact is so much more.
WIC serves as an important early intervention point for pregnant mothers to get access to not only the food and breastfeeding support that might support a healthy pregnancy and early life of their child, but also promotes access to social determinants of health interventions. WIC is, in every sense of the word, an important safety net program. It promotes participating moms and their children access to critical food that promotes food security. It prevents nutrition-related chronic disease and deficiencies and promotes healthy birth outcomes. Pregnant moms who participate in WIC are more likely to maintain long, healthy pregnancies and avoid preterm birth. They give babies who participate a better chance of achieving healthy weights, and in fact, WIC participation improves infant survival. In the true spirit of being an evidence-based intervention program, WIC food packages have been modified over time to promote the state of the science best nutrition interventions to address common nutrient-related deficiencies that result in poor child outcomes. And of course, aligned with the state of the evidence is not just food. It also includes nutrition education, breastfeeding support, and referrals to address any other social determinants of health issues. Children who participate in WIC have higher mean intakes of iron, vitamin C, thiamine, niacin, and vitamin B6, and yet no overall increase in calorie intake. That demonstrates that these children have improved nutrient density in the diets that they're consuming. The CDC has in part attributed a national decline in anemia, iron deficiency related anemia, from 7.8% in the 70s to less than 3% in the mid 80s to WIC participation. Moreover, when you compare children who are eligible for WIC but not participating to those participating, those who do not participate in WIC have worse outcomes, which again, not to overstate, includes a statistically significant difference in infant mortality. WIC improves breastfeeding outcomes. It increased dental caries, the most common infectious disease in children in America, and improves access to routine health care and even improves access to vaccinations. For 40 years, WIC has been improving the nutritional health and well-being of our nation's most at-risk children. However, Connecticut's enrollment rates are staggeringly low. They leave much to be desired.
Excuse me, Representative Foster, your time is up. Thank you.
Thank you, Representative. If you could summarize, that would be wonderful.
Sure. While national WIC enrollment rates are low, CT is amongst the lowest, with only 46% of eligible children participating. WIC is federally funded through the Farm Grant, and those grants are provided to each state. And although I would be motivated to increase WIC participation for its beneficial health effects alone, every dollar spent on WIC results in a $4.21 savings to Medicaid. Therefore, this bill is a prudent public health intervention and prudent fiscal choice. This bill aims to increase enrollment in this program as an evidence-based approach to improve child outcomes and reduce infant mortality.
Thank you so much, Representative Foster. Thank you for your good work on a bipartisan basis, and thank you to the speaker for prioritizing this very, very critical and life-saving measure. I think, again, was struck by what you said, that WIC participation increases infant survival. That's a really powerful statement. Question for you, outside of the legislature, what your background and work is, if you don't mind sharing that with folks, because I do think as a citizen legislature, one of the gifts that we have is bringing that experience. We've heard from Senator Marks today, for example, with our home health care and safety in the homes for our nurses and other providers. But if you could just share that with folks so that people understand from your perspective how important this work is.
Sure. So I'm a research scientist in my day job at the Yale Griffin Prevention Research Center, where my focus and expertise is on fruit and veg prescription programs. And WIC is actually the first most, strong body of evidence for food prescriptions. And I got my PhD a while ago now. And my expertise has always been in anti-hunger work. But in the last decade, anyone who does anti-hunger research has really transformed the way we practice anti-hunger to do two things. So one, not just address empty bellies with calories, but really focus on improving nutrition and diet quality, but also do things that promote a sense of autonomy and choice and dignity amongst the people who participate in their programs. And WIC, like SNAP, its sister program, they really do that because they allow families to make the choices that best suit themselves with flexibility within the program. WIC is more prescriptive than the SNAP program is, but families still shop at their preferred grocery store so long as they accept WIC, and there are flexibility in foods that they can choose within the food package. And again, that package is promoting health and well-being. And as someone who's worked in the anti-hunger space for my whole career, I know that a lot of times people say, like, we need to get more food donations into food banks and food pantries. And I think all of that work is important and has a lot of merit. But the reality is, for the vast majority of people who live facing hunger and food insecurity, having choice and autonomy to make choices at the grocery store is one of the things that they want, but they also really want access to healthy food. And knowing the foods that promote health and wellness for their children is critically important for every parent.
Thank you for that answer. And I think that's another reason why the aspect of the bill that looks at education for farmers markets as well, to encourage folks who are providing farmers markets and holding farmers markets to be able to allow people to access their benefits there. Thank you for that. And again, for all your good work together with Rep. Kennedy and others on this bill. We appreciate it. Senator Anwar.
Thank you, Madam Chair. Thank you so much for your testimony, and thank you for this bill. It's a very well thought out bill, and it's going to make our children healthy and women healthy as well. And then this is something that's you've been talking about it since the first time I've met you about having a prescription for nutrition and having a mechanism to be able to address this. Could you speak about the connection with the local farmers and how the nutrition, all of this is connected together, local in the community? If you can speak to that, that is in the bill.
Sure. Well, one of the things that we're asking to happen through this bill is collaboration amongst all of the agencies that do promote nutrition and food access. And one often forgotten component of that is the Farmers Market Nutrition Program and Farmers Market WIC matching. The farmers market also has senior farmers market vouchers that promote access to food. And so our farmers markets have local, healthy foods that are available seasonally, and Connecticut farmers markets are really like top notch, best opportunity to get out there. I'm very partial. I believe I represent the best farmers market in the state with Ellington Farmers Market. But I think that when folks participate in programs like this, sometimes there is a sense that you're going to get lesser quality things. And the farmers market shopping experience for some folks might be out of reach or out of touch. And so ensuring that anyone who participates in WIC has the best opportunity to find a WIC eligible farmers market accessible to them is really, I think, an important way that we can promote access to healthy food. But it also is really good for the farm economy because it's just driving dollars that can be spent. We know that when there's proposed restrictions to WIC food purchases or SNAP food purchases, that the food industries that get affected get up in arms very fast. And that's not because they might argue that soda, for example, if you restricted soda access, is something that has a negative or affects the health and well-being of the people who are participating. It's because it's a huge profit driver for their industry. And so farmers might not have access to a market segment that this significantly expands their reach and the ability that for them to find customers that they might not have had otherwise.
And I agree with you about Ellington because you represent both the towns together. One of the things that I've observed, and you can correct me, is that you sort of created this model in Ellington, and then you have a proof of concept, and now you're trying to see if we can get this in the entire state and then help the local farmers, but also the nutrition of the children, women and children and infants. Is that my understanding is accurate?
So Ellington Farmers Market is one of many farmers markets that doubles SNAP and accepts WIC vouchers. Not every farmers market in the state does, though. And so making sure that those that need additional resources to accept that, that would be something that this could look at. One of the components of this bill that I'm really excited about is that we're going to require a presentation of the agencies to this committee in the future. And if you're familiar with the LIHEAP meeting, which is also a similar grant to the state to administer, they present a plan to the committees of cognizance every year. And that gives the opportunity for us as legislators to hear what's working and plans to make improvements. And I think that's a good opportunity for us to consider how we might make further investments and support the programs that are happening. And I think in general, our farmers markets are a really good way to expand access to food by a total amount of like produce sold, for example. They're not going to really move the needle on hunger, but they really do change the experience of people who are shopping with the farmers market programs. And actually the first place that farmers market nutrition program piloted fruit and veg prescription programs, which is the area of research I did now, they found really positive impacts where people were happy. They felt more food secure when they were getting fruits and veggies through the farmers market nutrition programs. But we have emerging evidence that shows that you could reduce diabetes incidence through doubling the amount of produce that someone gets through a farmers market, and you might be able to improve cardiovascular disease outcomes. WIC on its own does that, but finding ways for people to leverage multiple different resources to get the most bang for their buck, which is what this bill is aiming to do, is a really good way for us to be good fiduciaries of taxpayer dollars, but it also makes sure that the outcomes for the people who are participating in the programs are as best as they can be.
And our state has a challenge where the lifespan is very different depending on where you're born and where you live in the state. And part of that is the air that you breathe and the food that you eat. So this is going to be able to look at the food component to some degree, and in some select possible areas, do you foresee that this would be a stepping stone to have perhaps Medicaid cover healthy nutrition for the ones who are nutritionally deficient, rather than giving them medications, we give them real good food, local?
Goodness gracious, do I hope that's the case. I would love to see fruit and veg prescription programs be funded through Medicaid, or really funded through any model, because I think the ROI is really strong. But what I will say about improving access to fruits and vegetables in lifetime, we have a good amount of evidence that it improves health outcomes, but the equity promotion, does it not just improve everyone's outcomes, like rising tides raise all ships? Does it differentially offer benefits to folks who might be differentially facing adverse health outcomes? That evidence is still emerging. And I have colleagues who are really working hard on trying to ensure that we find the best way to operationalize fruit and veg prescription programs to promote health equity. But my hypothesis is that it would be able to do that. Nothing in this bill is a research study for us to evaluate that, but there are some really interesting mechanisms to answer that research question. If we are able to significantly improve enrollment in WIC, there are a couple of different longitudinal data sets that would allow an eager researcher to do a cross-sectional analysis and see if this programmatic or policy change was associated or correlated with any positive changes down the road. But what I shared about the CDC hypothesizing that the WIC program significantly reduced rates of anemia, that is because those longitudinal data sets that monitor food insecurity and data sets like the Nutritional Health and Examination Survey, NHANES, or the Behavioral Risk Surveillance Survey, sometimes called BRFIS, those surveys, those nationally representative data sets help us monitor how policy changes impact health outcomes. And so that is a research question you might not be able to find a causal answer to, but you could certainly start to identify if there was a trend.
Thank you so much for the work, and thank you for your testimony. Madam Chair, back to you.
Thank you, Senator Anwar, for those questions, and very appreciative of the answers and all of this work. And I know there are others in the room who've been doing good work on this, and we appreciate all those behind the scenes as well. This is such an important bill. So thank you for taking the time to be here with us today. We miss you on public health, but we're glad you're back here today.
Thank you so much. Have a good day, everyone.
Thank you, Rep. Foster. Next online, we have Kim Sandor, to be followed, I believe, by Peter Hadler. I don't think Senator Fazio is doing the same transportation juggle that some of us are. Kim, welcome.
Thank you, and good afternoon, Senator Anwar, Representative McCarthy Vahey, Senator Kushner, Senator Marks, Representative Parker, Senator Summers, Representative Claire Dietra, and the members of the Public Health Committee. Thank you for the opportunity to provide testimony in support of Senate Bill 1, an act concerning the health and safety of Connecticut residents, 369 healthcare worker safety, and HB 5488 revisions of the public health statutes. My name is Kimberly Sandor. I am a nurse, a family nurse practitioner, and the executive director of the Connecticut Nurses Association. We really truly appreciate the Connecticut General Assembly's attention and focus on addressing healthcare violence. It's just wonderful to see it popping up in so many places. And the tragedies of this past year with our home care nurse, Joyce Grayson, and Otekili Moore-Rulan should never happen again. As nurses, we all feel connected to them. We've all had the fear and uncertainty at times providing care. And it's our hope that these bills will create safer environments for healthcare provider to provide their services, and will normalize asking for an escort, asking for assistance when they have that little feeling of a caution or something happens, that there's a red flag, or wonderfully having that information ahead of time so that they can plan. This really prioritizes a culture of safety, and we need it in all healthcare settings. We strongly believe workplace violence and safety is key to our nursing workforce retention and the systems that we are creating, accept more and more interventions and mitigation pathways to keep nurses safe. We appreciate the work of your committee last year to address this, and we look forward to continuing to address strategies in all healthcare settings to ensure safe environments, whether home care, a public health nurse going into a home, long-term care, or acute care nurses. In regards to this bill, I have a couple comments. I'm going to make them general and they kind of apply to all of them. The first is section 1, and I appreciate the comments already to work on this section to really think about how to collect the information and when and where. Most home care is made through a referral, so information is being collected along the way. But we talked a lot last fall about the need for interagency communications, correction, legal, social services, etc. So I hope as you reflect on how you might change and improve this, we also think about that really big other picture. When we're discharging people from a hospital into a home, it's like discharging them into a long-term care or some other place. You need to kind of really understand everything that's going on there. And there's a lot of work that goes into discharge planning. So we very much believe it can be done. But we also believe that balance has to be achieved between receiving care and being safe, and ensure that anything we do goes under rigorous review to ensure we do not create bias and systemic and structural racism for any challenges to accessing care. The Home Care Worker Safety Group, we just respectfully request you add specificity for the inclusion of direct providers and not just employees. They really need to be the people doing the work. They need to be part of that group and talking about what happens on the job and what needs to be done. The injury reports and data collection, we just are really advocating for consistency across settings. We shouldn't have one system in the hospital and another system somewhere else. There's words being used, whether it's abuse, is it violence, what is it? We should have one term, one set of things in all of our laws that pertain to this, so that there's consistency. We need good quality, reliable data that we can use to let us know whether our strategies are working or not.
Excuse me, Ms. Sandor, your time is up.
Okay,
Thank you.
I tried to talk fast.
Thank you, Kim. Thank you for those specific thoughts and ideas, even as you're saying they're general, but we appreciate the input, and we know that you're committed to helping to make this bill, or these bills, I should say, as strong as possible. Senator Marks.
Hi, Kim, it's good to see you. So I actually have a little bit of a problem with how it says home care agency or home health agency. I think with that, we're kind of missing out on the homemaker and companion agency. So I'm just curious what you think about that. I'd love to know what you think about a flag in the chart. I'm obviously thinking, I know Epic and I know Cerner. But I think to have a flag in the charts for all healthcare professionals, if somebody has been violent towards healthcare professionals. I'd love to know what you think about that. I'd love to know what you think about actual individualized training for the home care staff. Right now, our training that we get to de-escalate is all takes place in ambulatory care settings. You know, it's the videos that you watch, and it's good. I always get something from when I watch it, but we really need training that is just for home care nurses. And I do love what you said about the reporting. I still don't know how I'm supposed to report at work if there has been a abusive or aggressive patient or family member. And I know in aging, in their 5001, it talks about giving training on what is abuse, because different generations, different cultures, different genders might think some abuse it's okay to take, while others think it isn't. So I think on actually having training to actually define what is abuse, and for the home care workers to understand that verbal abuse, patient after patient after patient, can be a microaggression that can really increase trauma and really increase the stress with work. So I love what you're saying about the consistency, and we certainly don't have that now. So just if you could just expand a little bit. I said a lot, but if you could just expand a little bit, I would very much appreciate it.
So thank you for those questions. I tried to jot them down, so hopefully I can hit them. As far as who should be in this, I really defer to Tracy Wodash and you that have the expertise in this area. I really love the idea of our laws hitting everybody. And I mean, I had public health nurses. I know one of them submitted testimony that they go into homes all the time, like they don't see themselves reflected in this at all. So I think adding what needs to be in there, let's add it. I don't think there's anything wrong with that. As far as flagging the chart, our concerns about flagging are more about revisiting those flags and understanding the flags. Patients, the healthcare system's hard, right? I mean, I don't think there's much that's easy about it. We have people that wait for hours and hours on end in the worst versions of themselves, scared and sick. They might not be the happiest, most pleasant person, and not to excuse, poor behavior, but there's so many things that need to be unpacked to understand what's contributing to this behavior. It's more than just the individual. And so while I appreciate the flags and putting things in there, I think it can't be done without some system for reevaluation, a constant kind of reevaluation and check-in, because I think in different environments and different systems, when people feel like things are being done to them, they don't have a say in things, all that stuff contributes to, the way, and I know you know this, but the way patients are feeling. So I think that if there is something like that, I know it's a little tricky because of, what system are people using and things like that. But there should be, regardless of how, some sort of a mechanism to share. I mean, if home care is a referral, where is it coming from? What do we know? How can we share what we know across the system? Training, I think, is super critical. And I don't mean just, do another health stream and check it off the list. We're talking practice with the people that are going to be helping you, practice with the escorts, practice with the local police, practice with your colleagues. How's that going to go? Role play, really do it. And if the curriculums that are being provided, we should really have the flexibility to individualize them for your community, your types of patients, and to make them real, so that the goal isn't to just do training and check it off a list. The goal is that the providers know what to do. They know what to sense, they know what to look at risk assessments, and they know what to do in a situation to mitigate the problem, to de-escalate the problem. And if it's not getting there, have a way to be able to provide care and get other people in there. So, I mean, I think we all need to keep the goal in mind and think about how can we continue to achieve those goals. And I love your comment about the bill in aging, because I think they use the word harassment there. And I just keep reading this stuff. And I actually went back to look at the workplace violence stuff that we did last year, where it clearly says violence. And you know, our healthcare providers, our nurses might have their ponytail pulled, right? They might get pulled and yanked backwards. Someone might grab their arm rough and pull them back to get their attention because they're mad or they're angry. And, you know, that might not rise to the occasion of the policy or procedure or practice in that institution to be something that actually ends up getting reported to the Department of Public Health. So, and I don't think every healthcare provider understands what's getting reported, what's not getting reported, how is that defined, what are those types of actions. And I just really advocate for transparency in it all, because when people don't understand why their concerns are being heard and they're told, well, there's nothing we can do about it, but next time don't do this, like they did something wrong, that's contributing to workforce burnout. That's contributing to people leaving the field, because it begins to feel like it's all on you, that the system is not going to care for you. And it's not that the system has to totally care for you, right? I think all of us in healthcare know that people aren't always the best version of themselves when they're sick. And we understand that. But that balance, it's a very intuitive, it's a very delicate type of balance that has to be done, which I appreciate is hard to legislate. But that's why transparency and consistency and providing people with all the information they can so they can make those judgments. You're preparing people so they can be prepared in the situation. I hope I hit all your questions.
Yeah, you did. Just with the reporting too, but so I will say that it happens time and time and time again that we do have a client that is abusive or that says something very threatening, and then you're taken off the case, but another nurse is put on the case without any information to let that nurse know. And I think most of the home care nurses that I've talked to, and many from throughout the state have contacted me, that is one of the most frustrating things. And so then you don't want, like, let's say it is a tough patient. I mean, you have tough patients. And if they have a wound vac and you're there for an hour 3 times a week, and you're afraid to then go tell your supervisor how uncomfortable you feel when you're there, because you know that it's just going to get taken away from you and given to another colleague. And then you're going to feel, guilty that you said anything. So I think that has to be a big part of what management has to do when it comes to the patients that are, I don't want to say difficult, but the patients that are aggressive and are abusing the home care staff.
Thank you, Senator Marks. I guess, Kim, I was waiting for you to respond to that, but I think you've added quite a bit to this conversation, and we know that you will be an important part of it going forward as well. Thank you, Senator Marks. And seeing and hearing no other questions, we'll go next to Senator Fazio. Welcome.
Thank you.
Doing the transportation juggle, as we are, a few of us today. Welcome.
Thank you. Good afternoon, Chairs Anwar, McCarthy Vahey, ranking members, and distinguished colleagues. I'm here to testify in partial support of Senate Bill 440 and to testify in strong support for rolling back certificate of need laws, which would, without a doubt in my mind, increase access to care, improve healthcare innovation, and reduce the cost of healthcare for Connecticut families. SB 440 reflects some of the language from a bipartisan bill proposed by Senators Anwar, Gordon, Summers, Hartley, Rahman, and myself, which would roll back CON requirements for the expansion of many healthcare services while leaving them in place for some sectors for closure or reduction of services and for private equity or consolidation in the industry. It would also place a 30-day limit on CON decisions by the state government and would give some more resources to OHS to make that possible. The simple fact is that certificate of need laws limit entry into the medical profession. It's an extra permission slip from the government for the right to compete in an industry that doesn't exist almost anywhere else in the economy. CON substantially increases the cost of entry into the market, reduces competition, reduces quality of patient services, and increases cost. The Federal Trade Commission has even said that, quote, by their very nature, CON laws create barriers to entry and expansion to the detriment of healthcare competition and consumers. Data has proven out that states with CON laws see worse outcomes than those without. A study by the Institute for Justice surveying 128 Studies of certificate of need in the US found overwhelmingly that CON laws harm patients and residents. Only 11% of those 128 studies found that CON has a positive effect, 34% a neutral effect, and 55% said that they had a negative effect on patients. In one study from George Mason University, data showed that the mortality rates for pneumonia and heart failure are significantly higher in hospitals in CON states. Another study from George Mason found that repealing CON reduced healthcare costs by 6% in the areas examined and increased the available number of hospital beds by 99 per 100,000 people in the population. The evidence is very clear that CON should be limited. But it's not just studies. It's also our residents who know that the costs of this program firsthand, whether it's a small addiction treatment facility in my district whose opening was delayed by about a year by the process, or the Danbury area whose innovative cancer treatment center was denied by CON, or the people of the Waterbury area whose hospital has been in limbo for a year. It's clear that the time for reform is now. I hope that we can come together to reduce the burdens to competition and roll back CON for entry and expansion in the industry. I also think we can compromise and keep CON for closing facilities for private equity investments or consolidation. I know we need to act now and pass legislation to improve access and reduce costs for our residents. And I think that the initial bipartisan legislation would be a good place to start. Thank you for your time, and I'm happy to answer any questions.
Thank you, Senator Fazio. Senator Anwar.
Thank you, Senator Fazio. So what do you really think? No,
Not very often is you have an arcane program that gets this much passion, but maybe I'm a little unusual.
Thank you for your testimony. This is very helpful. So if I heard you right, you're saying that we should have a limited scope, which is to make sure that the bad actors do not come in, and then if they're coming in, there are protections in place for that. And also, when people are leaving, we want to make sure critical services are still protected in the community. And you're talking about the processes being simplified, and you don't want anything else. That's what I heard. Is that?
I think that's a perfect characterization. I want to find a middle ground here where as many legislators can get behind it as possible.
Okay. Thank you. I appreciate your testimony. Madam Chair, back to you.
Thank you, Senator Anwar. Senator Gordon.
Thank you, Madam Chairwoman. And Senator, it's good to see you again.
Thank you, Senator.
This may be an arcane issue to some people, but as we know, this has real world impacts everywhere in the state. So I've had a good opportunity to work with you and others who you've mentioned on this issue. I just wanted to have you, if you don't mind, clarify a very important point you mentioned where you talk about trying to limit the scope of CON, but also making certain that we do have CON in certain circumstances when it's needed for protecting the interests of the people of the state who are seeking the health care, but also looking to see what we can do to find the common ground. If you don't mind, just expand upon that point as far as, because I think it's a very important point to see what we can do, hopefully this session, to bring something out.
Yes, let's have a rollback of CON for qualified and licensed healthcare providers in certain areas to allow them to expand their services more easily. More psychiatric facilities, more hospital beds, and so on and so forth. It shouldn't take so long for Stanford Hospital in my region, for instance, to be able to buy a new MRI or CAT scan machine. At the same time, let's agree for now that we keep in place the CON limitations on the closure of facilities or from private equity investments, which I know have raised concerns on the committee, or for consolidation beyond a certain point. I think one thing that is clear is that we have CON in place in the state, and we've seen care get much more expensive at far too fast a pace. And so we're going to have to do something different in order to get different results.
And one real quick last question, if you don't mind, Madam Chairwoman. And also, it's my understanding you would agree as well, and this is another important point. I represent a rural part of the state, Northeast Connecticut, where I fought against efforts to get rid of certain services like labor and delivery, but also supporting hospitals that do want to expand certain services, such as maintaining labor and delivery or outpatient surgical and cancer centers that really people would have to go someplace else long distance for. But wanting to make certain that if certain services are closing where there's really no other option in the area, preserving CON, but also if someone wants to expand in a good way for care especially outpatient services, not letting CON stand in the way. Is that correct?
Correct. And that's exactly why the bill that you and I and Senator Anwar and Senator Summers and Rahman and Hartley proposed keeps CON for closure in order to have a guardrail for rural areas in particular, or underserved areas in particular.
Thank you for testifying today.
Thank you, Senator.
Thank you, Senator Gordon. With my apologies to our ranking member, Senator Summers. I saw you and then missed you, so please proceed.
No problem at all. Thank you, Senator, for your testimony. I am really grateful that you pointed out the studies that we all have seen that show that states that have CON do not have better health outcomes. And actually, in certain areas, the cost is reduced when CON goes away, because CON is inherently sort of anti-competitive on some level. I wanted to see if I could ask you, there's another bill in the governor's bill concerning private equity. So if you had a hospital or behavioral health center that was owned by X company, but yet they were going to sell off a certain percentage, which could be private, or there could be some, it would be private equity. Is there a percentage rate that you're looking for CON to be involved, or is it any kind of private equity transfer of ownership in your eyes?
I think this would be something that should be negotiated. It's, to some extent, there's a distinction without a difference. You know, there is a profit motive if they're a for-profit corporation, whether it's publicly held or privately held or closely held. You know, if the investor is a private, not publicly traded entity, isn't it all private equity? So there's some distinction without a difference there. I'm sure that there are definitions within statute that are at least somewhat reasonable. I think that a controlling stake would probably qualify as something private equity. But again, my goal is to make the statute, the regulations better. And I don't want to make perfect the enemy of the good. So if we can move it in the right direction while keeping certain CON regulations for certain parties that make legislators, policymakers feel more comfortable, then I'm open to it. I don't have any hard and fast rules here, but I think the premise of your question is a valid one, because to some extent we're dealing with distinctions that without major differences.
Right. One of the things that I'm concerned about is the way that, you know, it's not in this bill, but it deals with CON. The way it's written, it basically says if you are a controlling interest, so 51% you own, and of that 51%, you may be selling 10% of that to private equity. CON wants to look at it. And I think that is going to really bog us down. So I think that needs to be defined when we're talking about private equity, that it would have to be the majority share in order to really have CON take a look at it. And I share your frustration. I had a behavioral health facility that was coming to Eastern Connecticut that we desperately need, ready to go. And unfortunately, there was an intervener from the other side of the state who said we don't need the beds, and it was rejected by CON. So I think that moving this forward in the most positive way to try to move things along, but then protect our patients, which is what we really need to be doing here, is the wise decision. So I really appreciate your testimony and work on this bill. Thank you.
Thank you, Senator.
Thank you, Senator Summers. Seeing and hearing no other questions, Senator Fazio, we thank you for having us here with us today.
Thank you, Madam Chair. Have a good day, everyone.
Enjoy transportation. I think you're just in time for another amendment. Next, we have online Tina Waldy.
Hello. Thank you, Co-Chair Senator Anwar, Representative McCarthy Vahey, and honored members of the Public Health Committee for allowing me the opportunity to speak to some concerns that directly impact my work and access to nurse practitioner care. I appreciated the robust discussion from Dr. Lynn Rapsilber's discussion earlier about collaborative practice, and I'm going to tag on to that a little bit today. So to share a little bit about my background, I've been in clinical practice for 15 years as a psychiatric mental health nurse practitioner, and I'm also currently the program director for the Psych Nurse Practitioner program at Yale School of Nursing. I'm requesting that we add an amendment to HB 5488, allowing new grad APRNs to collaborate with experienced APRNs in addition to physicians. I'm hoping that this would reduce the restriction to transition to practice that we currently have, that requires physician collaboration. I came here to Connecticut in 2019. I had previously practiced for my career in Oregon and Washington. Oregon has some of the strongest APRN autonomy in the country. They've been practicing independently since 1979. So they're ahead of us by 45 years in some ways. And I had a really fantastic experience there. And when I came back here to Connecticut, experienced needing to find a physician collaborator for the first few years of my practice in the state, and would like to see shifts in that happen to allow experienced nurse practitioners coming to Connecticut to have a different experience than I did. I think that there are some anti-competitive disadvantages to having a restriction to having physicians as collaborators. And I think that includes limiting some of the really innovative healthcare delivery models that can often happen in states that have reduced their practice restrictions to transition to practice, increasing nurse-led practices and leadership opportunities as well. Decades of evidence say that NP care is safe, effective, and produces quality outcomes. We demonstrated that through the scope of practice review back when we were able to achieve independent practice here in the state. And we're not asking for any scope of practice changes. And to be clear, scope of practice refers to the actions that a health professional can take to treat a patient. So for example, as a psych nurse practitioner, I can treat psychiatric issues. I can't provide cardiology care. We're not asking to take new actions for patients. We're hoping that our experienced nurse practitioners can serve as mentors and guides through the healthcare system as they come and they rise from graduation. As a program director, I'm responsible for the curriculum at our school and ensuring that nurses provide competent care when they graduate from the programs. And yet when they graduate from the program, I'm not able to continue on that journey and mentoring them and guiding them as they gain those critical years of experience. And while we know that there are no studies that show collaboration increases safety, efficacy, or quality care, none, okay, there's a dearth of studies there, we do know that providing good mentorship increases the retention of nurses and nurse practitioners in practice. And that's something that we can do by allowing experienced APRNs to serve as those guides and collaborators for new NPs. And those are the main things that I'd like to say today, but I'm open to respond to any questions that come up from the committee. And I'd also like to respond, Dr. Anwar had, I think, excuse me if I'm wrong, Senator Anwar, that there was some questions around the minimum number of clinical hours. And I just like to specify that in nurse practitioner education, our hours are population focused. So you're working with a specific population. So for example, in psych mental health nursing, those hours that I had to graduate are all concentrated in providing mental health care. And that's a little bit different than in medical education. And we are shifting to the 750 hours, and that came from the 2022 National Task Force. That was a collaboration of 19 national organizations that were looking at the minimum number of hours needed in direct patient care. So that's a change that is happening now.
Your time is up, but thank you.
Thank you.
Thank you. You saw my hesitancy when you were done before your time. So that's wonderful. And thank you for that additional information. Seeing and hearing no questions, I thank you for your time with us today. Have a great rest of your day.
Thank you.
Next, we have Peter Hadler from DSS, who I believe will be the only one speaking from DSS, or you can correct me if I'm wrong. Peter, welcome. It's nice to see you live and in person and not just on a Zoom. Welcome.
Indeed. Thank you. Thank you for having me here. And yes, I have some colleagues who may call to pinch hit depending on the questions that you guys ask me. But good afternoon, Senator Anwar, Representative McCarthy Vahey, Senator Summers, and Representative Clarice Ditria, distinguished members of the Public Health Committee. My name is Peter Hadler, and I'm a Deputy Commissioner at the Department of Social Services. Commissioner Barton Reeves was unable to be here today due to a longstanding prior commitment and sends her regrets. I'll be doing my best to fill her shoes, and I'm joined again by several of my colleagues who might be able to answer questions that I'm unable to address. I'd like to comment briefly on two bills before the committee today, HB 5003 and SB 369. House Bill 5003, an act concerning child and family nutrition, requires the Department of Social Services in conjunction with other state agencies, including the Department of Public Health and the Department of Agriculture, to take a variety of actions in support of coordinating access to nutrition programs. DSS is broadly supportive of efforts to coordinate access to services and ensure that eligible households have access to valuable programs and benefits. While we are interested in and committed to collaborating with our sister state agencies in support of our state residents, we have some concerns with the specific proposals in this bill. Some of the proposals conflict with federal law, some proposals have already largely been completed, and others will require resources that have not been included in the governor's proposed budget. DSS therefore opposes this bill as currently drafted, but we are open to further conversations about how to expand collaboration with our legislative partners and sister state agencies, much of which we believe may be able to be accomplished without the need for legislation. More specifically, Section 1 of the bill requires that not later than January 1st, 2025, DPH, in collaboration with DSS and DOAG, shall develop and implement a plan to streamline cross-enrollment of any child who is on Husky A or Medicaid into the WIC, SNAP, or WIC Farmers Market Nutrition Program. Importantly, the bill requires that the plan include the use of licensed healthcare professionals employed by DPH to make an assessment of eligibility. I just want to highlight that because under federal law, DSS is the single state Medicaid agency and required to make the eligibility determinations for the Medicaid program. I do think there's potential for clarification, perhaps about the intent about which personnel at DPH were intended to do what part of the role, but we would ask that that be clarified in any bill that comes out of the committee. Section 1B requires DPH, DSS, and DOAG to jointly create a program fact sheet describing eligibility requirements for and types of benefits provided in Husky A, SNAP, WIC, and the Farmers Market Program. And Section 1D requires the placement of program applications in the fact sheet on each agency website. We appreciate and share the desire to make information readily available to state residents, but respectfully suggest that a statute's not required to create a fact sheet or post on our website, nor to have our electronic program applications posted there. For example, DPH, in consultation with DSS, has already created a website, and we've jointly created a fact sheet that's included on both agencies' websites and has been distributed to statewide to partners, including the Office of Early Childhood and 211. In addition, DSS and DPH already have our program applications available on our respective websites. We link to each other's programmatic pages, and we are certainly open to adding more links from state agencies or other partners without the need for a statute. Section 2 requires DSS, in collaboration with DPH, DOAG, and the State Department of Education, to coordinate statewide public access, information, and outreach, promote cross-referral and co-location of entry points and application processes for various nutrition programs, as well as securing federal reimbursement and additional funding for the cost of administering these programs. DSS is open to working with all of our state partners, and we do collaborate with these agencies, as well as farmers and nonprofits, through channels such as the Connecticut Food Policy Council. However, at this time, we cannot agree to the co-location of entry points and application processes due to the significant financial resources for staffing and operations and technology changes that would be required.
Excuse me, Mr. Hadler, but your time is up. Thank you.
I had a feeling I was going to hit that.
And if you can summarize, but we're going to have some questions for you as well.
Okay, great. I'll move as quickly as I can. I just want to note that we additional federal reimbursement and other funding cannot be secured at the levels required to cover these costs. And again, the funding is not in the governor's proposed budget. In Section 4, there are provisions to establish a seamless process for transitioning children between programs. And we think it's important to highlight that we already do referrals between DSS and DPH for WIC, and we have been doing so since 2021. We have a process where we currently yield about 25 referrals per week from the SNAP program to WIC. And we also have to note that federal law prohibits direct enrollment in SNAP without an application. So we are somewhat limited in how seamless a process may be under this proposal. We also note that resources would be required for outreach and that funding for this work has not been included in the budget. Finally, there's another provision about developing a plan for increasing access through data sharing, common applications or an application portal, and automatic enrollment. We are certainly open to working with DPH and DOAG on ways to expand data sharing and referrals, but we do have to balk at administering a common application. There are significant financial resources that would be required in order to make the system changes, and we'd require federal approval in order to have a joint application for these purposes. We also want to just highlight very quickly that we have a lot of work going on already at the state level to link state programs for ease of use through our health.ct.gov website. There's a lot of information there, the ability to determine eligibility preliminarily for many programs and collect and see your current status for enrollment in programs that you're already participating in. So we certainly look forward to additional conversations with the proponents of the bill and our fellow state agencies to advance coordination of access in these important programs. I'd also like to very briefly comment on Senate Bill 369, just to highlight that DSS is very committed to working with our partner agencies, including the Department of Public Health, providers, and other stakeholders to help address workforce safety. We have 2 studies going on that may be relevant. We have asked Carol on our Medicaid Programs Behavioral Health Administrative Services Organization to conduct a home health landscape analysis that we think will be contributing to this conversation. And phase 2 of our Medicaid rate study will also include home health provider rates. Between these 2, we'll have an opportunity to address access, quality, and safety in home health service delivery. We are also looking at other ways that we can enhance staff safety within existing state and federal funds. We look forward to continued conversations on this subject. And that brings me to the end. I'm happy to answer any questions.
Thank you so much. Yeah, you've answered some of the questions that we had, but I'm sure this is going to trigger more questions. But I wanted to start by a couple of thoughts. One of the rationale for the bill is for the first one, 5003, is to have no wrong door. That's the mindset. So if anybody who is in need, rather than having them shuffled around in different places, we want to be able to have agencies interact with each other and then connect them to DSS. I know by the federal law, you're supposed to go through DSS. So how come there is we cannot create a mechanism through legislation that whenever any agency is approached, they would actually be able to link to you, to DSS, to be able to get more individuals who are in need of help to get that help?
Thank you, Senator. One thing we are always careful of is ensuring that we have got consent to share data between programs. And that's one preliminary thing that we are working on already. We have started to include language on our applications and rule forms, giving us some flexibility to be able to refer folks who are applying to DSS administered programs to other programs that they may benefit from. So we think that we're moving in the right direction. We are doing this methodically and carefully to ensure that people aren't having their information shared, without them being aware of what is being shared for. And there also are some real challenges operationally and mechanically around what application forms we can use, how we can ask the questions, and how that eligibility is determined for various DSS administered programs that don't necessarily allow us to do a joint application for everything all at once.
So, but if the other agencies were connecting to DSS and DSS is the final conduit to do this, then you should be fine.
We may have to think about more specific scenarios than that, but there are opportunities, I think, for us to be able to work in particular in potentially doing some data sharing with Department of Public Health. I know that WIC is the main focus, and we'd like to make sure that we're able to refer people to WIC on a consistent basis. But I don't want to overly limit. Rep. Foster was very eloquent about the WIC aspect of things, but the bill as written really encompasses more programs, and so I want to make sure that we're thinking about the processes in the context of each specific program and how we might or might not be able to share, enrollment or refer folks over. It depends on their income eligibility for various programs in part.
So DSS is the main agency that is doing this work. The issue is that there's a need in the community, and then we need to address that need. And the entry point for the individuals who are in that need and legitimately would qualify, they are going to have access through different points. What's happening is there are 3 parts. One is not enough people have that information. The second is that the process is becoming a barrier. And I think this bill is addressing the low-hanging fruit to be able to provide the nutrition to the people who should get that nutrition by law. And I don't want the existing laws to restrict the people who are hungry to get their food. So that's where I appreciate the part that you said that DSS will do everything in their power to help us get this in the right direction, right?
We're certainly happy to keep talking about this and make sure that we set up a process that works and that doesn't necessarily involve a lot more additional funds and resources, because I know that is something we're very cognizant of, and want to make sure that we're not trying to do good things, but without a budget to do them.
Thank you. The second part on the other bill, on the worker safety bill, why was the funding or the support taken away for an escort by DSS?
I apologize. Could you? ask that
In the
question?
past, there was funding that Medicaid was providing to individuals who needed escort for home health workers. Why was that taken away? I believe, if I'm not mistaken, 2016 or 2017.
I am not aware of the reason behind that. However, I would love to invite up Fatma Williams, our Director of Integrated Care, who can provide additional insight.
Thank you so much.
Hello, distinguished co-chairs and committee members. My name is Fatmata Williams, and I'm a director of medical administration at DSS. So I'm here to support Peter today. But yes, there was, we did have what was called the home health rate add-ons. That was eliminated in 2017. It was just part of a larger budget mitigation process.
Obviously, many of the people around this table or the Public Health Committee may or may not have been there, but in retrospect, it was not a good idea. And to take that away, because that has Joyce Grayson may have been alive, if or others may have been safer if we did not have, if we had that law where if somebody was feeling unsafe, they should have been able to get an escort service to be able to have and Medicaid pay for it. So I just wanted to share my thought about that, and I appreciate your willingness to work on that bill as well for the safety of our healthcare workers. So, Madam Chair, back to you.
Thank you very much, Senator Anwar, and thank you for being here. I have a couple of questions for you, and thanks for your patience with me today. So one is just about the food policy, and you'll tell me if it's you or someone else. Just in terms of their work lately, I know that they've been doing some work to promote WIC, and if you can update us as the committee. We know you're usually before Human Services, so we don't get to see you very often. So if you can just share with the committee the work that's been happening there, that'd be wonderful.
I am actually going to have someone else come up to talk about that. Dan Giacomi is our Director of Program Oversight and Grant Administration, and our longtime SNAP Director is more familiar with the intricacies of the council and can answer that question.
Thank you.
And thank you. As the Deputy Commissioner said, my name is Dan Giacomi. I'm the Director of Program Oversight and Grant Administration at DSS, as well as currently the SNAP Director for the state of Connecticut, as well as a member of the Connecticut Food Policy Council. So throughout the past year, and since I believe it was 1997 or so that the council was created, there's a number of different avenues by which we operate. We do have periodic meetings that bring together state agencies, farmers, producers, markets, and a whole host of other individuals to bring awareness to the different programs that are available to individuals throughout the state. We do also offer a grant program for a number of different areas, including building sustainable farms or food programs throughout the state to individuals, as well as the areas of refrigeration and things of that nature. And we do go to different areas throughout the state, to different producers, markets, farms, and otherwise, to see the work that's being done in an effort to promote the work of all of the different areas of the food insecurity and food security arenas throughout the state.
Thank you for that. And I will direct this perhaps to both of you. Are there other nutrition programs where there is an auto enrollment with that, using Medicaid as the auto enrollment? Is there anything else?
So the two that come to mind right now, and not necessarily auto enrollment, but that it's what's called categorical eligibility, where the enrollment in SNAP confers eligibility to the income piece of a program. The two largest that you can think of is obviously the WIC program itself, and the second would be the school meals program through the Department of Education, where receipt of SNAP benefits Husky A or TANF benefits would qualify a child in public schools and some private schools in the state to qualify for free breakfast and free lunch.
Thank you for that reminder. As a school parent, I should have remembered that. But the last question is just in terms of other states. We often look at what other states are doing. You've been sitting here listening to the certificate of need conversation, and certainly there's been a lot of conversation around that. You know, are there other states that you're looking at in terms of best practices for how to get more people enrolled and get more people involved and make sure that we are assuring that safety and good feeding for our infants?
Certainly. In my free time, I'm also on the executive council of the American Association of SNAP Directors, which is bringing together the SNAP directors of all of the 50 states, as well as the some of the territories that we have. So we are constantly talking, discussing, and collaborating in ways. I know that there are a number of states that have data sharing agreements between the WIC agency and the SNAP agency to be able to share some eligibility information amongst the two. There are cross-promotional opportunities where information is being shared to the general public. And those are some of the things that, as the Deputy Commissioner has mentioned, that we've begun working on through our application and renewal language and our data sharing information, as well as information that we sent out in two recent nutritional programs, or one recent nutritional program people may have been aware of, called the Pandemic EBT program. With all of our notices that went out to our families there, it did include language about the WIC program as well as the Head Start program, neither of which are operated or administered by DSS. So those are ways that we're able to broaden the awareness of the programs themselves, as well as through the data sharing, to be able to confer that information about eligibility, which may reduce the number of procedural denials, as they're called, for individuals applying for programs.
Thank you. And actually, I do have one more because something you said just triggered that. WIC is under DPH. And so I think that is some of the tricky language. And you just said, or the tricky part of this, because you're not all together in that way. You said some states have data sharing between WIC and SNAP. And then I'm going to assume that we do not have that in Connecticut.
Not currently at this time, no.
Not currently at this time. Okay. Do you think it would be helpful if we did?
Most certainly. And as the Deputy Commissioner mentioned, that was one of the first steps that we needed to do, was to add language to our applications, both online and paper, as well as our renewal forms, that lets individuals know that we plan to share information with them about the WIC program, as well as other programs throughout the state. We're in the process of completing that, which will then allow us to enter into those conversations with DPH to have a formalized agreement.
Thank you. And you may have said that when I stepped out briefly. So thanks for repeating it if you have. It's something worth repeating. So I appreciate that. Seeing and hearing no other questions. Oh, Ms. Williams, please. Welcome back.
Thanks again, Madam Co-Chair. I just wanted to clarify something based on what Senator Anwar just said. We did eliminate those rate add-ons in 2017 because there were a group of add-ons that were for various components of, whether it was for an escort service or whether to visit someone who has AIDS. And at that time, we had made major advancements. So the utilization was extremely low. So it really was just part of a budget mitigation that was just, nobody's using this, we can just get rid of it. That's what happened. So it wasn't like people were utilizing that service and DSS just decided to use it as part of a budget mitigation. So I just wanted to state that for the record.
Thank you, Ms. Williams. Senator Anwar.
Thank you for clarifying that. And was it done internally or was it done through a policy? In other words, was it legislatively addressed or was it done internally by the DSS?
I am not sure. That I'm not sure.
And the reason I ask is, for obvious reasons, we want this back. For specific situations with right guidelines, we want to be able to have escort available as an add-on service for certain situations where the healthcare workers are feeling unsafe. And if Medicaid had it before, then we should put it back in. And the issue is that taking it away without a legislation, and now we'll have to put a legislation to bring it back. It sounds challenging because we cannot legislate everything. And to that point, to the earlier conversation, why do we need to legislate things? We need to legislate things for this very reason, so that nobody can change a policy internally. And the legislations are supposed to last far longer than our presence here. So that's the reason. So if I had the magic wand, I would actually put that legislation or internal policy back so that we can protect our healthcare workers and Medicaid pay for it too when it's in that situation. Thank you. Thank you, Madam Chair.
Thank you.
Thank you so much, Senator Anwar, and thank you to all three of you for being here with us today and answering our questions. We look forward to working together with you, and I know Rep. Foster and Rep. Kennedy will be as well.
Yes, thank you. We do too. Appreciate it.
Next, we have Deborah Bibbins. Welcome.
Thank you. Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. I am Deborah Bibbins. I live in Simsbury, and I am the founder and CEO of the nonprofit For All Ages, which is dedicated to connecting the generations and inspiring action to end loneliness, reduce ageism, and improve health for Connecticut's residents. I'm here today in support of Section 36 of Senate Bill 1 to create a working group to study and recommend opportunities to reduce loneliness and isolation among our residents, and I do have a few suggestions to improve it. First, thank you for focusing on this public health crisis. More than half of Americans are lonely, and loneliness is that feeling that we don't have the amount of positive social connection in our lives that we believe we need, and it can cause serious mental and physical health impacts, from depression to dementia, ultimately shortening lives and inflating our healthcare costs. Nearly 1 year ago, For All Ages convened the Connecticut Collaborative to End Loneliness, a cross-sector alliance to foster social connection across the state, and we're currently focusing on two foundational areas. Recognizing that healthcare professionals are common touch points for many people, we have begun to engage clinicians and health insurers to establish loneliness as a standard component of annual physical exams. We're also hosting Connecting Connecticut conversations across the state right now to normalize the conversation and reduce the stigma associated with loneliness so that people feel comfortable talking about it. There is much more work to be done as set forth on the Collaborative's website and in my testimony, my written testimony, and we welcome your engagement and your involvement. I do have a few suggestions to improve Section 36. First, For All Ages would like to be a part of the working group. And so I would respectfully request the addition of a representative of an organization in the state that is currently offering intergenerational and other social connection programs to reduce loneliness and isolation so that we can be a part of the group. Second, I believe the proposed timeline of the group to assemble, to evaluate the causes of and the methods to prevent and eliminate loneliness and isolation and prepare a report by early 2025 may be optimistic. And so to that end, and to provide flexibility, I recommend that Section 36B be edited to read that the working group may include, in lieu of shall include, all of the entities and the people that are currently listed, so that the group can begin meeting without being fully staffed. I also would like to ask that the word identify be substituted in lieu of the term evaluate, since evaluation can be a lengthy period of time. And given that the report is due in early 2025, I think identify may be a more appropriate word there. Thank you for this opportunity to speak with you today. I'm happy to answer any questions you may have.
Thank you very much for those very specific suggestions. Those are helpful and we appreciate it. And we appreciate your work.
Thank you.
And the fact you named, I think in your testimony, For All Ages also is working on ageism, but the collaborative, it sounds like, is across generations and not just directed to our senior population. Is that correct?
That is absolutely correct. The loneliest population is actually the young adult population, age 18 to 22. And we are very much focused on reducing and eliminating loneliness and ageism across the age spectrum.
Wonderful. Senator Anwar.
Thank you so much, Ms. Bibbins, for your testimony, and I wanted to thank Representative Parker for connecting us and the time you took to have a pretty long discussion with me previously and continuing the conversation.
Thank you.
Appreciate your insight. This is very helpful. Could you, for benefit of everybody else, talk about the work that you are doing statewide at this time?
Yes, yes. So we have convened a cross-sector steering committee made up of leaders of various organizations, from people representing employer health and employee health, to clinicians across, including Yale and UConn Health and Hartford Health Care, to start to focus in on what do we need to do to make change to reduce loneliness. How do we drive down this epidemic that is now impacting all of us, many of us, in some way, shape, or form? You know, we know that it has a detrimental health impact, from anxiety to depression, to substance use, to suicide, to gun violence. We know it's inflating costs. We know that lonely employees are less productive and have higher rates of absenteeism. And so across our society, loneliness and social disconnectedness is a problem. So we've started on the first two areas, one of which is pulling together healthcare professionals to talk about getting loneliness part of an annual physical exam, but it doesn't stop there. The next question is, once someone self-identifies as being lonely, what happens then? And that's where we need to be thoughtful around what opportunities are currently in place across our local communities, and what opportunities do we have to create that don't exist today. Driving down the stigma is key, because you can have all of the social connection opportunities as a municipality that you want, but people aren't going to attend if they feel like they're only being invited because they're lonely. So we need to drive down that stigma, and we need to turn it into a conversation around the importance of social connection. I hope I answered your question.
Yes, you did. And this bill that we're looking at in Senate Bill 1, it is trying to have this group create a decentralized plan so that there is a local effort, because for loneliness, part of the solution is for individuals to interact with each other in the local communities.
Yes.
So a town-based or municipality-based program. Tell us about in your program, are you guys exploring that option, and are there people in the country that are doing similar things?
Yes. So one of the goals of the Connecticut Collaborative to End Loneliness is, well, actually two of the goals are definitely local focused. One is addressing young adult loneliness and creating curriculum to be, to go throughout high schools, public and private high schools, to get youth and teens comfortable talking about loneliness and about the importance of social health. The other thing that we're doing is focused on older adult loneliness and the importance of social connectedness. And we haven't yet, but we plan to go out and speak to representatives across all of our municipalities about how to engage older adults in their community. It's going to look different between a rural and an urban setting, certainly. And what types of intergenerational opportunities might be created that don't exist today, that give our older adults a sense of purpose and give them the opportunity to mentor young adults, and have our young adults in all of our communities and our teens in all of our communities be connected with older adults. The intergenerational component is something that we view as sort of the icing on the cake, where not only are you driving down loneliness, but you're giving both the younger and the olders a sense of purpose when they come together.
Thank you so much for your testimony. Thank you for the work you're doing, and you would be, and your team would be wonderful to be part of what we are envisioning as well. Thank you.
Thank you. Thank you for your
Madam
time.
Chair.
Thank you, Senator Anwar. And I would just add, as a social worker, I often say, and as a legislator, that connection is the root and the heart of what we do. Certainly it is, as I approach this work. And when I think about the committees I serve on, I've talked about transportation today. Transportation, planning and development, how we actually build and connect our communities on a physical basis in terms of walkability and the ability to be on safe streets. There's research behind how streets are designed and the kind of connections that people have with their neighbors across the street.
Yes.
Based on speed and design of roadways. So I hope that as we continue to do this work, hopefully together, that those are some of the other considerations, because there are, as Senator Anwar said, it's a very diffuse plan or attempt to look at this issue because it really does impact so many areas. So thank you very much for bringing this forward, for highlighting this, as I know Senator Murphy has been
Yes.
having this conversation around the state as well. So hopefully we can link efforts and be even more successful in that way. Thank you.
Thank you. And just as a footnote, Senator Murphy does have his Director of Outreach serving on his behalf on the steering committee of the Connecticut Collaborative to End Loneliness.
That's wonderful. Thank you so much.
Thank
Thank you
you.
for being here with us today. Seeing and hearing no other questions, we will go to Kathy Flaherty, who's here with us in person. Welcome.
Good afternoon, Senator Anwar, Rep. McCarthy Vahey, and all the members of the Public Health Committee. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project, and we provide legal services to low-income adults with mental health conditions. I'm here, I submitted written testimony with comments on just Section 1 of both SB 1 and SB 369. Believe both of these are very important bills. I want to start by saying all workers deserve a safe workplace. All workers everywhere deserve not to be abused or harassed in their workplaces. All workers should be able to go home at the end of their shift and be safe. That being said, when the bill was just a shell of a bill and it said to protect the health and safety of Connecticut residents, and then the purpose was to help people with psychotic illnesses, I was like, why are we linking mental health and violence and almost saying, well, being around people with mental health conditions, we can't have safety? I think that's the biggest concern I have about the way that psychiatric history and violence are repeatedly put next to each other when most people with mental illness are not violent and are more likely to be the victims of violence. That is not to say there aren't incidences where people with a mental health condition have been violent. Previous incidents of violence are the best predictor of future incidents of violence. So I have no problem sharing that information, but when people do have protected health information, not only of the patient, but also the other people in the house, I think it's just something that we need to be careful of. I know my physical health treatment gets treated differently because there is a note in my chart that I live with a mental health condition. My doctors treat me differently. So the question is, do you have to know? Do you need to know to have the care? I will admit I wrote about Section 1 because at the time I wrote my testimony, I hadn't read the rest of the bill. But after talking to some people last night, I read the rest of it. And I have some very short questions on Section 3 or comments on Section 3. I think the reporting of abuse and neglect is really important. But you know, the one group of people that we don't have anywhere to complain about abuse and neglect is people living with mental health conditions. We have it for children. We have it for elders. We have it for people with disabilities. We have it for nursing home residents. We now have it for corrections, but they're working on getting that ombudsman and state-operated mental health facilities. But if you're getting treatment at any facility that's not a DEMAS facility and you're being abused and neglected, you have nowhere to complain about. So that's just something that I think this committee should be aware of. And lastly, Section 36, which we just heard talk about, people with mental health conditions are lonely too. And I noticed you don't have actual people with mental health conditions on this panel. You have psychiatrists. And I don't know that we want psychiatrists speaking for us. So that's just something to think about. Nothing about us without us. But I thank you for the ability to comment on the bill. And I appreciate your time.
Kathy, thank you so much for your valuable input today. I appreciate that, and especially that last comment, nothing about us without us. So Senator Anwar.
Yeah, so thank you so much for your advocacy and your testimony. And I think you should probably repeat what you had just said about people with mental illness are not dangerous. They're actually victims of abuse rather than a source of it. So if you can repeat that so that if we can hear it even louder.
I think it's really important for people to remember that people living with mental health conditions are far more likely to be victims of violence than they are to be perpetrators of it. And I think, unfortunately, there's a lot of media depictions where it causes the problem and people believe what they see in the media, but that's simply not true. The one thing I'd like to add is, one of the way people maintain connection is through their cell phones. And people are lonely, and we talked about that the other day at a hearing. So I just want to put that on the record too.
Thank you so much for your testimony, and thank you for the work you do. Thank you, Madam Chair.
Thank you, Senator Anwar. Seeing and hearing no other questions, thank you for being with us today. Have a wonderful evening.
Thank you.
Next on the list is Jay Hicks, who's joining us online. Mr. Hicks, welcome, and please proceed.
Thank you very much, Madam Chair, and Honorable Senator Anwar, Vice Chairs, Ranking Members, and other distinguished members of the Public Health Committee. On behalf of the Connecticut Society of Radiologic Technologists, I would like to testify on our partial opposition of HB 5488, specifically Section 10, that includes the language of or advanced practice registered nurse. My name is Jay Hicks, and I'm currently an assistant professor and the assistant director of the Radiologic Technology program at the University of Hartford. I have been a registered radiologic technologist for over 25 years, certified in radiography, and serve on many boards. However, today I'm giving this testimony on behalf of the members and the board of directors of our Connecticut Society of Radiologic Technologists as the president, and also inherently supporting the 4,300 plus medical imaging and radiation therapy workers in the state of Connecticut. Again, the CSRT is expressly opposed to Section 10 of HB 5488, and our first and paramount concern is that a scope of practice determination has not been performed. We are adamant that the addition of or advanced practice registered nurse, APRNs, to perform fluoroscopic procedures would in fact be a scope of practice change. So we would respectfully like to ask that the APRN language be removed and a scope of practice be set forth. In my written testimony, I've gone through some of the kind of pedantics of fluoroscopy. A couple of the main things that I would like to reiterate are that unlike regular diagnostic imaging, like say a chest x-ray that some of you may have had, that's a millisecond, and fluoroscopy includes the continuous live x-ray beam that is on the whole time that the engaged button is in fact is live. The radiation dose is cumulative in nature. There are the potentials for high doses of ionizing radiation, specifically during interventional radiography procedures, angiograms, cardiac catheterizations, et cetera. And these can, in fact, cause skin burns, non-healing ulcers, or soft tissue injuries. The majority, it seems, of the written testimony comes from interventional radiography, APRNs, from an entity, and that is our second primary concern is that unlike physician assistants, APRNs, after their 3 years, 2,000 hours, can work independent of the supervision of a physician. So we are quite concerned about that.
Excuse me, Mr. Hicks, but your time is up. Thank
Oh,
you.
no.
Thank you. Mr. Hicks, if you could summarize, that would be
Yeah.
great.
Yeah, no, we would just respectfully again ask that the language be further discussed under the scope of practice determination. We are very supportive of our APRN and PA colleagues. However, we believe that a transparent and democratic process as called through the general statutes should be followed. Thank you.
Thank you, Mr. Hicks. Senator Anwar.
Thank you for your testimony, Mr. Hicks. Can I just clarify if they're going through a training on fluoroscopy safety, your first point would be less relevant about the risk of exposure to radiation because there is a training process that is involved. That is the same as any physician assistant is going to go through.
Right. The 40/40 training for the didactic and clinical, and then the fluoroscopic examination. The fluoroscopic examination is that the PAs currently take is not the same exam that the radiologic technologist would take. And we feel that, radiologic technologists are in school education courses, laboratory and clinical for 2 academic years. And we have a much better curricular handle and practical handle on the safe radiation practices, radiobiology, and the physics of the fluoroscopy in general. So we would, if this does go forward, we would certainly like to try to beefen up this language a little bit to perhaps require some continuing education requirements annually and not just the modest 40/40.
Could you share with us, if you're aware of it, and if you're not, don't worry, about the physician assistants? Are they expected to undergo ongoing education too?
I cannot speak on behalf of that profession. I mean, I know, yes, they do in fact have continuing education requirements, but we would specifically want requirements specific to radiology.
And but if the PAs are undergoing the same 40 training, then why do you want it different for APRNs?
Well, because the physician assistants are working under the supervision of a physician, and APRNs, after their 3 years, 2,000 hours, can be completely independent of a physician.
Okay. Thank you for your testimony. Thank you, Madam Chair.
Thank you for your time.
Thank you. Seeing and hearing no other questions, we will go to Stephanie Bulletin. Welcome.
Hi, thank you. Good afternoon, members of the Public Health Committee. My name is Stephanie Bulletin, and I'm honored to stand before you as the VP of Sales for Kooth Digital Health. Today, I'm here testifying in support of SB1, an act concerning the health and safety of Connecticut residents, specifically Section 36 of the bill, which establishes a working group to make recommendations on methods to address loneliness and isolation and improve social connection. Subsection 18 of the bill adds a representative of an organization in the state that develops mobile applications that are intended to address loneliness and isolation. Kooth's application fits perfectly in this description. However, we ask that it be amended to allow for any organization, not just based in Connecticut, to be able to participate. We also want to share the efforts we are working on in other committees that impact student mental health. Kooth supported a bill before the Children's Committee, SB 261, an act concerning a study regarding the use of online software application to address the mental health needs of students. Kooth also testified in support of SB 5, Section 6, an act concerning school resources before the Education Committee. For more than 2 decades, Kooth has served the behavioral health needs of youth and young people via digital means, first web-based and now utilizing an app. Utilizing digital means offers the benefits of making behavioral health and wellness to every youth and young person to whom it is available, regardless of acuity of need. A digital application delivering behavioral health services such as ours does not replace the need for traditional live in-person therapies when warranted. Rather, it augments what is available and meets youth and young people where they are at exactly the time they need. At Kooth, we ensure that youth and young people have a secure, confidential, and timely means to access proactive behavioral health support. Our multifaceted approach within Kooth's platform provides 3 digital paths. First, we have a self-guided pathway where the user can delve into learning more about an issue they may be facing. This pathway also includes tools for emotional regulation. The second pathway is an asynchronous moderated community that is segregated by age group. This community is pre-moderated by members of the Kooth clinical team to ensure there is no personal information shared. The content meets community guidelines and is assessed for risk. Most users of Kooth receive exactly what they need through these 2 pathways. However, for those who need to talk to someone, a third pathway offers users immediate access to licensed clinician through chat-based sessions. Currently, the Kooth app, called Saluna, has already made a significant impact, being available to more than 20 million individuals across Pennsylvania, Kentucky, California, and the United Kingdom. It's for these reasons I'm here testifying in support of SB 1, Section 36, and I appreciate your time and attention to these crucial matters.
Thank you for your testimony. We certainly know that our young people are online quite a bit.
Absolutely.
Having had some debates with some tweens this weekend about getting off their iPads. So it is a really critical means forward. Can you just go back to what you just said in Pennsylvania, Kentucky? Just to repeat that, you're available. Just say a little bit more about what you mean by that.
Yes, so in Pennsylvania, it is available to over 100,000 students throughout school districts, both urban and rural. It's available in Philadelphia and then all across the state. In California, it's actually offered statewide to every 13 to 25-year-old in the entire state, and that started as of January 1st of this year. We're also in a university, the University of Pikeville in Kentucky. And Kooth was founded in the United Kingdom and has been available all throughout the United Kingdom for over 20 years.
Thank you for clarifying that. So in Pennsylvania, it's school districts who are offering this opportunity, but California as a state, do you know which department is offering that or which area?
In California?
Yes.
I can get clarity on that and definitely provide it back to you, yes.
Thank you. I appreciate that. Are there questions, Representative Dauphiné?
Good afternoon. Thank you, Madam Chair. Thank you for being here today. Just a few questions. You said that they're doing this in other states. Could you expand on how this is paid for, how much it is?
Yes, absolutely. So it's being offered, it's funded through the state in both Pennsylvania and in California. As I said, it's offered to every individual in California, and then the school districts are on an opt-in basis in Pennsylvania. And we are funded on a $30 per user per year in a school district or in any given population.
Thank you for that information. And you said children as young as 13 are using this app. Would the parents be aware of that, or is this something that they would be notified if they were using such an app?
Yes, so every school district that utilizes Kooth, we have a group of individuals, customer success teams that are their boots on the ground, and they partner with the school districts to make sure that the parents are very aware that this is being offered. There are webinars that are offered for parents to join, as well as information that's sent home and different types of informational materials. So absolutely, the parents are aware in every situation that this is being offered.
So the parents are aware, but they don't get to decide whether their child uses it or not. It's something that's offered to them, and the parents are aware that it's available, but would have no say in whether they do use it or not, correct?
We follow state guidelines. So we follow the age of consent in any state that we partner with.
Okay, thank you.
Thank you, Representative. Ms. Bulletin, thank you so much for being here with us today and for your important work. We appreciate that. Next, we
you.
will have Tracy Wodak to be followed by Neha Shanavas. Thank you, Tracy. Welcome. Please proceed.
Thank you. Thank you, Co-Chair McCarthy Vahey and distinguished members of the Public Health Committee. My name is Tracy Wodach, President and CEO of the Connecticut Association for Healthcare at Home. I am also an RN with over 40 years experience, including home health and hospice. Thank you for the opportunity to speak on Senate Bills 1 and 369, Sections 1 through 9 today. We support Sections 2 through 9 with some amendments. We oppose Section 1 with a recommendation to promote current home health risk screening practices, while the work group in Section 8 convenes and makes recommendations. The tragic murder of home health nurse Joyce Grayson back in October prompted all home health care providers to review their safety and workplace violence prevention programs. We have learned a great deal since October on what works or doesn't work, what info we need but have trouble accessing or can't access at all, not to mention the potential for violating HIPAA and confidentiality concerns of those in the home, not the patient. We must also comply with regulations requiring us to see a new patient within 48 hours of accepting the referral. Many need to be seen far sooner than 48 hours, especially our hospice patients. We cannot delay care to comply with Section 1 as drafted. In gathering the intake data, we are relying on referral sources, patients, and families for information which may be inaccurate, subjectively told, and often lacking. Putting this burden and liability as outlined in Section 1 solely on the home care providers is not the answer. Since state and local agencies have access to most of this information, our providers do not. We must find a workable solution that doesn't impact safety and access to care while minimizing unintended consequences such as longer institutional stays, higher costs, and people discharged to the community without timely services or any services at all. We respectfully urge this committee to allow us to continue to make reasonable efforts to gather the information in Section 1 while tasking the work group in Section 8 with recommending long-term and workable, fully funded solutions. We support Sections 2, 7, and 9 for training, enhanced safety mechanisms, and grant funding, but ask funding to cover the full cost of technology outlined. For Section 3, we already submit an annual report to DPH summarizing our workplace violence incidents, and we keep a log of all such incidents made available to DPH upon request. We support Sections 4 through 6 to fully fund the cost of escorts and ask that the same language in 5 through 6, as deemed necessary by such staff or agency, be added to Section 4. We strongly support a working group in Section 8, but request enhanced representation from our association, DOC, DPH, the Board of Pardons and Paroles, DEMIS, and the judiciary. Thank you so much for the opportunity to provide testimony, and please include us as these bills are negotiated.
Tracy, thank you very much. You packed a lot into that 3 minutes. You clearly have experience doing that, but there was a lot that you said, and I know we have a number of questions. Senator Marks.
Thank you, Chair. Thank you, Tracy. I've been looking forward to coming and speaking on this. I have a few questions as well about the bill. One of them is how they actually identified like the home care agency and home health aid agency. I think that because it's written that way, that there are going to be many agencies, hospice agencies, public health workers, and mostly our homemaker and companion agencies that are not going to be included with this legislation. Do you have any opinion on that?
Well, you will be hearing later in the day from Barbara Pierce, the CEO at Connecticut Hospice, regarding hospice and the impact of this bill in delaying much needed hospice care. But technically, the home health care agency as defined in the bill does include hospice. I do think you should consider carving it out or finding other ways for them to gather information in order to be able to get services started immediately as they need to. Regarding the homemaker companion agencies, this is a very medically drafted bill. When I read the intake requirements in section 1, and homemaker companion agencies are not medical agencies. They do not have necessarily have access to the diagnoses, to the medications. They simply get requests to provide support services in the home. They do a basic risk assessment, but it generally does not follow the medical path that it would if you were a home health care agency receiving a medical referral from generally a medical facility like a hospital, a nursing home, or a doctor's office. Those are our usual forms of referral, sometimes from DEMIS, sometimes from the behavioral health, ASO, things like that. So it's important for us to recognize that this bill seems to be very medically focused on the safety.
And I would say that the homemakers and companions that are in with these families 24/7, week after week after week, many of them not allowed to have a break. If they say they want to go home for a week or a weekend and they don't have anybody to replace them, they're told they can't, because then it would be patient abandonment. And there's many family members coming in and out. And I would say that they are probably the most vulnerable. I would question if anybody, any aide or homemaker or companion from those agencies has ever made a complaint to DPH. And I know you said we don't need the complaints to DPH, but yet people aren't making the complaint to DPH. I mean, people don't even know how to do it. Would you agree with that?
So regarding the home health care agency, that's the requirement is for the annual reporting of workplace violence incidents. And you are correct, Senator Marks, that the reports were not being made consistently. And this year, especially in light of the situations, we ended up doing a large push. And we also had our Department of Public Health at our annual meeting in February reinforce the requirements for reporting. And then other than that, agencies have really met with their staff, since Joyce Grayson's death. They've met with their staff, they've reinforced their policies, they've reminded staff to report any and all incidents, what would be included in a potential incident to report, whether it be, as Kim Sandor mentioned, harassment, abuse, actual physical contact, anything that would constitute need to report. We've really reinforced report everything and let us work with you and try to find a support that's needed and a solution. But those reports and are supposed to be kept by the home health care agencies. And when DPH comes in to do survey or on a complaint situation, they have every right to come in and look at those reports and see what kinds of trends they might be able to identify and things that we've put in place. So that's why I responded to Section 3 as I did, because we are already reporting, although we didn't report consistently in the past. I think there was misunderstanding as to who qualified for reporting. That's why I had the Department of Public Health emphasize the clarity that it is home health and hospice that have to report. Homemaker companions are not included in that. They do not report to DPH for anything at this point. They report to the Department of Consumer Protection, and they do not have a reporting requirement regarding workplace violence.
Thanks, Tracy. And then I know, right after Joyce Grayson was murdered, I sent you the NEOSH CDC fun facts for home healthcare workers from 2012, although I think they're still very relevant. And this is the CDC saying verbal abuse from the client's family member or people in the community is a form of workplace violence. Verbal abuse may be subtle, such as asking for help beyond the scope of the job, such as with cleaning. Can't tell you how many TVs I've fixed their remotes on. Or it may be obvious, such as complaining about job performance or worker appearance, or even threatening to cause harm. I just, do you feel that the home care agency, home care staff right now understands what is truly workplace violence?
I think there's a much greater awareness now than there ever was before, since the October incident. I can also tell you that we have offered many trainings more recently, and we're actually offering a 2-part webinar series this week that is from all the things I've probably listened to at least 6 trainings since October 28th. And this particular training that we're offering our membership tomorrow and Thursday is perhaps the most comprehensive, practical, offering excellent, clear examples of what constitutes workplace violence, along with situational awareness training, de-escalation training, all the pieces that you would want incorporated, and they're all the foundation would be CDC and OSHA, as well as real life experience.
I saw that when I worked last week, but they're not mandatory. And so that's what they really need to be mandatory if we want the nurses. I could ask a bunch more questions, but just one more, give other people turn. I have a problem with using the Crime CT websites. I went on it. All it does is say how many people were, there was crime in a town for the past year. Where, according to this, it says that you should work with law enforcement agencies to find the high crime area. And I think having something quarterly where you know that on the corner of Diamond and Pearl, there have been, 5 gang-related drive-by shootings or that kind of information. Because when the Black and Puerto Rican Caucus had a webinar about home care safety, there was a police chief that said, we're sending people out into these homes where we would not go without another police officer and all wearing our bulletproof vests. And, I know that for a while where I work, there was a very high crime neighborhood, and we did get escorts when we went to that neighborhood, and the patients did get better care because you weren't as afraid to go there as you were if you had a patient that was in that neighborhood all day, if you were seeing them at the end of the day, your anxiety was so high. But when you did have an escort, it really helped. So just wondering if you have any kind of opinion about the Crime CT website and what you think about talking to the actual police chiefs of each town that the home care agencies serve.
So I think one of the reasons that we highly support Section 8 of this bill is because it will bring the stakeholders, the subject matter experts together to really help define a process that is workable for the home health providers to be able to access the information timely and easily. Currently, I can tell you that our agencies they've been looking at the sex offender registry. They've been looking at connecting with their local police. They've been looking at the Connecticut judicial website, which is very difficult, especially if you have a common name. You're only allowed to put a birth year in, not a birth date. So you don't even know if you're looking at the same person. It's extremely difficult for us to gather all the information that is in Section 1 of this bill. We think that we know that a lot of the our state partners have that information. So we are hoping that we can have some type of an easy lookup, a secure portal, something that would be maintained so we would have up-to-date information. We could have in one locality, such as where you serve in Southeast, we could have several agencies serving the same area who would all be calling the local police, all trying to get the same information versus if we had one way of accessing the information, and also ensuring that our referral sources understand what information they are allowed to give us. We are clinical partners. We are medical partners in providing care, and we have the right to have the basic information about the patients that we serve. I will agree with Commissioner Navarrete from Demas that we really have some grave concerns about some of the questions we would ask the family members. I mean, we do ask basic questions, but getting into their personal substance use and psych histories and all those pieces, that can really raise eyebrows and raise angst in the people in the home and maybe even cause more escalation of behaviors. So we really need to be careful how we approach the questioning and how we gain the information. We do need to know the high crime areas, but most of our agencies do know the high crime areas based on their experience over the years. And then the last thing that I think I want to address based on what you had asked about on some of the prior questions is the escort piece and being able to have some type of safety mechanisms, et cetera. The bill addresses like GPS trackers, things like that. But I think Senator Anwar asked the question about what happened to the add-on. Why did it get eliminated? It actually was a state plan amendment change, and it happened in 2017, and we fought it. And we produced information as to why we needed it. And predominantly the agencies that utilized specifically the escorts for that add-on rate were serving Bridgeport, New Haven, Hartford, Norwich, Waterbury, all the areas that you would probably anticipate have the opportunity for some greater risk and need for an escort. So I think those are things that we need to really be aware of in how we proceed. Mandating that the sole liability and burden of gathering that intake information in Section 1 is on the home care provider makes it an impossible thing for us to be successful and to still be able to see our patients in a timely manner.
Yeah, I could ask a lot more, but I'm going to save it for later. Thank you so much, Tracy.
Thank you
very much. Thank you, Senator Mark. Senator Anwar.
Thank you so much. Thank you, Tracy, for the work that you're doing and your help with the bill as well. There is a testimony from, and we'll probably later hear from them, from one of the hospice agencies and their concerns with the bill. And then I think you're connected with some hospice, your workers and your team is connected with hospice agencies too.
Yes.
Correct?
Yes, Senator Anwar, we are.
And I think the issue is while there are a lot of emotions during that time and safety can potentially be a concern with family and how they are experiencing the pain. The bill, do you think that the bill, the way it is, could become a bit of a challenge for the hospice agencies?
I think it's a huge barrier for the hospice agencies. And I think when Barbara Pierce, the CEO of Connecticut Hospice, will be testifying before you later today, and she can cite for you the number of patients that they need to get out to within hours of getting the referral because the referrals come in so late in the disease process. Regarding the family unit or the loved ones that are also involved, yes, there can be high emotions, but the hospice providers have expert staff. They have social workers, they have bereavement and grief counselors, they have a medical director, they have many resources to be able to work on helping families cope and be supportive. I think getting out to evaluate that family situation as quickly as possible is the most important piece. And the burden of what's written in Section 1 makes it near impossible for them to be able to see their patients as quickly as they need to.
So how do we make sure that the workers are safe and the timeline be efficient at the same time?
Well, I think, I'm not sure if you were in the room, I'm sorry. But I think in my testimony, what we did was, we understand the need to have the information that's outlined in section 1. However, very difficult to have the home care providers be responsible for gathering all that information. We really think the work group can be a very productive use of brainstorming subject matter experts together to be able to come up with a solution to have like a one-stop shopping portal, secure portal somewhere. So we're not looking in 6 different places for information, which takes up added time, doing background checks, et cetera. Those are all things that are, it's just too time consuming at this point. We're doing what we can to screen and weed out. And then if we feel a risk is there, we try to send somebody additional. But as you know, the Medicaid funding was removed in 2017. And we just don't have the funds. We are anxiously awaiting for Medicaid rate study phase 2, because we strongly believe from all of our review that our rates are similar to the behavioral health provider rates, and that we're probably about 50% of the Medicare rate in what we get for Medicaid. And predominantly the Medicaid services in the communities tend to be the services that unfortunately are in the more difficult neighborhoods, in areas where there might be more crime.
And a quick question, was there a legislation in 2017 to take the funds away from the Medicaid when they changed the policy? Was it legislated?
Yeah, so it was actually not legislated. It was a SPA amendment, a state plan amendment that DSS submitted to Medicare, requesting that they be taken away. We fought it. It was a year following the behavioral health rate being decreased by 15%. It was all a budgetary driven process. And we showed in our testimony to fight the SPA amendment that the agencies that did participate and receive the add-on rates were those that served populations in the major inner cities throughout Connecticut.
Thank you so much. Your testimony is very helpful. And thank you for all your help and the work you do. Thank you, Madam Co-Chair.
Thank you, Tracy, and thanks very much to everyone who's been sort of working so hard on this bill, especially Senator Marks. Senator.
Yeah, absolutely, Senator Marks. Thank you.
Thank you, Tracy. So I just push back for a few things. I think we have to be really careful when we say that we need the escorts just for the bigger the cities. I have had many a patient that lives in very rural Connecticut who has been very difficult and not very nice. And we have brought escorts when back in the good old days when we had them. And otherwise they were the kind of patients where you pick up your phone and you call your loved one, or you call somebody and say, I'm going into this house. If I don't call you back in a half hour, this is the address that I'm at, and send 911. And I think we all know in home care agencies that we do that often. So when you say that we need to get care right away, and I agree with you. I mean, somebody comes home on a prednisone taper with pneumonia, or, new to Coumadin or Lovenox. There's lots of reasons why we need to get out there very quickly. I don't think that it should be the home care worker that suffers because of that. That's like saying you need to get into that room where you need to put on full PPE quickly when the patient's really going bad. So just don't put on that full PPE because you need to get in there fast. It's just, it can't be it can't be on the backs of the home care workers. So I will say it, I've said it a couple times. I think that sending an RN and an LPN together, where the LPN can do all of the charting while the RN tells the LPN what to write while you're doing the initial assessment. And it will probably take an hour, hour and a half of time off of the RN's work afterwards when she finishes up the care plan and does all that and checks the LPN's work and signs off on the OASIS assessment. And then I'm also going to say that when it comes to, like you said, who does the intake? I'm a pretty strong personality. I don't get afraid of much. I've done it for so long. But I will say one of the hardest questions for me to ask in a home is whether or not you have a gun. Because having a gun right now, it's such a, especially now that I'm a senator, I mean, forget me asking if you have a gun, but, asking if you have a gun, people get very defensive and say, I can have a gun, it's my own house. And I'll say, fine, I have no problem with you having a gun, but we just want to make sure your gun is locked before we take care of you, that it's not underneath your couch cushion. And I think we can all tell lots of stories of nurses having a gun pulled while they were in giving care. So I've just said a lot, but I think we have to worry about the company. We absolutely do. But I think this bill, for once, is about worrying about the workers. And we really need to protect the workers because we've never had a chance to write legislation that worried about the workers. And that's what I hope all my colleagues will agree with me, that it is about the workers and it's about giving those patients the best care. Because if you improve our safety and if you improve our anxiety, there is anxiety in home care. And if you make that better, maybe we'll have more nurses applying to be home care nurses and aides, and the patients will get better care and we'll go home and not have so much stress. So I said a lot there, but I do appreciate you. It's a privilege that I'm sitting here working with you and talking about it. And I think at the end, we really can do a good job.
Well, I appreciate you too, Senator Marks, and having the expertise that you have. I think I'll back up a little bit to the very beginning when you talked about cautioning me about escorts only in inner city areas. What I was trying to say was that the data that we had from back in 2017 to show which agencies had applied for the add-on and had been using it were agencies that served predominantly the major inner cities for Connecticut. So not that there are not other risk areas throughout Connecticut, but that was what the data showed us. Your comment about the LPN and the RN together, it's certainly not a bad idea. I can't support legislating it, but certainly know that some of our agencies practice many different options for offering added support, to people, and not necessarily, an LPN and an RN, but, it could be two people, maybe a therapist is in on the case too, and they could have both, the RN and the therapist going in at the same time. It could be that they are able to have an escort that they've hired. I know some of the agencies have escorts still on staff, that it's a full-time position with significant experience. It can't just be anybody coming into a position like that. So I think there are a lot of things that we can work on together. And again, I think that work group is so important. There is nothing that is more important to us than the safety of the staff, and also as you mentioned, the quality of the care and the timely ability to get that care out into the community. So we need to find the right mix, and we're certainly at the table to do that. We do hope that there can be some flexibility in Section 1, because if Section 1 passes as is, I don't think we'll be able to get out to see our patients if we have to do that on every single one of our patients, we will not be able to meet consistently the 48-hour timeline. And especially for the hospice patients who, I know you talked mainly about medical home health patients when you gave examples, but we have, we have hospice patients who are referred to us who die the same day we're going out there, very late referrals. And for us to have to take all the time to be able to support everything in Section 1 before we can get out there would deny the hospice patients the care that they need in their most needed hours.
Thank you, Tracy. We have one other question from Representative Zupkus.
Thank you. Thank you for coming today. And I think we're all here concerned about the safety of y'all going out. And we want to keep everyone safe. My question is, and I apologize, I came in late. You were talking about finding, I guess, maybe history or background on your patients. How would you suggest to do that?
Well, again, I really think that the work group identified in Section 8 is a great brain trust that we can really utilize all of the resources within the state if we tap into that and determine a way. I really think that if there's something we can really, that we can offer for the providers to get easy access to information, it's to have some type of a secure portal that we can look the information up in easily and not have to like what we're currently doing. We're asking a lot of questions, and asking gets us only so much accurate information and not always the information we need. And then seeking any kind of public sites like the Connecticut Judicial, the Sex Offender Registry, our local police. Those are things that we do now, but we don't have all that information. And regarding parole and probation, we don't always get the specific information needed to be able to give safe care. In that regard, the Psych Review Board usually is very involved in the
Tracy,
behavioral
thank
health
you.
clients. So it's a lot of different people, I would say.
Thank you. Well, I was just going to say, just to end it, I'm curious as to watch how that happens. And I'm not saying you need it or you don't need that information. It's more of, we just passed the clean slate bill, and there's a piece of legislation called check the box, and you can't ask all of these questions. So I'm really curious to see how all this will play out in the end, because we do want to ensure your safety. And then I know there's so it's just going to be a fine line and a balance to see how it all plays out. But thank you.
Appreciate it. Thank you.
Thank you, Representative Zupkus. And Tracy, thank you so much for this conversation. A lot to talk about, so we look forward to that.
Thank you very much.
So next, we are going to deviate from our list. It turns out we have 2 high school students who are with us today, and we are going to go ahead and hear from them before we go on to our regular order. First in person is Neha Shanavas, number 41, and then number 50, James Crocker. And then we'll go back to number 28, Jamie Kavanaugh. Welcome.
Good afternoon, respected co-chairs and members of the Public Health Committee. My name is Neha Shanavas, and I'm a senior at Sport and Medical Science Academy in Hartford. I'm also part of the Speakers Bureau of the Governor's Prevention Partnership Youth Advisory Board. I'm testifying to respectfully request that the Public Health Committee members support the co-dispensing of drug deactivation systems, along with specific prescribed medications like opioids, as per Senate Bill Number 1, Section 26. During my sophomore year of high school, a fellow peer passed away from fentanyl overdose. He was 13 years old at the time. It never occurred to me that someone who walked the same hallway as me and ate lunch at the same cafeteria as me could just leave this world so suddenly. Investigators eventually found over 40 bags of pure powder fentanyl across multiple classrooms in my high school. This has affected our school community even to this day. To the rest of the world, we were old news by the next month, but at SMSA, we had lost a student, a friend, and a part of our community. Through the help of programs like the GPP, a Demas-funded nonprofit, we created a civil space where curiosity, openness, and acceptance created a safe space for students at our school. I was firsthand able to see why schools unfortunately need to have these programs in place to aid their students to success. Later on, through my work with the Youth Advisory Board, I came to know that it was not just my school dealing with these issues. Education systems across CT were dealing with similar problems. My work with GPP also introduced me to the importance of proper drug disposal. It is common knowledge that there are high rates of opioid misuse in the US right now. In fact, adolescents and young adults between ages of 15 and 24 have high rates of opioid usage and account for approximately 10% of drug overdose deaths. The most prevalent source of prescription opioids that teenagers misuse are prescriptions from friends or family, followed by leftover medication from their own prescriptions. Another issue is accidental consumption of opioids by young children who have access to them at home, which increases their risk of opioid overdose. It is said that less than 10% of adults and children properly dispose of leftover opioids following surgery, which suggests that the issue of additional opioids left over in the house after a medical procedure is a widespread issue but manageable. The doTERRA drug deactivation bags provide a safe, easy, and environmentally friendly way of disposing of medications. There is a dire need for accessible drug disposal systems to address this concern in our community. In conclusion, I urge the Public Health Committee to consider the points raised in this testimony and take appropriate action against substance misuse. I am confident that by working together, we can make meaningful progress towards resolving this issue and creating a better future for all. Your consideration of these matters and solutions is very much appreciated. Thank you.
Thank you so much for spending your day here with us, for your testimony, and for your very important work in making sure that your peers, as well as their parents, understand the risks involved. And I think I saw, nope, I did not see a hand, but Senator Anwar.
Yeah, thank you so much for your testimony, and I'm so sorry for the loss of your friend. And it's hard to believe that that this is so common in our schools, and it's impacting young people. But also in honor of your friends, you're working to make sure that doesn't happen to anybody else. So I wanted to thank you for your testimony. Thank you.
Thank you.
Thank you for that, Senator Anwar. We have one more, actually. Yes. And
I appreciate
thank you. Oh, hold on one second, Rep. McCarty. Thank you so much for saying that, because I think we all share in our condolences and our sadness that you have lost a classmate and that so many people who we know and love have lost friends and family members. And Representative McCarty, who I am happy to be confused with so often.
Thank you very much, and please excuse me, but I too wanted to add my remarks because it's important for you to come forward and to really emphasize that no crosses over all age groups, and that it's even at a 13-year-old in your school. So I appreciate very much you coming forward, and I think having a deactivation kit available in the home, just as adding another layer of protection, is something that we can do. And again, I'm very sorry for the loss, but very appreciative that you came forward. Thank you.
Thank you.
Thank you, Representative McCarty. Representative McCarty has been a long advocate in working with students especially, and in working in prevention. So you have some really great allies here around this circle. Thank you so much for taking the time to be with us today. Next, we will hear online from James Crocker. Welcome.
Thank you. Honorable members of the committee, my name is James Crocker, and I'm here as a member of the Youth Advisory Board for the Governor's Prevention Partnership, but also here as a 16-year-old high school junior who has seen firsthand the devastating impact of opioid misuse and addiction on individuals and families within my community. I'm here to voice my strong support for Senate Bill 1, particularly Section 26, which addresses the co-dispensing of drug deactivation systems along with specific prescribed medication, such as opioids. This is a problem that hits close to home for many of us. Personally, I've witnessed my friends and classmates struggle with opioid addiction, often starting with the misuse of prescription pain relievers obtained from family members or friends. State Bill 1, particularly Section 26, proposes the co-dispensing of drug deactivation systems like doTERRA bags along with prescribed opioids. This simple measure provides a safe and discreet method for the disposal of unused medications, thereby reducing the risk of a diversion or accidental ingestion. By ensuring that these drug deactivation systems are readily available at the point of prescription, we can prevent the misuse and abuse of medication in our communities. Currently, many households struggle with proper disposal techniques for unused medications. While some communities offer drug take-back programs or provide information on how to safely dispose of medications at home, these options are not always accessible or widely known. Furthermore, there can be barriers to utilizing these disposal methods, such as concerns about privacy or stigma associated with seeking help for substance misuse. Passing State Bill 1 would change the landscape by making drug deactivation systems a standard part of prescription medication dispensing. This legislation would not only provide a practical solution to the problem of unused medication in our homes, but also send a clear message that preventing substance misuse starts with responsible medication management. In conclusion, I urge the committee to support State Bill 1 and its provisions for co-dispensing drug deactivation systems. By taking this proactive step, we can protect our communities, prevent substance misuse, and save lives. Thank you so much for considering my testimony.
Thank you so much. We're so thrilled and honored to have all of you students here joining us today. It's really wonderful to hear your voices. You said that oftentimes that there's a beginning with prescription pain relievers from family and friends is where people actually are receiving these drugs, where they're starting from. So a question for you. We're talking today about safe disposal. There are times when people need to have these medications in their home. And I'm wondering, because as this committee knows, I love our public service announcements. If folks have these medications in their home, what is a safe way to store them?
I mean, from my understanding, one of the most safest ways to store these medications is have a designated medicine cabinet. Sometimes, if there are children around, have that medicine cabinet have a lock to it so that it's not accessible to others and it's out of reach. But I think that further emphasizes the importance of Senate Bill 1, particularly the co-dispensing of drug deactivation systems, because while there are PSAs and signage telling consumers what to do, not everyone follows it, not everyone even sees it. So requiring the co-dispensing of drug deactivation systems like the deter system mentioned earlier would provide it for everyone, make it more accessible and easier just in general.
Thank you so much for that answer. Yes, I love the idea of having those medications stored safely in lock boxes that many of our prevention councils actually distribute. Representative Zupkis has a question or a comment.
Thank you. I would totally agree that, a lot of kids go in their parents' medicine cabinet. Sometimes you don't know if it's a friend of your kids, or it is very concerning. And I hear often that's how kids get addicted to it. So I'm very interested to continue to hear this bill and how we can kind of stop that, quite honestly. But I have one question, because y'all are students, and it's not on this bill, but opioids is a horrible thing for people that get addicted to them, and kids especially, well, anyone, but kids. And how do you feel about legalizing mushrooms?
Yes, it's definitely a very complicated issue, and I think it goes back to the systemic racism and injustice that occurred with the criminalization of weed and, well, marijuana, THC in general. But I think the most important thing is to acknowledge that while it's legal for those above 21 and it's illegal for those under 21, abuse still happens on a regular basis. And I mean, I see this happening in my school and schools all across America. And so I think that's why it's so important, the work that the Governor's Prevention Partnership is doing to prevent misuse and to increase education on the dangers of things like vape, marijuana, weed, pens, like that, because unfortunately, people still have access to it despite it being illegal. So that's definitely a loaded question, but I would say,
I didn't mean it to be, because I think this is all a huge concern, whether it's opioids, mushrooms, cannabis. Like, to me, it's all kind of in one, and it concerns me. I'm very concerned about people dying from opioids. I'm very concerned about what happens with this. So it wasn't meant to be a loaded question. I really honestly wanted to know your answer. So thank you, because I do put it all together But I appreciate it. Thank you.
Thank you. Seeing no other question or comments, Mr. Crocker, thank you for your testimony. Now you
Thank
can
you
do,
for having me.
you can do your homework. You don't have an excuse anymore. Next person on our list is Jamie Cavanaugh. Welcome.
Thank you so much. Good afternoon, Chair Anwar, Chair McCarthy-Vahey, Vice Chairs and distinguished members of this committee. My name is Jamie Cavanaugh, and I'm Legal Policy Counsel with the Pacific Legal Foundation. PLF is a national public interest law firm with 17 wins at the U.S. Supreme Court. And over the past few years, I've become a national certificate of need policy expert. So I wanted to provide some testimony in support of con repeal and hopefully answer any questions that the committee members have. I appreciate the robust discussion of certificate of need laws today. And I want to start by mentioning that 40% of the population of the nation lives in a state with 0 or only 1 certificate of need law. And the legislative trend around the country is that states are repealing their certificate of need laws, not adding to those burdens. And for the states that only have 1 certificate of need law, that's typically for nursing homes. So I want to make 3 quick points today. First, many providers, especially small and independent providers, give up without ever starting the con application process. So the numbers that we have of people who have actually applied for a certificate of need, whether they're denied or approved, that doesn't show the whole picture about who's interested in offering services. Second, the argument that healthcare doesn't operate in a free market doesn't support keeping con laws on the books. Now, of course, I agree that healthcare today doesn't operate in a completely free market. It operates in an extremely regulated market. But that isn't a reason to further distort the market or actively prevent providers from meeting their patients' needs. On the flip side, every single argument I hear for keeping certificate of need laws on the books is a market-based argument. Providers claim they're worried about losing profitable, privately insured patients. But if the existing providers offered great services, their patients would continue to use those facilities. And researchers who have taken the time to study this phenomenon have been unable to find evidence of cost shifting in the way that proponents of con argue. So even though healthcare doesn't operate in a free market, evidence shows that competition amongst healthcare providers improves quality for patients. States that have already repealed their con laws, because at one time every state had a con law, these states report higher quality healthcare and better healthcare outcomes. For example, states that maintain con laws have higher mortality rates for heart attack, heart failure, pneumonia, upper respiratory infection, influenza, diabetes, and COVID. Competition also improves the access to healthcare. This makes sense because certificate of need laws have been artificially suppressing the supply of healthcare facilities for decades. So of course, repealing those laws would mean that more facilities would open and patients would have greater access to care. States without certificate of need laws have more hospitals and more surgery centers per population. And this result holds up even if you isolate just for rural populations. So if con repeal caused hospitals or other providers to close, whether rural or urban, we'd expect to see fewer facilities in states that have already repealed con laws, states like California, Colorado, Pennsylvania, or New Hampshire.
Excuse me, Ms. Kavanaugh, but your time is up. Thank you.
Thank you very much.
Thank you
I'm
so
happy
much.
to provide the committee copies of any of the research I mentioned today.
Yes, we would really appreciate if you could send us some of the data because your testimony is important and it just gives a perspective that we need more data to support. Seeing no questions or comments, we move on to the next person on our list, who is in person here, John Brady. Welcome, John. Thank you for being here since this morning and afternoon.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Gladys Dietra, and members of the committee. First of all, I want to thank you for the service you give the people of the state. My name is John Brady. I'm a registered nurse and the Vice President of AFD Connecticut. Among our 30,000 members are approximately 8,000 healthcare members in hospitals, visiting nurse agencies, clinics, and schools, including our own Senator Martha Marks. AFT Connecticut supports SB 1, and I'd like to speak specifically to sections 1 through 9. The loss of two of our colleagues recently has been felt by all of Connecticut's residents. Healthcare and social service workers are 5 times more likely to experience workplace violence than all other workers. And this is despite general acceptance that workplace violence is underreported. Workplace violence can lead to PTSD, increased moral injury, burnout, turnover, all of which impacts healthcare quality and cost and recruitment and retention. Last year, this General Assembly took historic steps in passing safe staffing legislation, and many of you were involved in that heavily. This year, we must pass healthcare safety legislation. SB 1, along with SB 365, which is in the Human Services Committee, will strengthen existing statute. And I thank you for making that a priority. SB 1 deals with many of the dangers in the home care field, and SB 365 addresses some of those issues in hospitals and in nursing homes. Together, they form a package that will increase safety for both healthcare workers and patients and increase recruitment and retention. I'm going to save you going through step by step all the great things in this bill. We've talked about it enough today. And I think there's general acceptance of that. I think there's also a realization that there are problems in how it would be implemented, such as how to collect all the data. Please don't let those difficulties get in the way of having action this year, because it's critical that it be done now. People are in danger. To every problem that is brought up, there are solutions. If we need to get a healthcare worker in there immediately, as in the case of hospice, then maybe we have to send 2 people that time until a full assessment of the situation is done. My point is that to every problem, there's a solution, and we could do that. We've done it before. We did it last year with the hospital safe staffing. So I thank you for listening. I urge passage of this, and I'm here to help in any way I can.
Thank you so much, John, for your testimony and your commitment to making sure all the healthcare workers are safe. Senator Marks has a question or comment.
Yeah, thank you, John. And for all you do for healthcare workers. I would just say that I think we just need to make sure we shout it from the rooftop that this legislation will not protect the homemakers and companions working for the non-skilled agencies. And Otto Moreland died, doing 24/7 care. OSHA wasn't called. But there was a skilled agency in there as well. My agency I work for was in there as well. And for the probably almost 30 years now that I've been doing home care, I've always wondered when there are non-working smoke alarms. We ask on assessment, or you can hear it chirping. I'll say, where's that chirping smoke alarm? And I can't believe that the people can't hear it. I'd be crazy and have to fix it within 2 minutes. And I've always wondered, or if I'm on the 3rd floor of an apartment with a really long visit and there's no egress out of that 3rd floor apartment. These are things that we don't even really have specifics written in that bill about. And that is I'm going to keep saying it. It's somebody's home and we're doing home care, but that is our workplace. That is where we go to work, and we deserve to be safe, and not just the skilled, but also the unskilled. So maybe just, OSHA laws, nobody would go to work at somewhere that didn't have safe fire detectors or didn't have an egress out of, where you could escape. And I always wondered what would happen if I was at a place where there was a fire, and then it happens. And then it actually happens. I can remember I was out to dinner with my friends when I heard about this fatal accident, and I had just been in his house 10 days previous. And I was like, everything that I always knew could happen in home care has just happened twice in Eastern Connecticut. And I wonder how many other, the fact that it wasn't reported to OSHA, how many other times that unskilled home care workers have been injured or died, and it wasn't reported to OSHA. So if you can just, tell us what you think, OSHA law very well, and you've been listening to me for 25 years, and I'm sorry about that. It's finally, we're getting something done, and I'm very excited.
Thank you, Senator. Yeah, we've had OSHA guidance on workplace violence in healthcare for many years now, but it's guidance. It's not a standard. There's OSHA standards, which you would have like for chemicals in the workplace, where you have to have the sheets, the MSDS sheets. Those are enforceable by OSHA. OSHA guidance is a step before that. And we've never been able to get that over the finish line and to do it. And Joe Courtney's been a champion on this. And, we do have help, and we are lobbying that happened maybe even this year. But there's no guarantee that it will get through this year. And there's no guarantee what will happen in the fall and whether the next administration will be pro OSHA regulations or not. So I think Connecticut has a chance to lead the way, hoping that OSHA standards do get put in, and then we have real protection for all healthcare and social service workers. But if that doesn't happen, or even if not, we should lead the way. We have a pretty great state in many ways, and I think it's a place where we could set an example for the country.
I agree 100%. I think working smoke detectors is a pretty easy place to start.
Thank you. Thank you. Oh, Representative Daphne.
Thank you, Mr. Chair, and thank you, John, for being here today. Certainly is a complicated issue, and I think the simplicity of it is that we do need to protect our workers. So I totally agree with you there. We don't always agree, but I agree with you there. But you said for the immediate response, perhaps because it's complicated and we're going to have to work through this, maybe have 2 people go. But I was thinking of the staffing shortage we have. And we have such a staffing shortage. I don't see that as being realistic either. And now we're talking about OSHA and fire alarms in people's homes. So it gets complicated, really complicated. Did you have any other ideas that you were thinking might be viable?
Thanks, Representative. My representative, by the way, and a nurse. So when we say that maybe if one of the concerns was if you needed to get a nurse out right away, you wouldn't even have that 48 hours to collect the data if you could get it within 48 hours. And you can't wait in some cases. You need to get somebody out there. And I think that's why it's important if we can bring back the funding for agencies for an escort. That might be the perfect time to send an escort. It doesn't need to be even another healthcare provider, but another person going in with the nurse or on that first visit until that background check, whatever it ends up being, could be done. I mean, that was just one example of a problem, but there are solutions to it.
No, I was just talking to Representative Zupkis and explaining, because I did home care for years too. And, I was explaining this scenario where you get discharged from the hospital and sometimes you need immediate care the next day. And sometimes it goes on daily, depending on what the treatment is. And sometimes it ends in a week. So by the time we would get background checks on some people, that could be long over. So it is a complicated issue, but I thank you for being here today and testifying.
Thank you. Seeing no other, Senator Marks again.
Yeah, just one more thing. What is your thoughts on increasing safety, increasing support, increasing training, knowing that the nurse and aides and homemakers companions, all those social workers, PTs, have the support of their employer? Will that help burnout? And will then maybe more? Right now, we have a nursing shortage because 50% of our nurses aren't working as nurses. That if they felt they were in a safe working environment, we might increase the workforce.
Yeah, absolutely. I think the 2 things I hear the most as far as the recruitment and retention problem, especially the retention problem is it's not that there's not enough nurses and other healthcare professionals out there. It's that there's so many of them that aren't willing to work under the conditions they are. So they find other things. They have other options, you know. Yeah, I think increasing staffing, which we addressed last year and we're still working on, is one of the big things I hear, and the other one is safety in the workplace. People are afraid, are tired of getting beat up. I mean, your comment that what nurse hasn't had a gun pulled on them, kind of like you made that rather quickly. It's pretty amazing, you know? And who wants to go into that profession? If you want to go in that profession, you probably became a police officer, you know? So those are the two things, workplace violence and staffing, that will help with recruitment, retention, and burnout.
Thank you. Mike Coachman.
A quick comment. Thank you so much for being here with us. I needed to step out to vote in another committee, but I'm looking forward to continuing to work with you. You've been such a great partner on so many of these issues and such a great voice for the nurses of our state. So thank you.
Thank you. I mean, this committee proved last year, you know, in a bipartisan way, what can happen. And, you know, great leadership, both sides of the aisle, including my senator, who is not Senator Marks, it's Senator Summers.
Thank you so much. I was going to see maybe her hand will be, but she's probably in a different meeting too right now. But thank you for everything that you do and what you represent, and we will have multiple conversations, and perhaps this year too, we'll be spending more time than we did with our families in the committee bills. Seeing no other questions, we'll move to the next person on our list, who is in person over here, Zach Hardy. Welcome.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and members of the committee. My name is Zach Hardy, and I am a State Government Relations Officer for the Michael J. Fox Foundation for Parkinson's Research. Thank you for the opportunity to testify today in support of SB1, specifically Sections 33 and 34, which will improve the livelihood and health outcomes of people living with Parkinson's disease. The Michael J. Fox Foundation for Parkinson's Research was founded in 2000 and has been singularly dedicated to finding a cure for Parkinson's disease through an aggressively funded research agenda and to ensuring the development of improved therapies for those living with Parkinson's today. To date, the Fox Foundation has funded nearly $2 billion in research programs worldwide. The foundation strongly believes that governments must invest in initiatives aimed at developing strategies to address the impacts of neurodegenerative conditions, including Parkinson's. Section 33 includes a directive for the Department of Public Health, in collaboration with the Office of Health Strategy, to establish a Healthy Brain Initiative, which will strengthen policies concerning the prevention and treatment of health conditions affecting the brain and utilize data on these conditions to guide further policies to support patients and their caregivers. A crucial aspect to ensuring that the necessary data to analyze Parkinson's exists is supported by Section 34, which will establish a statewide research registry for the disease. This registry will help fill a gap that presently exists in Parkinson's research, while providing additional data that will produce more accurate statewide statistics on incidence and prevalence of the disease. A population-based registry is necessary to generate the basic data that will help researchers, treatment providers, and lawmakers determine the causes of the disease, evaluate the efficacy of treatments, uncover inequities in healthcare, and make decisions about the allocation of resources for prevention and treatment of the disease. This data will help identify high-risk groups, support patient contact studies, and serve as an invaluable data resource to the research community. The information collected by the registry will fuel research that seeks to discover more effective treatments and therapeutics for Parkinson's. By passing this legislation, Connecticut would be joining California, Maryland, Missouri, Nebraska, Nevada, Ohio, South Carolina, Utah, Washington, and West Virginia, and establishing a research registry dedicated to Parkinson's. According to the Centers for Disease Control and Prevention, Parkinson's disease is the second most common and the fastest growing neurological disorder in the world. There are an estimated more than 1 million Americans currently living with Parkinson's, with about 90,000 more diagnosed each year. The national cost associated with Parkinson's is approximately $52 billion per year, with that cost projected to rise to nearly $80 billion by 2037. The direct and indirect cost to care for the more than 12,000 people living with Parkinson's in Connecticut, which we believe to be an undercount, is estimated to be $617 million per year. The discovery of improved treatments and therapeutics and ultimately a cure for Parkinson's will not only change the lives of those living with the disease and their families, but would also be in the economic interest of the state. So on behalf of the Michael J. Fox Foundation and the community that we support, we urge swift legislative action on SB1. Thank you for your consideration, and I'm happy to answer any questions.
Thank you so much for your testimony, and thank you for the advocacy that you've done. There are a lot of very organized group of advocates in our state. We have a Connecticut Coalition to End Parkinson's that are going to be part of this effort as well in one of the sections. The question I wanted to ask you was, there will be some funding needs that we will have for Healthy Brain Initiative. There will be some funding needs, and the state budgets are very tight. Are there foundations that are out there that can help us out? Are you aware of?
Yes, so thank you for the question, Senator. There are opportunities that we have seen specifically with the registry bill that we have, engaged with in several states when it comes to funding mechanisms, because that always is a concern. We understand fiscal considerations that go into these types of provisions in the bill. So whether that be through other organizations, I can say on the record that the foundation has been involved in certain funding aspects of registries, particularly in their infancy, because we believe so strongly in these registries. We know that they are critically important. We hear from the research community over and over again how there is that gulf in data that exists. So we're happy to engage in those conversations. What's important to remember is that once these registries are up and running, it will take anywhere from a year or 2 years to actually have enough data so that the researchers can tap into it for contact studies. So the sooner we can get them up and running and legislatively approved, the sooner that we can see some real results in the research community. So I'm happy to engage further on that, but correct to point out that there are fiscal considerations to have with this registry, and more conversations to be had on that.
Perfect, because we will be in our infancy, so we will be calling you.
Of course, we will answer them.
My co-chair.
Thank you so much for that, Senator Anwar, and thank you for being here today. And I'm excited and grateful that we're having this conversation with you and others. And you answered in part one of my questions in terms of referencing the other states. And because you do state government relations, I'm wondering what other pieces of legislation that you've seen in other places around the country that you think it would be important for us to look at as a complement to what we're looking at today.
Thank you, Representative. I appreciate the question. And actually, it was just last week that I testified on another bill that is before the legislature this session pertaining to biomarker coverage. We see that as an incredibly important issue that has sprung up in state legislatures across the country in the last 2 years, because biomarkers are incredibly important in a Parkinson's patient's journey from diagnosis to further treatment. They help guide medical decisions with physicians and patients of what treatment could best help them throughout their in our purposes, their Parkinson's diagnosis. We've made a lot of breakthroughs in biomarkers. Just last year, the foundation announced that we have discovered a new biomarker for Parkinson's that again can just really help rule out potentially unnecessary treatments that an individual may have to go through, because unfortunately today there is no one therapeutic for Parkinson's disease. It's an incredibly individualized disorder that folks have to deal with, and sometimes it is that trial and error of trying different therapeutics to see which one helps them the best with their symptoms. So biomarker access is an incredibly important topic for us, as well as genetic testing protections. When it comes to insurers, particularly when it comes to life insurance, long-term care insurance, and disability insurance, there are federal protections against genetic testing results being used in terms of denying coverage or increasing premiums as it pertains to healthcare coverage, but those do not extend to those other subsets of insurance coverage: disability, life, and long-term care insurance. So that's another issue that is incredibly important to the community, as they often have to consider those additional insurance coverages. So it's something that I would certainly, I'm not sure what's on the books potentially already in the state, but it's something I would certainly encourage this committee to take a look at as well.
Thank you. I very much appreciate that. I think it's Senate Bill 307 and for the biomarker coverage that you're referring to. And
That is
I
correct, yes.
appreciate you referencing, you're not sure what is on the books, but those are helpful answers. Looking forward to working together. Thanks, Senator.
Thank you. Seeing no other questions or comments, we want to thank you for being here, and you will be hearing from us.
Thank you very much.
Thank you. Next person on our list is Lucy Nolan. Welcome. Thank you for being here with us throughout the day.
Thank you for having this hearing. That's actually been very, very interesting. So I don't usually get in front of public health. My name is Lucy Nolan. I am the Policy Director at End Hunger Connecticut, a statewide anti-hunger advocacy, outreach, and assistance organization. And I would like to speak today on HB 5003, an act concerning child and family nutrition. So I just want to say right off that according to the 2015-2022 Data Haven Wellbeing Survey, adult food insecurity, which is not having enough money to buy food, nearly doubled in 2022 from 2021. However, in 2021, families with children had 12% food insecurity, and it leapt up to 23% in 2022. So it's really, since all the pandemic relief programs and even more of them have gone away, are really affecting families with children. So these federal food programs really play a pivotal role. SNAP is the defense, nation's first defense against hunger. And WIC is a prescription program that is to, serve our children under 6, their mothers who are either pre or postnatal. And it is an incredibly important program. In Connecticut, the recipients of SNAP, TFA, or Husky are automatically income eligible. Given the new SNAP guidelines, eligibility at 200%, it does not go the other way. So I think that's something we need to look at when we're talking about putting the programs together. WIC is not an entitlement program, and SNAP is. WIC is out of DPH. SNAP is out of DSS, as we all know from today. But what we see around the country and is this adjunctive eligibility, which we do have in Connecticut, but so DSS could share the WIC information with DPH, who could then use texting, mail, or phone calls to contact people that are eligible for WIC. That's what other states do, and I put in my testimony a link to some information about that. I think it's important to also know that DSS does that with SDE. They let them know for schools to know who's on SNAP so that they can figure out categorical eligibility. So it is happening. It does happen. I did give you a lot of stuff about what we do, but I just wanted to say that one thing that I really find missing in this is any community-based organizations or any organizations who work with WIC people or with WIC participants, SNAP participants. We work with double SNAP in the farmers markets, in 40+ farmers markets. And so, you have a wealth of advocates and other organizations who know the people, they're culturally in tune with the participants, and they should be part of these decisions. I really feel like we should have a role in this, and it should be in the legislation. Otherwise, we may not get a role in it. So,
Excuse me, Ms. Nolan, but your time is up. Thank you.
Thank you. Just to sum up, I just want to say, I also think Section 4 is very important, that when kids get off WIC, that they see if they can get into SNAP, because as I said, if kids are on SNAP, if their families, they get free or reduced price meals. They'll get free meals at school automatically. And as we know, that's really another critical in child nutrition program that I personally, and you have all have fought and worked on getting no-cost school meals in Connecticut because how important it is for our kids. So thank you.
Thank you so much for your testimony, and thank you for the work that you do. Your points are well taken about having a broader group of people weigh in on this. You heard from DSS earlier. There was a bit of a hesitancy about communication and data sharing information. Do you want to be able to speak to that? And do you know of models where this is happening seamlessly?
Well, there are, and I did, as I said, I do have it in my testimony. There's the Center for Policy and Budget Priorities did a WIC coordination with Medicaid and SNAP, and it's a whole report. The one thing that we do have in Connecticut is because of the pandemic, WIC people can apply for WIC online. People can apply for SNAP online. So what DSS could do, and it sounded like maybe they would think about it, is to have an eligibility question, which would then shoot people over to the DPH website and they could fill it out, because if they have SNAP or TFA, they're automatically eligible for WIC. So that would be one thing that they could do. I hesitate to ask DSS to put another program in their eligibility because we do SNAP assistance and there's some problems there. And I hate to add more things to them so that people won't be getting benefits because they can't get through.
Thank you for that. And then I can just mention that this bill may need a little bit more collaboration and coordination. And I'm sure after this public hearing, we will reach out, our team members and the people who are advocates will be reaching out. Do you know if SNAP enrollment also enrolls people who are WIC enrollees?
So that's not, because SNAP, the eligibility is at 200% of the federal poverty level and WIC is at 185. It can go from SNAP to WIC, but not WIC to SNAP.
But at your center?
Oh, at ours? We have not actually, that isn't, it's a funny thing because WIC has never been, because it's DPH, it's considered a medical, there's different people who do it. We have not been doing outreach, but we would be happy to on WIC, especially if there's going to be this cross collaboration.
Good. This is helpful. Seeing no other questions online or comments, we thank you for your testimony and for being here with us.
Thank you very much.
Thank you.
Appreciate it.
Next person is online, which is Dr. Thomas Farquhar. Welcome.
Hi, Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Claridis Dietra, and members of the Health Committee. My name is Thomas Farquhar. I'm the president of the Radiological Society of Connecticut. Our membership includes over 300 radiologists, which are physicians with over 4 years of specialized training in performing and interpreting imaging for medical diagnosis and treatment. I wanted to thank you for the opportunity to submit comments on 2 bills before you today, Senate Bill 440 and House Bill 548. I'll start with House Bill 5488, an act concerning various revisions to the public health statutes. Section 10 would add advanced practice registered nurses to the statutory language that currently involves physician assistants to perform fluoroscopy procedures. We have concerns about this, specifically after undergoing the required training and supervision and a test, physician assistants are able to use fluoroscopy, but they're never able to practice independently. Whereas an APRN with sufficient experience would be allowed to practice fluoroscopy completely independently. And we do not believe that this increase in the scope of practice for an APRN should be changed to allow independent practice of fluoroscopy. And as such, we would suggest striking Section 10 from the bill. Regarding Senate Bill 440, an act concerning certificates of need, we have concerns with the inclusion of the phrase, it's Section B, upgrades to radiologic technology, that's on line 170 in Section 26, and creates the 6-year moratorium on CON. And our concerns lie that the phrase upgrade and radiologic technology are not adequately defined. Radiologic technology could include just about anything from the voice recognition systems we use, the picture displays, computers that we use, ultrasound, X-ray, or mammography. And so we would worry that the day after the moratorium ended, June 30th, 2030, this would suggest that CON language could apply to those modalities. The other is 6 years is a long time in our profession. So we actually have no idea what equipment using technology to image the human body might be available 6 years from now that would be completely exempt from CON. The other term is regarding upgrades for advanced upgrades. So currently, advanced imaging equipment like CT, MRI, and PET that are covered by the CON statute, they're often eligible for what you'd consider to be an upgrade as the technology improves. And that's a good thing because it improves quality and safety for the care that the patients received. And usually this is just kind of a software update, similar to what you might do with your phone. And it doesn't require the involvement of the CON process. And so the term upgrade is already outside the CON process in that sense of the word. But for cases where a new machine is purchased, we believe these are already included in language elsewhere in the bill under replacement of existing scanners. And so for this reason, we would suggest removing section 26B on line 170. And in closing, I'd like to thank you all for your hard work on behalf of the patients and citizens of Connecticut. And again, thank you for considering our comments from the Radiological Society of Connecticut on these two bills. We would be happy to engage in a dialogue with you in the coming weeks as the bills receive further consideration. Thank you.
Thank you for your testimony. Did not get a chance to look. Did you have a written testimony as well?
It was submitted online, yes.
Okay, with some of the changes that you're suggesting?
Yeah, exactly, with the specific references. Yep.
Okay.
To the line
Appreciate
numbers.
your insight. This is very helpful. Thank you for your testimony. Seeing no questions or comments, we'll go to the next person on our list, which is Regina Stankaitis. Welcome. Thank you for being here, Regina. Thank you for being such an important advocate and staying with us the whole day.
God love you that you stay 7 hours.
Oh, we are just getting warmed up here. We're not even done through the first page.
Good afternoon, Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Regina Stankaitis. I'm a person with Parkinson's. I am here today to ask you to support Senate Bill number 1, sections 33 and 34, an act concerning the health and safety of Connecticut residents. You've heard from my colleague Zach from Michael J. Fox organization. You will be hearing from several doctors who are involved with movement disorders. I think it's important for you to hear something from a person who does have Parkinson's. The symptoms of Parkinson's and its rate of progression are different for each individual. Having Parkinson's disease is not only a physical problem, but it's also a psychological one. Depression and other emotional changes take place. Having your dreams dashed and seeing your health deteriorate is devastating. As the disease progresses, knowing what your future may be takes away your will to live and to fight the disease. I was diagnosed in 2014. My symptoms appeared earlier, but I didn't pay much attention to them. When my facial expressions started to change, my right arm didn't move when I walked, and my upper body became rigid, my doctor referred me to a neurologist who tested me and informed me that I have Parkinson's disease. I was in disbelief, I was in denial, and I felt like I received my death sentence. All my plans for my future suddenly changed. When I was younger, I was an athlete. I actually played basketball for UConn and competed in many other sports. My coordination has been affected that I have difficulty holding a basketball, cannot even dribble, much less take a shot. Today, I cannot run and I can barely walk. I was a golfer and I plan to retire and play golf. Today, if I swing a club, I fall right over. I was a lifeguard when I was younger. This past summer, I slipped into 2 feet of water in a swimming pool and couldn't get up. I almost drowned. I cannot go to any sporting events or concerts where there is a stadium seating because I lose my balance and I fall.
When I began falling down and hitting my face on the pavement, I was scared. I would scrape my face, my arms, my legs. At first, I thought I stumbled and was clumsy, but I kept on falling. Even inside my house, I had fallen up to 7 times a day. I was bruised and I looked like I was in a fight. I began noticing that I was moving slower. I was having difficulty getting in and out of cars. My body has changed. I'm more rigid. My posture is bent, and my speech is affected. I feel that I'm a person trapped in somebody else's body. Because I could not climb stairs, I had to sell my house and move into a ranch. It's only a matter of time before I won't be able to stay there. Parkinson's is a terrible neurological disease. There is no cure for Parkinson's, but we need to try. Please consider Senate Bill number 1, sections 33 and 34, and act concerning the health and safety of Connecticut residents. It's too late for me, but please think of all the other residents in Connecticut who you can help, okay? So that
Excuse me, Ms. Dankaitis, but your time is up. Thank you.
I know it's
No,
so they won't have to live their lives as I do mine. Thank you.
thank you so much. I wanted to just ask you a question. Do you want to say anything else?
No, what I want to say is please help. You know, please pass the bill, and there'll be an awful lot of people that will be happy in the state of Connecticut.
Thank you for your leadership. You have been an enormous help. You've been a great advocate. You have raised the awareness for this legislative body, but also to individuals that you have spoken to. So this bill is happening because of all the work that you have done. And I want to thank you for that.
I thank you both too.
Representative Kristen McCarthy-Vahey.
Thank you. I'd like to echo Senator Anwar's words. You have been very persistent, which is wonderful. And when we hear that 12,000 people in Connecticut are living with Parkinson's, it's really important that we address this, especially for the reasons that you shared, which is that Parkinson's disease manifests itself so differently in people, which makes it very challenging, I think, not only for those living with Parkinson's, but also for care providers as well. And I just thank you for taking your story and taking the pain and the struggle that you have and turning that into something that is advocacy for others. Thank you so much, Regina.
Thank you.
Thank you, Representative Kennedy.
Thank you, Mr. Chairman, and thank you, Ms. Dankaitis, if I said that correctly.
You said.
So I've only been in this room for about an hour. I was upstairs for 5.5 hours, I think. But I just wanted to tell you, thank you so much for sharing your story with us. And truly from my heart, I think you look terrific. And you just keep fighting the fight, and we'll hopefully do what we need to do on our side. So thank you so much for coming
Thank you
here
very
today.
much.
Really, really appreciate it.
Thank you all.
Thank you, Mr. Chairman.
Thank you. Seeing no other questions or comments, we will move to the next person on our list online, which is Dr. Michael Conair. Welcome, Dr. Conair.
Can you hear me?
We can hear you, but we cannot see you.
You can't see me. That's unfortunate. I will need.
Do you?
I'm on. I have.
Why don't we just listen to your
Okay, very good.
Thank you.
Honorable co-chairs, ranking members, Senator Summers, Deidre, and members of the Public Health Committee. I am Dr. Michael Conair, the last solo practice orthopedic surgeon in South Central Connecticut. Most of my 70+ local orthopedic colleagues are employed either by hospital university healthcare systems or large groups. I'm also an executive board member of the Fairfield County Medical Association, the past president and board member of the Connecticut Orthopedic Society, and I am the physician vice president of the National Union of Hospital and Healthcare Employees, which is part of AFSCME. I speak today in support of Senate Bill 1, specifically in favor of Section 28. Through this language, Connecticut will finally be able to be in compliance and consistent with federal labor laws. It is important to remove ambiguity from the laws which give rights to employed physicians to effectively organize to provide the best care for their patients. Connecticut's physician demographics have drastically changed over the last 2 decades, from primarily private practice to an employment model for the majority of Connecticut physicians. The new healthcare landscape is complex and rife with challenges, from physician burnout to inadequate and uneven patient care. Within this complex new environment, physicians remain the cornerstone of healthcare delivery, and yet they often find themselves at odds with the very systems that they work within. Physician employment contracts dictate not only the salary, benefits, and working conditions for a physician, but also the manner in which patient care is provided and the quality of the patient care. The majority of these contracts are unilaterally imposed by the employer with little or no negotiation possible. That's why physicians should be permitted to collectively bargain under the supervision of the National Labor Relations Board. This will shield both patients and physicians from financially motivated shortcuts by healthcare systems. Good faith collective bargaining between physicians and employers would address all contractual issues, including long working hours, protecting professional autonomy and ethical standards, assuring sufficient staffing levels and access to essential resources for patient care, and measures to to reduce burnout and turnover rates amongst physicians. Depression, burnout, and suicides are a huge problem. Constructively and cooperatively addressing these issues via a traditional collective bargaining mechanism will benefit the physicians, patients, and the healthcare system as a whole. By empowering physicians, they become more influential stakeholders with louder voices in driving positive changes within the healthcare system as it continues to transform. Connecticut trains many physicians, yet has difficulty attracting and keeping practitioners. Empowerment of employed physicians to collectively negotiate with employers will improve the desirability of Connecticut as a place to live and practice quality medicine, as I chose to do and have done so for decades. I urge the members of the Public Health Committee to support this concept and Senate Bill 1. Thank you for the opportunity to address you.
Thank you so much for your testimony, Dr. Conair. I just wanted to make sure that we repeat something that you said very eloquently, which was that this part of the bill is going to bring Connecticut in compliance with the federal law. Is that what you said?
Yes.
Can you expand on it a little bit, please?
Yes, the federal law already deems physicians employed for the large hospital systems and groups suitable for organization under the National Labor Relations Act. Connecticut, under its Connecticut labor laws, has selected out physicians to be, if I might phrase it, special employees, and therefore not entitled to use the benefits of the NLRA. And that is contradictory to the intent of the NLRA. Now, if docs were to organize, there would be state action, perhaps, based on the state labor laws, and the federal laws. It would remain to be seen whether they would prevail or not. But it's, I think, most important that the body of law, both in Connecticut and nationally, is consistent, so that physicians may indeed benefit from the NLRA, because they are becoming yearly more and more and more employee-like and less independent and professional, and there really isn't a reason why they should be excluded from these benefits. It benefits both them and their patients.
Thank you so much. Representative Terciak, you had a... Yeah.
Sorry, I was just mouthing a comment, but as long as you said my name, I like the idea of the National Labor Relations Act and Labor Board for everybody, but for physicians too. We already have the Connecticut Medical Society, the AMA, individual societies for individual specialties. I'm surprised to hear you say that we're not allowed, that physicians aren't allowed to unionize. I'm sure you're right. But in Connecticut, the physicians who work for the state of Connecticut, like at CVH or in community clinics, they are members of a union. So I don't know why it should be different for the private sector. And if it is, we have a committee that could look at that, maybe make a change. Thank you very much for the time.
Thank you so much.
Thank you.
That was more of a comment, so I appreciate that comment and it's useful. Seeing no other questions or comments, thank you, Dr. Conair, for your work and your advocacy, sorry. Chris Pankratz.
Thank you. Good afternoon, Chairs Anwar and McCarthy Vahey, distinguished members of the Public Health Committee. My name is Chris Pankratz, and I'm resident of South Windsor. I'm the Chief Executive Officer and co-owner of Masters in Home Care. We are a licensed and certified home health care agency specializing in providing skilled medical services in the home to the growing older adult population for the last 10 years. I have personally been in the home health care industry here in Connecticut for over 20 years now. I'm testifying on SB 1, specifically sections 1 through 9, but with respect to time, I'll comment on sections 1 and 8, and I have submitted written testimony on all sections. The reason we're all here today is because we share a common goal of improving the safety of our workforce as a top priority. And the proposed legislation represents a well-intentioned effort to lay the foundation for improved safety measures. However, the items in Section 1 are simply not practical to implement as drafted. Section 1 outlines the information we as providers would be required to collect at intake. While having all this information is ideal from a safety risk assessment perspective, the challenge is we simply have no way to obtain that information today. Additionally, as others have spoke prior to me today, identifying others in the home to the level of detail needed to obtain the information has significant privacy and potential HIPAA concerns since we're not providing services to those individuals. It would also create immeasurable delays in the process of admitting a patient and providing care. As you know, delaying treatments that are ordered by a physician for us will negatively impact a patient's clinical outcomes and their satisfaction. I would respectfully ask that you permit us to continue to make reasonable efforts to retrieve that information as outlined while promoting agency and industry-developed risk screening procedures and tools, and charging the work group identified in Section 8 to collect and report on trends so that we can make practical, data-driven, and informed recommendations back to this committee. I strongly support Section 8 as a collaborative, roundtable effort to lead to better informed decisions and the proliferation of best practices. And related to my comments on Section 1, I would suggest that consideration be given to other state departments and agencies, which might include Department of Corrections, Department of Public Health, and any other department or agency that could provide insight and access to the required data and systems, and to securely provide that information to us providers. Lastly, funding must be embedded into any safety initiatives in such a way to fully cover the implementation and sustained use of those tools, resources, or processes to improve the safety of our workforce. Thank you for the opportunity to provide testimony today, and I ask that you consider my perspectives as a home health care provider dealing with the very challenges that the legislation is intended to address. I welcome any opportunity to work with you to arrive at legislation that meets our mutual objective of enhancing the safety of our workforce and keeping both our staff and community patients safe. Thank you.
Thank you, Mr. Chris Pankratz, for your testimony. I have, well, first of all, great to see somebody from South Windsor. So, thank you. You have a
Thank you.
beautiful town. Who was your mayor? Sorry. Senator Marks.
Thank you, Chair. Thank you, Mr. Pankratz. Are you a nurse or a medical training in healthcare?
I am not a nurse. Nope, I'm on the operations and financial side.
Okay, so since the two deaths of healthcare workers, home care workers in Eastern Connecticut, have you changed any of your practices at your agency to improve safety of the workers?
We have, actually in October, prior to the incident, we had hired a social worker to come in and perform mandatory de-escalation in service for all our clinical staff. And after the murder, we have worked on implementing a pre-visit safety questionnaire. So we identified questions that we have now automatically set up for clinicians prior to the first visit to a patient. And they include a number of the items that the legislation references, such as other people that may be present, other people who normally live with the patient, are there weapons, those sorts of questions. And we look at the risk assessments. So we actually have integrated into our assessments as an accredited provider as well. We've got a number of items in our assessment at the visit regarding the safety of the environment. Because as you know, Senator Marks, when you walk in, you never really know until you're there, what are the issues? Is there a working smoke alarm? Are there trip hazards? Is the bathtub safe for the patient? So they have to assess a number of items while they're at the home as well.
So if there is a weapon or gun in the house, I'm assuming intake asked those questions, or if there's a dog in the house, then what's the next step? Or if there's not a working smoke detector, what are the next steps for those three scenarios?
Sure. So we have follow-up questions to that. And just to clarify, we don't actually place that with intake. We put it with the clinician that's going out to the home. Because as part of their normal course of duty, they're going to be calling to validate that, and notify the patient they're coming out. It might be the same day. And let's say they ask about the animal question. They say, do you have any animals? If they do, then the follow-up is, can those be restrained? And the same thing for weapons or firearms. If there are weapons if there are weapons present in the home, are they secured and out of sight? To your point, so they're not, visible, so there isn't, they're not laying around or under a couch cushion. And we're reliant entirely on the patients honestly responding to those questions and, and their understanding of the questions.
Thank you. And then is there anything in the admission packets that says if there are animals in the house that they have to be restrained, or if there is a gun in the house that it does have to be locked away? I mean, the dogs is huge, the dog issue, which I know, and I know most managers want the dog to be restrained because so many of us get bit by dogs, and then you don't have somebody to work. Any of that in the admission packet?
I'm not positive to what detail that's outlined in the admission packet, but I can tell you that I agree with you 100% on the dog issue. It seems to be an increasing problem. And sometimes the dog is restrained and the dog, gets out of a door, or they haven't really put the dog away fully. The staff is supposed to wait until the dog is restrained prior to entering the home. But it certainly is an issue. And we try to communicate, as you referenced in some earlier testimonies, that the question of asking about a weapon or firearm can be controversial to certain people. And even asking that question in of itself, we have to be very careful and very, very sensitive and explain why these measures are important to keeping our staff stay safe in their home.
Yeah, I thank you. And I do think things are going to get better and that they already are. So appreciate your answers, and I'm excited for all of us to work together to make it better.
Thank you.
Thank you. Seeing no one else, we thank you for your testimony. Moving on to the next person on our list, which is Dr. Adam Kay. Welcome.
Hi there. Sorry, I guess I went a little early and I'm just getting my camera set up here.
We can hear you, but we cannot see you. Oh, we can see you for, yeah. Now
there I am. Okay, so Dr. So Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claritas, and members of the Public Health Committee. Thank you again for allowing me to talk. My name is Dr. Adam Kay. I'm a partner at Advanced Radiology Consultants in Shelton, Connecticut, and I'm currently the chair of radiology at St. Vincent's Medical Center. I'm speaking to you today as my colleague, Dr. Thomas Farquhar, did on regarding two issues. First, regarding House Bill 5488, as Dr. Farquhar eloquently put, we're asking to strike Section 10 from the bill. Us radiologists spend 4 years of residency on top of our years of medical school, our years of an internship, our years of subspecialty training, and years of experience in practice, learning and perfecting the art of fluoroscopy, which is live X-ray. We use it for diagnosis as well as for procedures and treating things like excess fluid in the lungs or the body and treating things like cancer. Our physician assistants utilize fluoroscopy as well. And yes, they go through similar radiation safety training as is proposed here. But most importantly, they utilize fluoroscopy under our or other physicians' supervision. And also, our radiation technologist colleagues, as Mr. Hicks, who testified earlier today, did so elegantly, they do so as well, but under physician supervision. Allowing APRNs to operate fluoroscopy without the supervision of physicians would be potentially harmful for our patients for the many reasons you've heard. I'm happy to elaborate more if you need it, but you've already heard Dr. Farquhar and Mr. Hicks testify excellently on this. I'm also here to comment on Senate Bill 440 regarding certificate of need. And just to expand on Dr. Farquhar's statements, as you've heard me say before and him say before, states that eliminate certificate of need are faced with increased, not decreased costs. And I know that you've seen testimony to the opposite, but we, as I've said before, we have evidence in our neighboring state of Rhode Island where we saw the elimination of certificate of need lead to increased costs in the form of many times in the form of things like self-referral, where you have non-radiology providers owning their own equipment, referring to themselves. When you own your own scanner, you are much more likely to want to send your patient there and potentially get imaging that if you didn't have your scanner in your backyard, you might have otherwise foregone. And so it can lead to inappropriate imaging, which leads to increased costs for us all. We do support the goal of reviewing the existing CON process and identify areas of improvement for efficiency, effectiveness, and alignment with state and federal healthcare reform efforts. And we are all for making the process better. But I think that we believe that throwing out the process would be harmful to patients and harmful to patient access and and the affordability of care in Connecticut. I am happy to yield my time to questions if there are any the rest of the time. So
we do. Thank you so much for your testimony. I have Representative Kristen McCarthy-Vahey, followed by Representative Denning.
Thank you, Dr. Kay. I just wanted to say hello and thank you for your consistent advocacy. You've joined us at many of these hearings, and I actually look forward to seeing you in Fairfield later in this session or after session is over. Thanks, Senator Anwar.
Absolutely.
Thank you, Representative Denning.
Hi, good afternoon, Dr. Kay. Thank you for your testimony. Can you explain to me when you talk about supervising or under your supervision used for a physician assistant using X-rays?
Sure. Yeah. So, any physician assistant that provides care and at least in our practice, and I believe that this is everywhere, needs to be supervised by a physician in the form of a physician being present, being available for any issues that arise during the procedure, and being frankly responsible for whatever happens during that procedure, right? So we have excellent PAs here in our department just outside my door here. They're doing procedures as we speak. We also have an interventional radiologist here who is supervising them and making sure that they have the support they need to provide the care at the level that's appropriate for them and practicing sort of within their license, right? What we worry about with what I've heard so far today, what I worry about with APRNs is that that if they are able to, after I believe it was 3 years, I don't want to speak incorrectly. I believe it was 3 years though. If they can go off and start doing fluoroscopy on their own, they don't have the same level of supervision for this important technology and this life-changing technology. But frankly, sometimes can be in the wrong hands dangerous technology if somebody is stepping on that fluoro pedal and providing live X-ray. That's more and more radiation. And we're there as the radiologists who are trained in the physics of this to supervise our PAs and our radiation technologists and our radiology assistants to make sure that they're utilizing it appropriately. But we like to control that and make sure that it's being practiced in a safe manner.
So when you're supervising them, you're in the room with them.
We are on site and available. Yes, they are either in the room or in the adjacent, in the adjacent room in the.
So would you know if they were stepping on the pedal continually by accident?
If you're watching somebody do fluoroscopy, you can tell if they are stepping on the pedal inappropriately. Yes, you can. If somebody has their foot on that pedal too long, you can you can see it happening in front of you. Correct.
Yeah, but when you're supervising, you may not be in the room with them, so you wouldn't be able to see that anyway.
Well, if you're in the control room, you can see it. If you're not in the room, and if there are, we have quality and safety measures that we utilize for our PAs to make sure that they are staying within safe radiation limits. Right. We monitor fluoro times. We for not just our PAs, we monitor them for our radiologists as well.
So
just to make sure that they are not overutilizing radiation. We have radiation safety committees that do that too. So
I'm a nurse anesthetist, and I not use fluoro directly, but when we put lines in, we have with an anesthesiologist in the room, and I've seen fluoro used. But my question is, a nurse using fluoro would be monitoring the same fluoro times that you would be monitoring. A physician may or may not be in the room with her, depending upon the supervising. And I'm just not sure that you've convinced me that your supervising prevents the kind of errant activity that you're hoping to prevent.
So I guess I would say, I'll give you a situation, right? Let's say a PA is doing a procedure, okay? And they're utilizing fluoroscopy. And that procedure involves putting needles into patients. It involves draining cavities in the body. I'll try to keep it as non, I don't want people losing their dinner, but so if a PA feels that they are uncomfortable with what's going on, there's a physician available for them to go help, to go ask for help, right? What I worry about is in the situation we're talking about with APRNs, if they have their own fluoro machine and they're doing this somewhere where they're not under the purview of a physician. It's not just radiologists, by the way, it's orthopedists. You said you're a nurse anesthetist. You're in the room with orthopedists who are using fluoro as well. And I'm sure orthopedic PAs are doing the same thing, right? It's the same sort of thing where an orthopedic PA doing a joint aspiration, something like that under fluoroscopy, if they feel uncomfortable, if it's a difficult needle stick, if they need help, there's a physician available for them to come in, complete the case, make sure everything's happening safely, right? And make sure that the patient is taken care of in a safe manner. If you don't have that physician supervision, what I worry is that there's no backup, right? It's an APRN doing this procedure, and if they don't feel comfortable, and they don't have that availability of somebody to provide them that backup, what happens in that situation? And is what happens in that situation safe for the patient?
I would argue that it is, but we're not here to debate.
Yeah.
I'm just getting your opinion, and I appreciate for the work that you do. And thank you for your time, Mr. Chair.
Thank you.
Sorry, that was a question or comment, I guess, Representative Dauphine, welcome.
Thank you, Mr. Chair, and thank you for your testimony today. I'm just curious, so you're supervising them. I'm just wondering if you're supervising them and in the room with them, as you say, how cost effective can it be having someone else do the procedure when you're suggesting that you need to be there anyway? So I'm thinking you can't do anything else. You've got to be there watching them, to make sure the procedure is done correctly. Can you comment on that?
I mean, not entirely, because I'm not a interventional radiologist per se. I'm in a department with it that employs them, and practice that employs them. But they are, if you've ever seen a Flora room, I mean, in an IR suite, there might be two rooms together. You can be supervising at the same time that you are, say, on the phone with another provider, talking about the next patient and making sure that you have an eye on what's going on with the PA. When we talk about supervision, we're not necessarily talking per se about direct eyes on, right? We're talking about the ability, as I was saying, of having a backup and making sure that you have a physician who has seen and knows how to handle complications and knows how to handle when things get out of hand. To use nurse anesthetist as an example, a nurse anesthetist always, should have an anesthesiologist, correct? That is available for them. And you can correct me if I'm wrong, but I believe that nurse anesthetist has to have a supervising anesthesiologist. You can actually comment better on that than I can, because I'm not an anesthesiologist or a nurse anesthetist. But how would that work in an anesthesia setting, right?
So Dr. K, I think we shouldn't be going, just
Sure.
answer the questions, and then that's probably the way to approach it.
Okay, I'll leave it at that then, and say no more.
Thank you for your answers. Thank you for being here today.
Thank you. Representative Denning, if you want to speak again, you're welcome.
I didn't mean to put anybody on the spot there. I'm sorry.
Oh, you didn't. Thank you very much. Now, just to clarify, for us to practice anesthesia, we just must practice under another physician surgeon.
Right.
Okay, thank you so much. Seeing no other questions or comments, we'll move to the next person on our list, which is Dr. David Hergen. Welcome. Thank you. Sorry I missed you. We were looking at you remotely, but you're in person here, so thank you. If you want to just press the button so that perfect. Go ahead.
Thanks for having me. My name is David Hergen. I'm a board certified orthopedic surgeon. I've been caring for patients in Connecticut for 15 years. I live in Guilford and I practice medicine in Middletown at Middlesex Orthopedic and Spine Associates, which is a division of orthopedic and neurosurgery specialists. We're an independent medical practice that cares for tens of thousands of patients in Connecticut each year. I'm the chairman of our clinical governance board and recently spent 4 years as the chair of the orthopedic department at Middlesex Hospital. I'm currently the director of the joint replacement program, as well as the quality improvement program at Middlesex Hospital. I'm testifying in opposition to SB 440 and HB 5316. These bills pose a serious risk to independent practices like mine. I ask that you study the impact that changing the Senate's Certificate of Need laws will have on patients' access to high quality, lower cost, and convenient care furnished by independent practices before you consider either of these bills. My practice's partnership with Spire Orthopedic Partners, which is a management services organization, has enabled us to expand access to care, enabled us to provide cutting-edge healthcare services, and provide higher quality care at a lower cost. Historically, building an independent orthopedic surgery practice has come at a great risk, borne by the practicing physician, and practices like mine have had a difficult and hard time competing for top talent recruitment against our state's hospital systems. But with our MSO partner, we have been able to hire into our practice 16 surgeons of different subspecialties within orthopedics, including a cranial neurosurgeon, as well as an orthopedic oncologist. These are the type of specialists that independent practices are typically unable to bring into the community setting, and this is ultimately a win for our patients and our communities because it expands access to high quality, local orthopedic care at a much lower cost site of care than at a hospital. Our group's MSO partnership also has enabled us to open new facilities that expand access to quality care in our communities. One example is 3 urgent orthopedic care clinics that are open beyond regular medical practice hours and are fully staffed with physicians as well as advanced practitioners. Aspire support, we turned down no one at these centers. They have expanded the number of operating rooms also in our surgical center. These new rooms enable us to provide shoulder, hip, and knee replacements, as well as cervical and lumbar spine procedures. These procedures require increased staff. They require very large operating rooms and special equipment, including new robotic technology. Additionally, the new outpatient and same-day joint replacement program ensures that people are able to recover in their own home after surgery with check-ins before and after their procedure. With the support of our MSO partner, our independent medical practice would have struggled to make these projects come to life. And these are projects that our healthcare system in Connecticut really needs, because in addition to providing access to exceptional care, they save patients and the healthcare system a significant amount of money. An outpatient total joint replacement surgery costs typically about 1/3 of what the same surgery would cost in a hospital setting. And it does not require an overnight stay.
Excuse me, Dr. Hergen, but your time is up. Thank you.
Can you press the button again? Thank you.
Sorry, I want to say that our practice is on the right side of the cost curve. And I also want to say that my physicians and I do not work for Spire. I'm the chairman of our clinical governance board. My physician and colleagues and I make all the decisions regarding any clinical matters, including hiring physicians, firing physicians, when and where we work. We do not work for Spire, and no one at Spire interferes with our clinical practice or our responsibilities or our judgments. They have absolutely no say in how we take care for patients. This allows me to focus on one thing, providing my patients with the highest quality care that I can. And in conclusion, I'd ask you not to rush with Bill SB 440 or HB 5316 through session. I'd hate to see these bills force independent medical practices like mine to have to choose between closing their doors or selling to a higher cost hospital system or an insurance company, which are buying medical practices at an alarming rate across our country. Please give independent practices like mine the opportunity to come to the table with you to consider whether to modify our CON laws without jeopardizing our patients' access to high quality, lower cost care at independent medical practices. And I thank you very much for your time.
Thank you so much for your testimony. I have a few quick questions. If you
Please.
can explain what an MSO is for everybody's benefit.
It's a management service organization. So what happens is with a private equity backs forming an MSO, a group that provides administrative services to help an independent medical practice, a CEO, CFO, C-suite executives, marketing team, HR help, all across all the business of running a medical practice that we would otherwise be kind of bogged down on our own.
And Spire is a private equity group.
Spire is the MSO group that is funded by private equity.
And could you tell me the percentage of patients with Medicaid that you see in your practices?
I can get you that number, but what I can tell you is that since we formed the partnership, we are able to see a significant higher amount of Medicaid patients. I believe the number of Medicare and Medicaid patients is close to 10 or 11%, but I can get you the exact number of Medicaid when I know that number.
Sure. One of my colleagues has a question, so I'll come back to my questions in a second. And Representative Zupkus, please go ahead.
Thank you, Mr. Chair. Thank you for coming. Could you just explain to me, because you said you oppose 440, which is the CON. So can you tell me why? And do you think it works now?
I would say I oppose it. I think it's just going to create, it would limit or create an onerous process for a small orthopedic practice like mine to go through this process where we feel like we know where our blind spots are. We know what our community needs. We are able to go out and talk to hospital systems, different groups, and in order to survive and keep our employees employed and doing what they love to do and doing what we love to do, we realize that we need to make a move the way the healthcare system was changing. And we feel like imposing a new CON law that would require us to go through these steps would be cumbersome and may not allow us to do what we need to do and maybe push us into a hospital system, which would lead to less autonomy for our group.
So do you have to go through the CON process now?
We do not.
Understood. Thank you.
Thank you.
Thank you so much for your testimony. I think 440, from what I understand, is not asking you to be part of the CON process. But I think the other one is.
5316.
5316 is. But I just wanted to speak a little bit about this because I'm glad you're here. Thank you for staying with us and thank you for being in person. This is an important issue. From my understanding of and interacting with private equity, there is a honeymoon period. And that honeymoon period is where the private equity is investing into the area to try and get the market share. And then before you know it, they will actually sell all your robotic equipment and have you lease it. And lease it to the price that they would actually have their own holding company. And they do these slicing and dicing activities that allow them to be able to maximize their financial potential from anything. So you are an orthopedic surgeon and you're doing this because you want to help the people with your skills that you have. But then the private equity is coming to a community. Their primary goal is how can they maximize the profit from this? So there are two different prisms. And there is an alliance for a short time, and that's the honeymoon period I'm talking about. And then there is a divergence. And if you can speak to that a little bit, and well, I don't know if you can speak to that yet.
Yeah, no, I appreciate your viewpoint on this. And in some respects, I don't disagree with you at all. I understand that the private equity goal is to make profit and create for their shareholders a profit. This is, I think, I would say my answer to that would be, I don't, after speaking to multiple groups, I do not feel like all the, what we would say private equity groups are the same. And I've seen that firsthand. There are some with alignment and whether it's perceived or not, I can speak to my experience firsthand. There are some that are interested in supporting the physicians and creating organic growth, supporting us because they feel like we're good at what we do. And it's freed us up as surgeons to do things we wouldn't have been able to do on our own. And if I think there are some groups who don't look back and do what they need to do at the expense of others. But I can tell you that is not our experience. And I do not think that that is every private equity's goal. I think they wouldn't be in business very long with some of them. I think on the larger scale in the hospital settings, I think there have been some unfortunate incidents that have happened. But for the small independent practices, I do think ultimately it's going to be a win-win for both us and our communities.
And I'll say one more thing is that they are going to come to the parts of the business which are lucrative, right? They would not buy a primary care practice because it doesn't make any money. They wouldn't buy a pediatrics practice or psychiatry, but they would go for orthopedic and ophthalmology and dermatology kind of areas, which they may feel that the return may be a little better. The issue is that there are good actors and there are not so good actors, right? And the bills, what they're looking at, Senate Bill 9, 5316, 440 to some degree, they're looking at making sure that the state is involved, because when things fall through the cracks or when the private equity leaves, the state has to make up for all the losses. And that's part of the challenge. So there are actors who are coming in and who are saying that we will come and we will not take the proportionate number of Medicare, Medicaid patients in the community. So the process that we are trying to work on is going to make sure that they will get the authority to work, but they would have it in writing that they will be taking care of the patient in proportion to what the number of patients are in that population. In that sense, and creating a mechanism that whenever there's a transaction, because these private equities do pretty interesting things. They would identify parts of the business that are making far more money and they'll keep them, and the ones that are not making money will be removed or sold. And then they would break down the business into the building and then have the business pay for the rental for the building and create smaller entities and and multiple different things. They're pretty smart in what they're doing. So that's what the bill does, is to have those protections in place.
And I can tell you from our experience with our independent physician practice, I have had colleagues and friends who they're being bought up by hospital systems, they're being bought up by insurance companies, Optum, and the primary care, like you said, non high revenue generating maybe, or high profit centers like primary care. And these physicians are leaving because they've lost complete autonomy. They're being told when they need to see patients, how many patients. They don't make any decisions. I'm here, and I respect your opinion wholeheartedly. I'm just here to tell you our experience has been very different, and I would hate to see practices like ours being forced to close or joining a hospital system where there's higher cost of care, and it's we lose all our autonomy.
Yeah, you made a very strong point from your perspective. We appreciate you being here. Thank you
very
so
much
much
for your time.
Thank you. The next person on our list is Kelly Kearney. Welcome. Thank you for your patience with us. Welcome. You're on.
Well, thank you. Thank you very much. Can you hear me okay?
Very well.
Great. Well, good afternoon, Mr. Chairman, and also good afternoon to the members of the Public Health Committee. Very much appreciate, first of all, the heavy lift that apparently is what you do at the Capitol, which is incredible. This is just an indication that you deserve a lot more praise than you get. So thank you for what you do. My name is Kelly Kearney. I'm part of the leadership team at Cure Now PD. We're actually based in East Hartford, but the South Windsor connection that I have is my wife's business, which is right on Governor's Highway. So there's my South Windsor connection. And my Fairfield County connection for your co-chair is I grew up in Norwalk. So I'm 2 for 2. Just wanted to quickly point out our support for SB 1, sections 33 and 34. We are a group that is Connecticut-based, but we're national in scope. And we are essentially focused on clinical trial recruitment. And our purpose for being involved today was to point out the fact that SB 1 has such great potential. And as we heard from Reggie, this is what we want to get done. We have so many people in the state of Connecticut, but also nationwide and worldwide, that are looking for a cure, looking for results. And, the path to a cure is paved with research and innovation. But the journey's hindered by a significant obstacle, and it's one I wanted to make sure got heard. And it's the challenge of clinical trial recruitment. And we hope to work with the coalition that was mentioned earlier. The statistics on clinical trial recruitment, they're alarming. Remember this, 85% of clinical trials face delays, 30% fail to recruit any participants, and 80% don't meet their recruitment targets. So it's really important, and I'm sure, as you know, Senator, based on your industry, it's impossible to get results if you can't get enough participants in clinical trials. So Connecticut's got the opportunity to lead by example by passing SB 1. And Cure Now is actually actively involved in clinical trial recruitment. We have a Center of Excellence initiative. We have an ambassador program that we are in the early stages of, but we were asked to bring that up today. And the mission of Cure Now, real quick, is we're out there to be positive agents of change in PD research, and we focus on full enrollment and participation in studies and clinical trials. And our strategy leverages a local network of Parkinson's ambassadors to make it happen, which demonstrates our commitment and proactive approach to overcoming the recruitment challenge. So at Cure Now, we're people with and without PD, and I know that Michelle Hespler is a name that Reggie is probably familiar with. Steve DeWitt, White House Champion of Change, is our co-founder, both actively involved in our organization. And so our point is every delay, every missed opportunity like those that would happen without fully enrolled clinical trials is another day of struggle for those living with Parkinson's. So we support SB 1, and we ask distinguished members of the Connecticut legislature to support and pass it. And our ability to make a difference in PD research will be significantly enhanced by doing so. And so in closing, I ask you to consider the lives that hang in the balance, the mothers, the fathers, siblings, and friends affected by PD. And there's no silos in our fight. We're all working on the same side, which is to beat Parkinson's. So by supporting this bill, you're investing in the promise of a healthier, brighter future for all, and you're helping to put Connecticut at the forefront of Parkinson's research. Thanks for your time and consideration. And together, let's make Connecticut a beacon of hope in the fight against Parkinson's.
Thank you so much for your testimony, and thank you for the work that you do. We appreciate you for your testimony, and we appreciated your first part of the testimony too.
Thank you for all that you do.
Thank you. Seeing no questions or comments, we will move to the next person on our list. We have Ann Manuski. Welcome, Ms. Manuski. Number 42, Ann Manuski, you can speak. You can unmute yourself and turn your camera on. While Ms. Manuski is looking at that, we can move to the next person on the list, which is Dr. Benjamin Cherry. Welcome, Dr. Cherry.
Thank you. Thank you, co-chairs Anwar and McCarthy Vahey. Thank you so much, ranking members Summers and Claritas Ditria, and all the distinguished members of the Public Health Committee. Good evening at this point. Thank you for your stamina for inviting us to participate in this crucial process. My name is Benjamin Cherry. I live in Woodbridge and I work in West Haven. I'm a board certified internal medicine physician practicing as an academic hospitalist at VA Connecticut. I'm also assistant professor of medicine in the section of general internal medicine at Yale, sub-I director of the internal medicine sub-internship at Yale School of Medicine, and co-chair of the Health and Public Policy Committee for the American College of Physicians Connecticut chapter. I want to be clear that I'm not speaking on behalf of any of these groups and my views are my own. I'll try to keep it relatively concise because I know you've heard a lot of important testimony on Senate Bill 1, which is what I'm here to speak about. I want to express my strong overall support for Senate Bill 1, especially with attention to sections 10 through 18 regarding graduate physicians. I do have some concerns with other sections of the bill. So sections 10 through 18 regarding the creation of the graduate physician concept in Connecticut, I believe fill a critical need for both graduated medical students as well as Connecticut residents by providing a mechanism through which medical school graduates who have not matched into a specialty residency program can provide essential access to primary care services here in Connecticut. For the graduates, it helps build their experience with appropriate supervision under a collaborating physician. It helps them continue to meet their own basic financial needs by earning a salary reflecting their skill and knowledge. And in many cases, these are people with significant educational debt. I can tell you I still have a really significant mountain of educational debt, which can be burdensome, to say the least, if you're not able to earn a salary for your work and expertise. For Connecticut residents, this can increase access to essential primary care services. And, you know, if these graduate physicians are utilized in, I think, the most beneficial and educational way, they can get more time with these patients, which means that these patients, these Connecticut residents, are getting more time with a physician to really listen and hear their concerns and questions. I've seen firsthand students that were unable to match into their intended specialty who found tremendous fulfillment in internal medicine, which lays the foundation for primary care in its various forms, including general practice primary care, geriatrics, home-based primary care, et cetera. Many of them that I have personally met and interacted with were able to do what's called scramble into an internal medicine residency. That is where a student who does not initially match is able to find a residency spot, but there are still very many students, thousands of students each year who are not able to scramble into residency positions. The students that I worked with who scrambled into internal medicine and ended up completing residency training in that specialty stayed in internal medicine, and in several cases ended up pursuing primary care and primary care adjacent specialties like geriatrics. Personally, I'm an academic hospitalist. I never intended to be a hospitalist. I intended to pursue pulmonary critical care training, but for reasons related to my personal circumstances, I needed to work for a year or two before applying to subspecialty training. And I found that I really loved general internal medicine. Believe it or not, hospitalists really have longitudinal relationships with many patients in the hospital. Sometimes I like to joke that we're like primary care physicians for the sickest patients in our health system. And so,
Excuse me, Dr. Cherry, but your time is up. Thank you.
thank you.
If you want to finish your last thought, please.
Sure. The last thing I'll say is that, you know, the experience that I had, the exposure that I had to the practice of general internal medicine made me really love it. And I'm hopeful that if we are able to create a graduate physician position here in Connecticut, that showing those students, those graduates, those physicians, those young physicians, how valuable, important, complex primary care is, that they'll have a greater understanding for it in their career as physicians, if they do not stay in primary care, and that there's a good chance that they may become primary care physicians themselves. Hopefully we can keep them here in Connecticut. So thank you.
Thank you. And from what I gather, there have been about approximately 4,000 people who have not matched in the past, and then there may be 16,000 or so about a year or so ago too. So the number of these individuals are increasing as well. Is that what your understanding is as well?
Yes, you know, this is a really significant problem, and it's a problem that affects international medical graduates, U.S. domestic medical graduates, U.S. citizens who graduate from international medical schools are especially affected. And so there are a number of initiatives being you know, taken around the country. I believe there are 8 states currently that have initiatives such as this, because it's a significant issue that we haven't quite figured out how to handle yet.
Thank you. I think 15 other states have done something like this just to be able to address this immediate need. I have a couple of my colleagues who have questions as well. Representative Wielander, you're on.
Thank you, Mr. Chair, and thank you, Dr. Cherry, for coming in today. I also just wanted to say thank you for your email to me recently, and I would love to set up a specific time to talk about this and talk about your testimony as well offline, just to make sure that I am understanding your perspective on this as much.
Thank you very much. And thank you for doing such a great job painting my son's face at that event we saw you at over the summer.
Oh,
he still loves the photo of him as a cyborg, so thank you so much.
oh, that was a great day. You're welcome. I think I accidentally muted myself halfway through, but I'd love to get together and talk through that just to make sure that I'm, you know, understanding the nuances of this. And I will yield back to my colleagues. Thank you, Mr. Chair.
Thank you. Representative Denning.
Dr. Cherry, I just wanted to get on and thank you for the work you do. As a nurse anesthetist, primary care physicians have given me clues that I wasn't catching up on other people. And as a hospitalist, I counted on you numerous times. Your work that you do is invaluable, and you're right, we need more of people with your skills and determination. Thank you very much. I yield to the chair.
Thank you. Thank you so much, Dr. Cherry, for the work that you do. Seeing no other questions or comments, we'll move to the next person on our list. Thank you. The next person on the list is again Ann Manuski. Perhaps you can fix, I hope you've been able to fix your technical issues. You can unmute yourself and speak if you want to. Going once. Going twice. All right, we'll move to the next person online. Number 49, Jim Iacobellis, in person. Welcome. We're starting to miss you, Jim. Welcome.
Good evening. I think it's good evening. I'm Jim Iacobellis, the Senior Vice President of Government and Regulatory Affairs at the Connecticut Hospital Association, and I'm here to testify on 2 certificate of need bills, Senate Bill 440 and House Bill 5613. We, for many years, have supported the Certificate of Need program, and I think it's fair to say that our support has been challenged in the last couple of years. The CON should be a tool to support world-class healthcare, but the current process is broken with excessive delays and administrative burdens. At its heart, the Certificate of Need program should be looking and focusing on patients and patient access. And should be the balance. And as I was writing my comments this morning, just before Dr. Gifford and AG, the Attorney General and Senator Looney, who used that word a lot, we wholeheartedly support it. It's a balance between regulatory oversight and providing access to care. We support Senate Bill 440. It takes a significant step toward restoring the balance, an important step. And how does it do that? It does that with process improvements. It streamlines the process, puts in effective deadlines, and provides for an automatic approval, something that was in the statute for a number of years. It also creates an expedited process. It also puts into place legislative priorities of services that should be under the Certificate of Need program. It exempts certain services. We wish to have an ongoing conversation with the committee on some of the language in there, which we think can be tightened up or explained. And a conversation about the interplay between relocation on municipality and mileage. I think as currently drafted, it may lead to some unintended results, but we look forward to those conversations. And it transfers the cost market impact review to the Attorney General's office. As I said, one of the last times I was here, we have never stood up here and said something should go to the Attorney General's office as opposed to the Office of Health Strategy or any other state agency. This belongs there. Substantively, it belongs there. The report from OHS has to go there anyway. They do the market work. They do the work related to antitrust. And it looks at a level playing field and ensures all equities, all entities, including private equity, are subject to CON. With respect to House Bill 5136, we oppose that bill, and I'll give you an example, two examples. One we've spoken about because it uses that language in Senate 9 again here about exempting from Certificate of Need those entities acquiring hospitals, except for, those entities acquiring for physician practices except for hospitals. It allows private equity to continue to do that. But there's a mandate in this bill that requires a Certificate of Need for physician personal services agreement. That means if a hospital wants to have a relationship with a high-end specialty hand plastic surgeon, right? That we know we have injuries and we know that these are very limited, the expertise is very limited. That personal service agreement would now have to go through the Office of Health Strategy. We wanted to hire new physicians to go on call in an emergency department. Those agreements now would have to go through the Certificate of Need problem. If we wanted to hire Senator Gordon to come down and to do education work in one of the hospitals, though that agreement would require to go through the Certificate of Need program. We do not support that. And one last comment, Senate Bill 9, Senate Bill 5316, and Senate Bill 440 cannot independently pass. They do not flow together. You can't layer one on top of the other. We have to pick a bill and put the CON in the bill, because if we do it in two separate bills, the problem, I put my old LCO hat on, the problem would be huge if we did that. And a final thank you to this committee. It's the last public hearing. I think I've testified at almost every public hearing. Thank you for listening. This committee is really a joy to testify in front of. You put the people in front of you through substantive questions, and thank you for that. I think you get at the issues really well. And in addition, you read the testimony that's submitted. We've submitted testimony with some specific language changes related to Senate Bill 1. So thank you, and I'm happy to answer any questions.
Thank you so much. There's a lot to talk about here. So if I heard you correctly, 440 is pretty much okay in every aspect.
With some language, I think, clarifications, we support 440, yes.
Okay. And what I can tell you or share with you is that the Office of Health Strategies is trying to address the challenges that they've had with private equity in the recent past with 5316. And that's what they're trying to get at through this bill because private equity tries to slice and dice things and it's trying to look at how can they be aware of what's going on and not find out a little late in the game. How can the state be aware of what's going on if we don't have a bill like that, or at least parts of the bill like that?
I would say that Senate Bill 440 gets at it better in a cleaner way to get at it. In addition, it also provides for a study to amplify or to look at issues. In addition, I think 440 gets at it in a better way.
Okay, so in other words, we are still having the protection without having that process and information, because some of that is burdensome to the entire process and the duration of that process, what it takes.
Correct.
Okay. I want to just look around, make sure none of my colleagues have questions. Yes, my co-chair has a question, Representative Kristen McCarthy-Vahey.
Thank you, Senator Anwar, and Jim, thank you so much for being here. It's always a pleasure to have you here with us, and I appreciate the conversation both here at the committee and outside. So you talked about the fact that the current process has significant delays and burdens, and earlier today, I know you were here, you've been here all day, as you always are. When Dr. Gifford spoke, she talked about the changes in that office and the fact that there were 0 or 1 attorneys at one point in that office. And just curious from your perspective in terms of whether or not you have anecdotally even experienced a shift and a change as those changes have occurred in staffing.
I have not heard that people are saying, okay, never mind, the system is now working. But let me try to, because I heard that and I understand absolutely what Dr. Gifford is saying, but I think I want to look at it a little differently, is that we are relying on the efficiency of the Office of Health Strategy in the Certificate of Need program because they currently have the staff to do it. Life happens. People lose their desire to do one job and decide to do something else. The statutes are the things that would govern the timeframes going forward, notwithstanding the amount of staff that is in the office. I think it's great. I think it's terrific that the goal is to reduce the timeframe. But in 6 months from now, if 2 attorneys decide they want to move to the Department of Social Services or someone else, we're back to where we are without making changes in the process. So I think it's great. We absolutely support and thank Dr. Gifford for doing that, but these statutes should live independently of how and when the office is staffed fully.
Understood, but statutory guidelines or not, there still have to be people in place, right?
Correct.
To do the work.
Correct.
So I hear what you're saying. You'd like to see that in there. You talked about the movement over to the Attorney General's office, and earlier today, the Attorney General talked about being able to have economists and others, you know, in your experience with the Hospital Association and working with hospitals who are acquiring other practices, who are the people who are the kinds of experts that they look to? Because certainly they're looking at the market. So who are some of the folks that they're talking with as they go through that process?
Is your question like specific entities or types of
Types of.
They would be legal experts that know antitrust market share, because any acquisition of a hospital also needs to go through the FTC, right? And they have to present evidence and a filing with the FTC. So it would be those, whether they are attorneys, they're probably attorneys, market analysts, and economists. And then they work, why we think it's an appropriate move is they currently work with the Attorney General as they're working with the FTC. So it is a specialized area, but the Attorney General's office has the expertise there related to mergers, acquisitions, and antitrust. So they have some of it there where the Office of Health Strategy has to go out and actually have consultants and work with consultants to do it. There is some in-house there. I understood and I heard the Attorney General talk about that they would need additional staff. And I think we'd be open to a sort of a transition period in order to get it there, applications filed after a certain date, to give us the opportunity to work through the budget issues.
Thank you. And I appreciate the reference to the earlier conversation, and whether it's additional staff or the ability to hire those experts. I think Senator Anwar perhaps earlier talked about the creativity of the financial markets, and we've seen that. And we've seen the results and the impacts. For example, in 2008, when we had very complex financial instruments that were used that then resulted in, tens of thousands, hundreds of thousands of people losing their homes. Here now in healthcare, we're seeing these different financial instruments being used, and these are people who speak, a language of the financial, just the financial background, expertise, et cetera, that many of us in government simply do not have. And so that's one of the things I think about when I think about, it's not just private equity. We use that term as an, kind of an overarching term. It's more than just private equity. And as the Attorney General said earlier, it's not that all of these options are necessarily the worst options, or we don't want to characterize these actors as all bad actors. We have a system that is set up to allow this. So I think, to Senator Anwar's questions earlier, the ability to review and regulate and provide the balance, that was a word I used earlier as well. It really is important. So I know that I will also just underscore and thank you for referencing that we have multiple bills. There are bills proposed by this committee, bill from the Office of the Governor, bill from the Office of Health Strategy, and there are competing sections within those that will have to be resolved. So we will need to get around the table and look forward to being in conversation with you as part of that. Thank you, Senator.
Thank you. And I think your comment about some forward-thinking flexibility is important, because I'd spend probably as much time as you did looking up REITs and reading what was happening in Rhode Island and Massachusetts and other states. And healthcare has gotten as challenging as it ever has been in my 23 years of doing this, and understanding the different governance structures, the different way in which healthcare is provided. And we need the ability to regulate and to look, which is why I talked about a balance. The balance is accountability, because we have to make sure that there's access to the patients and quick access to the patients. It ties it into some of the conversations that Tracy Wardich was having about hospice care, and how do we make sure and protect the home care nurses at the same time we know we need a quick referral. And so we've got to get the balance right. The balance is not there today. 440 goes a long way, we think, into restoring that balance. But as always, we're ready to have this conversation.
Thank you. Thank you so much, Jim. I just wanted to explore this further. Earlier, there was a testimony about physician practices, and private equity is trying to get their hands into everything. And they wanted to be excluded from this whole process. And I think the governor's bill and Senate Bill 9 sort of gives an exclusion for a certain time. That's what you're talking about, was the concern that you have, right?
Correct.
And what the Connecticut Hospital Association's perspective is that there should not be any exclusion.
Our perspective is, if a hospital's activity is required to go through certificate of need, any other entities doing the same type of activity should go through certificate of need. I don't blame the physician who stood up here. I don't blame him at all for not wanting to go through the certificate of need process. Even this committee in the legislature has acknowledged the problems with CON repeatedly. When we needed more children's behavioral health, we took them out of the certificate of need. When we wanted harm reduction centers to get up, if they could, we took them out of CON. Last year, we did the same thing with birthing centers. So there is this move that we're acknowledging that the certificate of need program is not working and we're moving things out. Anything that's new that we want up and running, we're moving out. There's a flavor of that in 440, which we support, but I don't blame anyone from standing up and saying, we don't want to go through that certificate of need program as it is when we hear a year to get through a CAT scan and they're reading all the articles on the length of time to go through the certificate of need program. However, our view is if a hospital is required, when we're acquiring a physician practice is required to go through the certificate of need, anybody else who has to do that. And the 440 is written, as I said, in a way that it is pretty nuanced. It didn't talk about investment. It talked about in controlling interest, right? There is a distinction there, and 440 makes that distinction.
Yes. So since 2019, we've been trying to get a bill and address the CON issue. And then now we have like 4 bills on CON alone. And then we're trying to figure out how do we navigate each 4 of them. Because there were some profound testimonies today with respect to how do we manage this, because there is a voice rightful that we need to do the minimum that we can get away with, and also recognizing the data is not supportive of ongoing CON. We've seen the bad experiences that have been there, and I think striking that balance and is going to be the tricky part. It will require many hours of conversations, but I think the prism, and I said that to Commissioner earlier, Dr. Gifford, the prism that Office of Health Strategies is looking at is entirely from the 3 hospital and the disaster that we are still enduring collectively. And that's one of the prisms. The second prism that we are looking at it from the Public Health Committee's perspective is that we want the process to be efficient, but we also want it to be cognizant of the needs of the community right now. And so that disconnect needs to be connected collectively and identifying that common ground and these are starting points of conversations. But I can tell you these bills, as they move forward, will result in a number of different conversations. The governor's bill will go in its own format, and there will be different groups that will be having that conversation, but we will be in the midst of each one of those conversations and would make sure that Connecticut Hospital Association is as well. So
thank you. It is, and you're right, figuring out the best path for the 3 different versions is going to be a challenging one. I think that one of the concerns we have is the weight and breadth of all of these issues may make it difficult in the next 50 days to do there. And I'm listening to comments about what are the things that we need to do and what are the things that we need more conversation on. And so I heard a theme of that in today's hearing. I think there are key things that we need to do this year, and I look forward to having those conversations with the committee.
thank you. Seeing no other comments or questions, we appreciate you, Jim. Thank you for being here. And next on our list is Michelle D'Agostino. Welcome. I hope I pronounced your name accurately.
You did. Thank you. Good evening, Senator Anwar, Representative McCarthy Vahey, ranking members and distinguished members of the Public Health Committee. My name is Michelle LaValle D'Agostino, and I'm a movement disorder neurologist with Hartford Healthcare Chase Family Movement Disorders Center. I'm here today to speak to you about Parkinson's disease and to support Bill 1, specifically sections 33 and 34. So as you may know, Parkinson's disease is a neurological condition that affects the body, brain, and many organ systems. There are approximately 1 million people living with Parkinson's in the United States, with 12,000 of those people living right here in Connecticut. It's estimated that 90,000 Americans will be diagnosed with Parkinson's this year, which represents an increase of nearly 50%, according to a 2023 study conducted by the Parkinson's Foundation. This data is alarming to those of us who have dedicated our lives to the treatment and one-day cure of this terrible disease. We are so grateful that you have partnered with our community. With proposed sections 33 and 34 of Bill 1, we are excited that the Healthy Brain Initiative and statewide registry are under consideration. I have been working with Parkinson's patients for more than 2 decades, and I also have a family member with the disease. I feel that this gives me a fairly unique viewpoint as I see it from the perspective of both the movement disorder specialist and also the challenges that families face as they try to do everything they can for their loved ones. Navigating the dementia and psychosis that may come with Parkinson's and other neurological conditions is both heartbreaking and terrifying. The Healthy Brain Initiative can be instrumental in supporting patients and families, increasing education, reducing social and emotional isolation, and bringing resources to a population in need. This initiative will help build the foundation to care for our population living with dementia in a way that helps maintain dignity while providing the care and support that they and their families so desperately need and deserve. People living with Parkinson's and their families are often left feeling overwhelmed and uncertain of how to move forward with the treatment of the many symptoms associated with the disease. There is significant variability in the treatment and outcomes of people living with Parkinson's country and even within our own state. Therefore, 10 states have already established registries for people living with Parkinson's, and another 5 have proposed bills, including Massachusetts and New York. With the evolution of the electronic health record, we now have an opportunity to gather data in a way previously impossible. Having a registry will not only allow us to gather data and learn more about this disease, but make sure that every patient is receiving the gold standard of care appropriate for their symptoms. Gaps in treatment or areas of poor outcomes can be determined and thus lead to augmentation of resources and support services where they're needed. I thank you for all of your time and consideration and look forward to working with you to make Connecticut both a leader and a champion in the battle against Parkinson's.
Thank you so much, Dr. D'Agostine. I just wanted to ask you, do you know of a model or any of the state that is doing this right at this time with respect to the ending the Parkinson's, the registry, but also Healthy Brain Initiative?
So California, Ohio, Maryland, Nebraska, and Kentucky have some very robust models. California in particular has a very robust model to gather the information. California is much larger than Connecticut, but what I've seen in my years of practice here is that there are huge disparities even within our small state. And so what a lot of the other states have done is really use the registry to determine where are the areas where patients are really getting substandard care, where they're not living as long, where the quality of life measures are much poorer. So we have great examples to look to. And then again, our close colleagues in Massachusetts and New York also have bills coming before legislature this year.
Thank you so much. Representative Christian McCarthy has a question or comment.
Thank you, Senator Anwar, for indulging me. And really, it's a thanks. I wasn't able to say this when Regina testified earlier, but I lost my dad to Parkinson's disease. And I am incredibly grateful for people like you who are helping to make it so that it's not too late. When Regina testified, I don't know if you heard her say, "It's too late for me." And that phrase has been haunting me since she said it, and the work that you're doing, and thankfully, hopefully we can pass this in Senate Bill 1. It will mean that it's not too late for so many other people. So just thank you.
I'm so sorry to hear about your father. Thank you for all this hard work that you're doing. You're really making a difference in so many people's lives. Thank you so much.
Thank you. Thank you. Seeing no other comments or questions, we want to thank you for your testimony and for being with us all day. Next, we have on our list, Stacy Yarbrough. Welcome.
Good evening.
I hope I pronounced your name accurately. Sorry.
It's wonderful. No worries. Thank you so much. Good evening, and thank you for your time, co and vice chairs, and all the distinguished members of the Public Health Committee. Again, my name is Stacy Yarbrough. I'm the town clerk, the registrar of vital records, and the tax collector of the town of North Haven. I'm speaking to you today in my positions for all the different things that I do for North Haven, but also as a member of the legislative committee for the Connecticut Town Clerks Association in opposition to Section 7 of HB 5488, which is lines 165 through 174, an act concerning various revisions to the public health statutes. For centuries, town clerks have been responsible for the processing, indexing, modification, maintenance, and permanent retention of all vital records. And specific to HB 5488, we're speaking on the birth and death records that occur in our towns. Towns have heavily invested in the protection of these permanent documents, which includes climate, humidity controlled storage vaults, control of access to the public per access to these records, creation of documents with the appropriate and approved archival paper, and certified copies limited to certain individuals based upon state laws that exist currently. The Connecticut Town Clerks Association, in conjunction with the Department of Public Health, develop and provide clerk training and have an entire module dedicated for vital records. Further, the Connecticut Town Clerks Association, while it recognizes the importance of ensuring the integrity, the accuracy, and the preservation of all town records, especially vital records, which include these birth and death records, we just want to elaborate upon the point that town clerks play an important role providing the public with certified copies of these records, and they provide the adequate seal on each document that is sent out to the public. The Connecticut Town Clerks Association is concerned about relaxing the production and retention of birth and death records to anyone other than trained town clerks / registrar of vital records, and respectfully, we oppose Section 7. In conclusion, on behalf of the town of North Haven and the Connecticut Town Clerks Association, I do want to thank the Public Health Committee for working in collaboration with us to ensure the integrity and preservation of all vital records as we move forward. Thank you.
Thank you for your testimony. So you're talking about Section 7, right?
Yes, sir.
So do you know the rationale for that part of the section?
Well, you know, it's funny you should say that because there are going to be two towns that are going to be most affected by this. And I've reached out to the town clerks in those towns, and we've had a good discussion about that. And those towns would be Ledyard and Uncasville, which is a village of Montville. And also read and researched the testimony that was provided by legal counsel for the Mashantucket Pequot Tribal Nation. And the idea is this is being brought forward, and I'll quote, this abridged version of history. There's a whole history of the tribal nation. The tribe has fought hard to keep its land and to be recognized as a sovereign nation. They don't want it to be treated merely as another municipality in the state of Connecticut. And they end with to be born or to die as a Mashantucket and have a certificate that identifies the location as a Connecticut town cuts them deeply. And I understand that, and I understand where they're coming from with regard to this policy. But I also understand the importance of a unified system of maintaining these vital records. And I have heard some stories about how things haven't quite worked out as it perhaps should so far with regard to marriage licensing, which has started to be retained by the two tribes that are here.
As sovereign nation, they have that right. But what was important to this committee was that data be shared with the municipalities, and I think that's part of the work that we have done in this bill, which is going to address that. So the municipality will have the data, but the sovereign state would be maintained, and they would still be able to have their own birth certificates and death certificates. And I think that's what we are trying to do, and it's been a compromise after looking at this for over a year.
And I would respectfully disagree as to some of the stories that I've been hearing as to just the marriage portion, because that's what we're looking at thus far, is that sharing isn't exactly going on as it should be. And I think that is a major concern for the association, because these vital records to be maintained appropriately. And we're not just talking about the sharing aspect. We're talking about all the requirements that we have as town clerks and registrar of vital records to maintain these records for posterity, for forever. And we are concerned about that aspect as well.
So you want it to be maintained as long as it's maintained by the neighboring municipalities, right?
Absolutely. If it's going, yes, as you know, at this point, we take care of the towns of occurrence, and then that information obviously is shared with other towns if necessary for other needs. And we want to maintain the sharing process and the integrity of the documents themselves.
So perhaps what you're saying is that you want the bill to be modified slightly rather than saying that you're against it.
I could see that being an appropriate answer.
Okay, I appreciate that. Thank you so much for your help.
Yes, sir. Have a good night.
You too. Bye-bye. Next person on our list is Joyce Rowe. I hope I pronounced that accurately.
That's quite all right. A lot of people get my last name incorrect. I'm Joyce Rio. I do want to thank everybody here for your time and the opportunity to speak. I am here to speak on Raise Bill 1 and 369 on behalf of the Connecticut Occupational Therapy Association. For Bill 1 and 369, our task is twofold around, or excuse me, our ask is twofold around home care worker safety. First, that the intake and collection of prospective client information includes whether animals are on the premises. And then two, that when a staff member reports an instance of abuse or dangerous incident, that the agency has a structured debriefing process or procedure in place for the employee or employees. We are also curious if this legislation captures all home health care work. For instance, occupational therapy practitioners are frequently members of home services through Birth to 3, school services for homebound students, in-home rehabilitation services, community mental health supports, home environmental assessments, and end-of-life care. And in fulfilling these roles, it's crucial for providers to be well prepared and informed of the environment that they will be entering. Examples of real and urgent risks faced by occupational therapy providers in-home have included dog bites, unpredictable client behavior, verbal assault and threats, unexpected presence of others, and lack of client background, insufficient information, and lack of mandatory training up front leaves providers vulnerable to potentially dangerous situations. Inclusion of healthcare worker safety provisions in legislation is not just a matter of preference. It is a requirement to perform our jobs safely and ensure clients' continued access to these services. For Bill number 1, our ask is specific to Section 36. We ask for the inclusion of both occupational therapy students and practitioners as work group members tasked with studying and making recommendations to address loneliness and social isolation. In 2021, the CDC highlighted the widespread occurrence of loneliness and social isolation affecting people across all age groups due to factors such as stigma, aging, health concerns. Occupational therapy practitioners understand this issue and address loneliness and social isolation by encouraging meaningful participation in social interactions, leisure pursuits, play, education, productive work. The results of such involvement in these activities result in boosted well-being, better health, and an overall improved quality of life. On a population level, we advocate for health promotion and the creation of compassionate communities, fostering support and connection to reduce feelings of loneliness and social isolation while improving overall well-being. At the group level, we focus on prevention and intervention for individuals experiencing loneliness due to disability or health changes. And on an individual level, OT practitioners, we intervene to guide clients to adopting new roles and routines that are personally meaningful, ultimately enhancing their well-being and satisfaction.
Excuse me, Ms. Roy, but your time is up. Thank you.
Thank you. Thank you for considering our requests.
Thank you very much for a number of substantive suggestions for us. Seeing and hearing no questions, we thank you for your work, and we will consider all of these as we continue to have conversations on this.
Perfect. Thank you so much.
Before we move on, I'll go back to Gary Sikorsky just to make sure he's not here in the room with us. I don't believe he is. Okay. Next, we have number 56, Laura Pryor, who is here in the room with us. Thank you for waiting with us. Welcome.
Good evening. Okay. Representative McCarthy Vahey, distinguished members of the Public Health Committee. I'm here in support of Bill 5488, Section 10. I want to thank the Public Health Committee for adding APRNs to Section 10 to allow them to utilize fluoroscopy. I am an advanced practice registered nurse working in radiology for the last 13 years. I perform fluoroscopy procedures every day, and it bewilders me that I cannot utilize the equipment in which I use to do the procedures. And I understand the gravity of patient safety and radiation safety. I think we've talked a lot about what fluoroscopy is today, so I won't go into that detail. I do want to talk about what the current state is of practice. The current state is if I'm performing a procedure, I am directing the radiologic technologist to utilize the equipment. My physician and physician assistant colleagues are able to utilize this equipment themselves. I feel that if APRNs are able to utilize fluoroscopy, it is within their job that it is necessary. We can actually increase efficiency of service and actually reduce radiation dose. When you have to rely on your colleague to take images at certain intervals, there are delays. I'd like to address some of the concerns that were mentioned earlier today. One of them was patient safety. As Section 10 reads, the education, training, and testing pathway, as endorsed by the American Society of Radiologic Technologists, would enhance the knowledge and proficiency of APRNs utilizing fluoroscopy. This is the same standards that our physician assistant colleagues are held to. And I do not personally know, and I've done some research as well, that there have been any adverse events or poor patient outcomes in the last 10 years. More than 10 years that physician assistants have been able to utilize fluoroscopy. The other issue that came up was the idea of us doing this independently. That has been a common theme mentioned today. I will mention that the hands-on clinical component in Section 10 is done with a radiologist. This fosters an environment of oversight, trust, and knowledge sharing. APRNs working with fluoroscopy is not a solo act. The radiology team is comprised of many members, and we all depend on each other. I do feel I need this to perform my job at the highest level of my license, and I have many colleagues that feel similarly. I don't entirely understand the restriction, and I feel that my physician assistant colleagues are able to perform these services. We work in the exact same capacity. Why can't I? I've been doing, again, this job for 13 years, and I feel I'm able to learn how to use the equipment and utilize it safely.
Excuse me, Ms. Pryor, but your time is up. Thank you.
Thank you. Do you want to summarize your thoughts, or are you good?
No, I think that's good.
Thank you for coming and, well, for staying with us for such a long day to testify and share your experience. So you've heard the conversation here today that many who have expressed the concern have stated that APRNs have the ability to practice independently as opposed to a PA who would be working under supervision. And I know you've shared a bit in your testimony, but how would you directly address that concern that some of the folks have expressed?
Thank you for that. APRNs working with fluoroscopy are working in a hospital setting, usually in a radiology department. And in that setting, we are under the supervision of an attending interventional radiologist.
Thank you for that. So I think that's an important clarification. I see Representative Denning has his hand up. Representative Denning.
Thank you, Madam Chair. Thank you for your testimony. I want to go over some things to distinguish so that I more clearly understand, because the scope practice between healthcare professionals has become very territorial. So I have been told that when an advanced practice nurse can practice independently, that she can do her, and the concern is that she could do, or he could do, her or his practice independently without physician backup if you should run into a problem. Is that the case?
I would say absolutely not in my work environment. As I believe someone said before, they were alluding to the fact that APRNs have no one to go to if they need help. That is not the case. Where I work, I have a supportive network. If I need help from radiologists, my threshold for asking for help is super low. And I call them in time and time again if I need to. And they are there in moments.
So what does supervision look like for the physician assistants? I mean, how does supervision look like for them? Is there a radiologist standing in the room, or are they watching, or what are they doing that shows that they're supervising?
So supervision, even direct supervision, is defined as being immediately available. Typically, that means in the building. They are not at our elbow. They are not necessarily in the control room. They are immediately available. So the nature of the relationship is such that they are immediately available for anything we need. So they are sometimes doing other things in the department, but they can break away immediately and help us. And that's PAs and APRNs in my department function exactly the same.
Very good. Is there any difference between the schedule that you run in the hospital of efficiency to move patients through versus what you do versus what a radiologist does versus what a physician assistant does?
So I think I did mention earlier increased efficiency, because there's things I noticed in everyday practice that makes a procedure a little bit longer, or perhaps a patient on the table a little bit longer, because I'm not necessarily in control of what's happening at that moment. It's very difficult to have to turn to someone and direct them to do something and say, oh no, do it this way, or move it that way, or go higher, or something like that. It's kind of counterproductive. And I love our radiologic technologists that I work with. So this is not about a workforce issue or encroachment. This is about me using a tool to do my job. And yeah.
Very good. I really appreciate your testimony, and that's the only thing I have for you. And thank you, Madam Chair, for the time to ask a few questions.
Thank you, Representative Denning. Seeing no other questions or comments, thank you so much for being here with us and for sharing your experience and perspective. We appreciate it.
Thank you.
Next on the list is Lee Ward.
Hello, good evening. How are you?
Good evening.
Sorry about that. Let's see here. Dear Senator Anwar, Kristen McCarthy Vahey, and other esteemed members of the Public Health Committee, I'm writing in support of House Bill 5488, an act concerning various revisions to the public health statutes, and in opposition of Senate Bill 440, an act concerning certificates of need. I am Leah Ward, a geriatric palliative care nurse practitioner in long-term care facilities in Connecticut. I am concerned that the language in Section 20 might exclude experienced nurse practitioners from out of state who transferring to Connecticut, as some did not have a requirement for a collaborative physician and their cannot transfer here easily to assist with the workforce shortage without finding a physician who may be prohibitively expensive or in short supply for the APRN run practices. As I am approached regularly by friends, neighbors, and the homeless cats at Torrington's overflow shelter that I volunteer for, who are looking for a primary care provider because they're either struggling to find a provider or feel lost in their current practices that are understaffed. I would appreciate making it easier for out-of-state APRNs to have the ability to transfer here and work for our APRN-run practices that serve the underserved without restrictions of any kind. This barrier affects the APRN-run practices disproportionately, as they cannot easily find or afford a collaborative physician and therefore cannot hire APRNs coming from out of state that may have many years of experience, but were not previously required to be supervised by a physician and were instead supervised by APRN colleagues. The body of evidence supports that such restrictive requirements for collaborative agreements with a physician decreases access to care, decreases the quality of care, and increases healthcare costs. In regard to the bill for certificates of need, I was hoping for some clarification if this could eventually affect hospices in the state. I used to provide on-call palliative care coverage for New York State that had certificates of need that only allowed 2 hospices per county. While it was just determined that 2 hospices per county should be sufficient, it rarely was, and especially not during the pandemic. The result was disastrous because the hospices often became overrun with referrals, were very restrictive of who they would accept, and would not show up for a week or more, leaving dying patients and their families truly desperate for services that sometimes didn't come before they passed away. Today, they have the lowest hospice utilization in the nation, surpassing Connecticut, related to their certificates of need for hospices. I'm concerned about the eventual impact of certificates of need on end-of-life care in Connecticut. Maybe you can provide clarification if it could eventually go that way.
Excuse me, Ms. Ward, but your time is up. Thank you.
Very good. Thank you so much for hearing me. I'm happy to take any questions.
Thank you so much. And thank you for sharing your concerns and your support as well. But in particular, with respect to the hospice piece, I know you're not the first person today who we've heard this from, and it's something we certainly will be exploring as we move forward. Seeing and hearing no questions, thank you for taking time to be with us today. We appreciate your testimony.
Thank you. Have a great evening.
Thank you. Next, we have Diane Kosenko. Welcome.
Thank you. Representative McCarthy Vahey and distinguished members of the Public Health Committee, thank you for allowing me to testify. I'm here about HB 5488, and it's Section 10. I'm a radiologic technologist. I'm the legislative chairperson for the Connecticut Society of Radiologic Technologists. I'm also a radiographer, and I'm certified not only in radiology, but interventional procedures and CAT scan. Our first concern is the scope of practice determination was never done for this APRNs being allowed to do fluoroscopy. And that's a concern of ours because that's where discussions and things take place. And we think that should be done. We think this should be eliminated from the bill and the scope of practice determination be done. Another concern is that less than half of the states allow fluoroscopy by an APRN. Another concern is that the independent practice of an APRN doesn't mean an independent practice within the hospital, as they're saying. They also work in outpatient clinics, radiology offices, but in some states, an APRN will own a pain clinic using a C-arm, which uses fluoroscopy. And as we've discussed, you've heard it earlier, fluoroscopy can give you a large dose of radiation. It can cause skin burns, a host of other things. And our concern is maybe in a few years, an APRN will open up a pain clinic here in Connecticut. So I think you have to think of the future when you talk about independent practice and allowing an APRN to do fluoroscopy. The other thing that we do have a concern about is the credentialing of the PAs is not public knowledge. It's not listed on the DPH's website. It's maintained by the employer. We think that should be put on the DPH's website so patients can see if the person doing the procedure on them has been credentialed and has taken that test. And we think language should be in the bill, or even for the PAs, to do continuing education in radiology. I'm sure they have a ton of education that they do. We all do in healthcare, but specific to radiation protection should be done. If you have any questions, I think I'm done.
Thank you very much for your testimony today and for
Thank you.
outlining your concerns in a specific way. We appreciate your perspective and the time you've spent being here with us today. Seeing and hearing no questions, we'll go to Barbara Pierce. Welcome.
Can you hear me?
Yes, we can.
Thank you. I'm Barbara Pierce. I live in Guilford and I'm CEO of the Connecticut Hospice in Branford. 50 years ago, we were founded as the country's first hospice, and we were the first hospice in the world to offer home care. 40 years ago, we originated the Medicare hospice benefit, which was signed into law in 1983 and has been used by millions of Americans since then. We are proudly not-for-profit, and more than 90% of our patients have Medicare or Medicaid. I'm here to oppose Senate Bill 1 as written, although we certainly support efforts to make sure that caregivers are kept safe. Hospice care needs to be eliminated from the covered entities due to its urgent and short-term nature. Our National Hospice Organization could find no similar bill in any other state. This bill is too broad, too unclear as to requirements, not guaranteed to achieve its aims, duplicative of other procedures required in hospice care, and contradictory to certain regulations of Medicare. Hospice care at the end of life is a critically important component of the healthcare ecosystem, although it is a very small part in this overall bill. We are in the business of fulfilling last wishes. Our simple mission is to make sure that nobody dies alone, afraid, or in pain. Our service is frequently sought at the last possible moment. Friday is by far our busiest day. We admit frequently at night and on weekends, and families are often dependent upon our admission to be able to bring their loved ones home to die if that is their choice. The statistics are shocking. 20% of our home care patients die within 3 days of admission. Since 2020, this has only accelerated. In the last few years, approximately 300 patients have died in our home care within 3 days, 200 within 2 days, and 100 within 1 day. If a law or regulation were imposed that in any way impeded our ability to admit urgently, we would see a huge drop in patients and families served. The list of proposed requirements in Senate Bill 1 would mean that most, if not all, of these patients would have died in a hospital, an emergency room, or at home without nursing support or comfort measures. Medicare requires that we start care within 48 hours, and we would simply not be able to perform the background checks outlined in that amount of time, especially on an evening or weekend. It also requires that we not discriminate, but checking neighborhood crime rates will almost surely cause some less fortunate families to experience delays. We already read patient medical records, send social workers to perform risk analyses, train on de-escalation and personal safety, and offer escorts when requested. We often go with more than one person. None of that will prevent every incident, but honestly, our biggest risk factor comes from grieving family members who are angry when they feel that our services are not delivered promptly enough. If we wanted to protect ourselves completely, we would not have taken dying COVID patients, and yet we did. All we ask is that you stop Senate Bill 1 from interfering with our critically urgent delivery of end-of-life care. I will end with a public service announcement to legislators. We want to prevent you from having to hear from grieving constituents who are outraged that background checks on their loved ones and families stopped them from receiving hospice care. Please
Excuse me,
don't let
Ms.
that
Pierce,
happen.
but your time is up. Thank you.
Ms. Pierce, if you could finish that thought and summarize, that would be great.
I got one more sentence. Please don't let that happen. Remove hospice from this bill. Hospice care is desperately needed and all too often urgently. Thank you very much to the committee for allowing me to testify.
Ms. Pierce, thank you for taking the time to be here and for highlighting your concerns. I don't think there's anyone here who wouldn't agree that hospice care is so important, especially here in Connecticut, where we've led the way. So we appreciate all of the things that you've outlined, and I know that we will remain in conversation with respect to this. And your statistics about the timelines in terms of 1, 2, and 3 days upon admission is very significant. There is a question or comment from Representative Rader.
Thank you, Madam Chairwoman. Barbara, I just want to thank you for your testimony. I got your email the other day, and just first of all, thank you for all you do for these families in their last days and weeks and sometimes hours. And I just simply wanted to thank you for your advocacy and pointing this really important issue out to us as a committee. So thank you.
Thank you for letting me do it.
Thank you, Representative Rader. Seeing and hearing no other questions, thank you, Barbara, for your work every day. It's so important, and for being here with us today. Next, Ed Finaro. Is Ed here? Mr. Finaro, if you're able to unmute yourself and go on camera.
Okay, let's see. All right, good evening.
Good
Can you hear me?
Yes.
Very good. Good evening, honorable members of the Public Health Committee. I know you guys have had a long day, so I'll try and keep my comments brief and to the point. I'm here to speak regarding present testimony regarding Section 26 of Senate Bill number 1, which addresses the requirement that a pharmacist must dispense a personal opioid drug deactivation and disposal system to a patient at the time such pharmacist dispenses an opioid to such patient. While I applaud the idea, and I'm in firm support of providing these deactivation disposal kits or any mechanism to potentially reduce harm caused by misappropriated medications, I oppose the wording. The requirement to provide such a system for every opioid prescription dispense is short-sighted, and I think it's extremely wasteful. From a realistic so first off, again, my name's Ed Finaro. I'm a pharmacist, owner of Visel Pharmacy, an independent, family-owned and operated community pharmacy. We've been serving the community since 1913. I've been a practicing pharmacist for over 40 years. But from a realistic and practical standpoint, patients that are prescribed opiates for an acute condition for a limited short-term use, that kit makes, or the destruction kit makes perfect sense. For a alternative, the patient's on long-term therapy, maintenance therapy, they're using their medications. They do not need just a deactivation and destruction kit presented with every prescription. So again, we all recognize the importance of harm reduction, but we feel that implementing a program to make these readily available through community pharmacies is a great idea. It can be promoted through public service campaigns, point of sale materials, but I just strongly feel that presenting or dispensing a kit with every opioid isn't going to be the right way to go with this. The system, the bill as it's written, is a little bit deficient. It doesn't describe how these kits are going to be provided. As there's limited opioid settlement funds, I think that the bill should specify, how these kits are going to be dispensed. We don't feel that it should put any additional burden on an individual community pharmacy. Pharmacies are the perfect place to provide these kits. Community pharmacists are recognized as valued, readily accessible healthcare providers. They're considered medication experts. We feel they should be fairly compensated to provide these kits, choose the appropriate patients that should receive the kits, inform the patients on how to use them. So the bottom line is that we oppose the mandatory dispensing of a kit with every opioid prescription. Instead, alternative, utilize the available funding to provide the systems and promote their use, and allow the community pharmacist to use their professional judgment to assure that they're dispensed properly and they're utilized effectively. And so that is my testimony. If there's any questions, I'd be glad to answer.
Thank you very much for your testimony. We appreciate your perspective as you're on the ground. And I have a couple questions and you probably don't have this data at your fingertips, but you're talking about the difference between an acute situation versus a long-term maintenance in the use of opioids or for pain management. In your experience, in your pharmacy, what's the breakdown in terms of percentage? Again, I recognize I'm asking you to guesstimate, and you likely don't have the actual numbers here, but if you can just give us a sense of that, that would be great.
Well, I think because of the restrictions with the dispensing or the prescribing of opiates, I think that number, the acute dispensing is down. Plus, there's usually a limited, maybe to a 7-day supply on their initial, as opposed to long-term maintenance patients. That's, again, I think that's our larger population. And one other point I should make too, if you're going to make mandatory dispense, I do not personally handle long-term care facilities, but there are other pharmacies that do. In a long-term care facility, those healthcare providers there cannot access the controlled medications that are in the packages, or their pill packs or pill boxes. So you've kind of made this mandatory. There needs to be a little bit more thought put into it, provide some exclusions on it. But again, in the big picture, I think that the right way to do it is leave that discretionary, not mandatory, for the community pharmacist.
Thank you for your testimony today, Mr. Finaro. Seeing and hearing no other questions, we will go to Sage Hoja.
Thank you very much.
Thank you. Thanks for being here with us. Sage, welcome.
Thank you. Good evening. Good evening, chairs and distinguished members of the Public Health Committee. My name is Sage Hoja. I live in Colchester. I work as a therapeutic recreation professor and a per diem recreational therapist at an inpatient behavioral health hospital. I'm here to testify in support of Bill Number 1, Section 36, the working group to help address loneliness and isolation in the state, along with adding recreational therapy as one of the work group members in Section 36B. Section 36 of this bill is crucial, as loneliness and isolation are not new phenomena or issues, but with the COVID pandemic, these issues were highlighted, exacerbated, and experienced by more individuals than ever before. We need to seriously look at remediating this, as loneliness and isolation have significant effects on one's physical, social, psychological, and cognitive functioning. Loneliness has been shown to contribute to increased risk of heart disease, dementia, mental illness, addiction, and suicide. and when experienced by children and adolescents, impacting academic performance, leading to substantial costs for our healthcare system and education systems. Not only can the epidemic of loneliness and isolation be treated, it can be prevented by placing a great emphasis on psychosocial determinants of health in our education and public health spheres. I asked that Section 36B include a certified therapeutic recreation specialist or recreational therapist, as the education and scope of a CTRS already addresses and encompasses so much of what the section hopes to accomplish. As defined by the American Therapeutic Recreation Association, recreational therapy is a systematic process that utilizes recreation and other activity-based interventions to address and assess the needs of individuals with illness or disabling conditions as a means to psychosocial and physical health, recovering, and well-being. Further, recreational therapy means a treatment service designed to restore, remediate, and rehabilitate a person's level of functioning and independence in life, to promote health and wellness, as well as to reduce or eliminate the active limitations and restrictions to participate in life situations caused by illness or disabling conditions. When individuals are suffering from a physical injury or mental illness, they need help learning not only how to live with the disability, but how to enhance their quality of life by reducing isolation and helping them to participate in leisure activities. As a recreational therapist, spending majority of my career in behavioral health, and as an educator, I can speak to my experience in working with individuals who hold some of the highest loneliness and isolation rates. This epidemic continues to diminish mental health, increase physical deconditioning and disease, and increase substance use and negative quality of life, all of which lead to significant financial burdens on our healthcare system and communities. As a recreational therapist, we utilize a strengths-based approach to help individuals through leisure education and counseling, leisure exploration, social skills development, leisure barrier navigation, and community integration work. Our field has been specializing in preventing and addressing loneliness and social isolation for decades. We want to further strive to end loneliness and isolation in our wonderful state by applying our clinical knowledge and experience to this working group. I'm in full support, and thank you for your time this evening. And if there's any other questions, I'd be more than happy to answer them.
Thank you so much. Thank you for taking the time to stay here with us and for sharing your work and your perspective in terms of how to address loneliness. And we appreciate that so much. Seeing and hearing no other questions, we will say thank you and good evening, and then say hello to Amanda Gunthel. Welcome.
Hi. Good evening, Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Amanda Gunthel, and I am the president of the Connecticut Association of Ambulatory Surgery Centers. I also serve as president of our ASC Patient Safety Organization and have been a center administrator in our ASC community since 2005. It's nice to see so many familiar faces, even this late in the day. I am here this evening to testify on Senate Bill 440, an act concerning certificates of need. The bill before you today seeks to streamline and modify key aspects of the Certificate of Need process in Connecticut, a welcome change in several key areas important to our ASC community, and we appreciate the committee's efforts in that regard. There are a few elements of the bill that call for additional clarification, but what's always foremost on my mind is that our ASC community, as the mainstay of low-cost, high-quality outpatient care, is given due consideration and the opportunity to participate in further discussions to support appropriate legislation by providing valuable industry perspective. I'd like to touch on a few salient points before my time runs out. We did submit written testimony, and so I will keep them brief. We would like clarification or confirmation regarding the ability to perform specific cardiology services in the ASC setting, which is how the bill reads and is consistent with current CMS guidelines, but is a departure from current statute. We would like clarification regarding conflicting statements related to facility relocation, specifically lines 64 through 67 and 175 to 178 for reference. We thank you for supporting a deemed approval process, and we also support the applicant's ability to request an expedited process when appropriate. Private equity, which has been a hot topic today. There is such great variability in how these relationships can be structured, and they can, irrespective of recent events within the state, be beneficial. Using our industry as an example, following recent years of significant industry headwinds like the ASC tax, the pandemic, now tightened credit markets and high interest rates. Increased access to capital and other support provided potentially by a PE relationship could prove to be helpful. And we respectfully request that these CON requirements be further studied and refined prior to adoption. Again, what I'd like to be, forefront in this testimony is our respectful request to be included in related bill discussions impacting our industry. I have been in attendance today since the hearing began, and I would also like to touch on a few points that were raised today. Senator Summers so appropriately pointed out that sections regarding PE involvement need to be better defined. Dr. Hergen I think I said that correctly, I hope I did a fine job of illustrating how his group has been supported by their MSO and related PE firm, and how that support has in turn allowed his group to better support the community by increasing access to Medicaid patients.
Excuse me, Ms. Gunkel, but your time is up. Thank you.
Okay, I will wrap it up. And then I just want to point out, as was discussed during his testimony, that the establishment of an ASC and material ownership changes are already subject to CON legislation. We thank you for the opportunity to address the Public Health Committee regarding this important piece of legislation.
Thank you.
I will do my best to answer questions and hope my dogs don't start barking or that my kid doesn't crash the.
What is the trigger word, Vilasa? Rep Denning.
Thank you, Mr. Chair, and thank you. I won't keep you too long. I'm very curious because I'm not condoning at all of private equity in healthcare, because the nature of private equity is to basically come in, purchase, and then sell what they don't need, decrease the amount of costs, and take the profit themselves. So can you explain to me, when you say that private equity in the outpatient surgery center is a good thing, and be specific if you can?
Well, I think the main takeaway from what I said is that there is so much variability in how those relationships are structured and what they can do, that it's important that the legislation doesn't prevent people from seeking those opportunities. And that could be access to capital. That could be administrative services provided. I take it that you were not present for Dr. Hergen's testimony earlier, where he talked about how that directly impacted his group and provided
heard that
specific
testimony.
Examples.
Yeah, I heard that testimony, but I was also involved with Prospect Medical, and I didn't want to go into all the details about how that adversely affected our group.
I understand that. And I think it's a terrible thing. And I just think that not all firms are the same. Not all relationships are the same. And so we should be cognizant of that as we look forward and look to adopt legislation.
So how do we do that as a state that knows that there are good players and bad players? What's the line of demarcation that we set?
I don't know the answer to that. I think we as a group can probably, we would be happy to participate in further discussions and offer suggestions, but for the right here and now, I would not be able to answer that.
All right, thank you for your time, and I'll let you get home to your dog.
All right, thank you so much. Seeing no other questions or comments, we'll move to the next person on our list, which is Joseph Kappa. Welcome.
Good evening. My name is Dr. Joe Kappa. I'm a board-certified gastroenterologist caring for patients here in the great state of Connecticut since 1993. I'm also chairman of my practice, Connecticut GI, where we care. That wasn't me, I don't think, right? Where we care for tens of thousands of patients each year in over 27 offices and that cover the local communities throughout the state, such as Sharon, Torrington, Norwich, Bridgeport, Stamford, New London, Enfield, Hartford, and Bloomfield. Our group is an independent medical practice and has always been proud to partner with the hospital systems in our communities to expand local locally and optimize cost and effective patient care. I oppose Senate Bill 440 and House Bill 5316. Now, both bills will make it dramatically harder for the independent practices to remain competitive to counterbalance the high cost of hospital care. Now, understandably, Senator Looney, Attorney General Tong, and this committee are looking for ways to address the deeply troubling issues at Prospect Medical. But I am concerned that the changes being proposed to our CON laws will throw the proverbial baby out with the bathwater. Capital investment in independent medical practice like mine is helping expand access to high quality, lower cost care in Connecticut. I do not believe that this important issue has ever been studied in the unique circumstances in our state where healthcare is dominated by 2 hospital systems and care in independent practices is becoming rarer each year. Here is my experience. My practice partnerships with our management service organization, GI Alliance, and you asked Senator Anwar the right question, managed service organizations need to be defined and understood. It has elevated the standard of care we delivered by expanding access, providing cutting-edge healthcare services, and enabling high-quality care to be delivered at a low cost. By analyzing data from nearly 3 million patients across 16 states, our MSO partner has helped to develop comprehensive care management programs for independent practices to lead the way to better healthcare outcomes for patients by minimizing unplanned episodes of care. And this directly benefits the patients in Connecticut who suffer from fatty liver disease, inflammatory bowel disease, and obesity, and kept these patients out of the emergency room and preventing unnecessary expensive diagnostic imaging studies such as CAT scan. It's helped reduce emergency room visits, and it's a great help to our hospital partners who can then serve more patients with acute care needs and serve them more quickly. Our partnership has also brought high-quality clinical research studies through the MSO partner, and we are now positioning our patients to get life-enhancing drugs. Here's a concrete example. Last week, the FDA approved a drug called Rezdiffra, which is for the treatment of adults with non-alcoholic fatty liver disease known as NASH. And this drug has the potential to be a game changer in our practice, in our patients with patients of fatty liver disease. And it's our partnership with the GI Alliance that's going to enable us to get patients access to these drugs faster at a lower cost than we have had before. By 2025, there is an estimated, we have to face reality, that there's going to be an estimated shortage of more than 1,600 gastroenterologists nationwide. And recruiting physicians to community practices like mine is a terrible struggle, especially in Connecticut. The GI Alliance, our MSO, has a sophisticated national recruiting program that has helped us to recruit new fellowship-trained gastroenterologists, with 2 more joining us later this year. We wouldn't have
Excuse
had
me, Dr. Kaplan, but your time is up. Thank you.
recruiting top doctors without our partner. In closing, our partnership has really allowed us to focus on being doctors. And I firmly believe that SB 440 and HB 5316 would limit independent medical groups from assessing necessary expertise and capital to compete in the current healthcare environment in our state. The people of Connecticut really deserve healthcare transformations that do not pose unstudied, disruptive consequences. And I ask that you please consider a bill that really studies how Connecticut is being impacted by hospital system consolidation, insurance company acquisitions of medical practice, and private
Thank you.
equity.
Perhaps you can address some of that in the Q&A.
Sure.
Representative Zupkus has a question.
Great.
Thank you, Mr. Chair. Thank you for coming. You mentioned Prospect, which is a problem, and the CO in the whole process is a problem, in my opinion. However, I do understand where you're coming from, and until we fix the problem or try to fix it, I don't believe we should incorporate anyone else in it. And you mentioned a study. Can you just tell me a little bit more about that?
I don't know the details of how this would be done, but I imagine I've been around for 30 years. And when I started my practice, I was with one individual. We grew to 83. I've watched the changes that have happened in healthcare in the state. I'm getting a little bit nervous and scared for my colleagues and the patients that we have to think about something. And I know when the word private equity is used and you look at that Prospect example and there's obvious concerns, and I really listened this morning and really understood what the concern of the committee is and of the state. But I think we need to study this a little bit differently and try to understand if we really believe in value medicine to our patients, high quality, low cost, can the investment from a private equity group through an MSO organization really do that? I don't know I'm assuming the answer is yes, but it would be great to understand that.
You raise a good point, again, because I believe we have to do something with the CON process this session. But we have to hold the Office of Healthcare Strategies somehow accountable and responsible, because what is happening, and it's been going on for years, like 15, 20 years ago, there was another incident in Waterbury and the CON process was messed up then. And so it's never been, it's gotten no better. And so I think we have to do something, but I think to your point, maybe a study on the other side of it without bringing everybody in. Let's fix what we have and let's do a study on it. So thank you. I think that's a good point.
Thank you. They're good actors and they're not so good actors. And the laws are made for not so good actors. And while it is working well for you, the issue is that the not so good actors have made us worry about the broader issues. There are groups within the state of Connecticut who about 2-3 years ago would have testified here exactly like you are. But now they would tell you that they have a very significant issue because one private equity was bought by another private equity, and now the ownership is somewhere else in another part of the country, and they are expecting to squeeze everything out of everybody who's working there. And so these are entities who have clearly different interests than any clinician's interest would be. And we're trying to make sure that if something like that is to happen, the state has the opportunity to learn about it before things go out of control.
I appreciate your concern and totally understand that. And we just, the trade-off is, and we learned that the CON process, how difficult, how burdensome, how slow it can become. The trade-off is trying to accomplish the goal of doing the right thing for our patients, but not slowing down the process where we exclude physicians and access to care that we may be able to offer. And that's the trade-off in question.
And I think that's part of one of the bills we are hoping to, but you make a strong point about the process itself. Thank you for your testimony. Thank you for being here.
Great.
Next person on our list over here is Christina Mukon. Christina.
Hello, Senator Anwar, representatives of the Public Health Committee, senators in the Public Health Committee. I'm Christina Mukon. I am the chair of Health Policy for the Connecticut APRN Society. I am a family nurse practitioner, and I am here to talk about SB 1 and HB 5488. I want to give you just some background that currently, as of last week's roster, there were 22,045 physicians in Connecticut and 8,602 APRNs. So we are a significant portion of the healthcare providers within the state. For SB 1, I want to congratulate you and thank you in support of the work groups on fatty liver in Section 20, as well as loneliness in Section 36. We support that. I'd also like to request that you consider including APRNs within those work groups. Again, we are a significant portion of the healthcare providers, and without our involvement, we are missing an important lens. For 5488, I do want to thank you for adding fluoroscopy. If you have questions regarding the scope of practice after, I am happy to address that. It does not change the definition of what we do as an APRN in any way, and I can speak to that more. I'd also like to request that you update the language on collaboration, as has already been spoken of by some of my colleagues. The current barriers to collaboration are not evidence-based. In terms of the collaborative agreement, we are the only state in Connecticut that's requiring that. You also have my written testimony, so I thought that my time might be better used addressing some of the things that came up previously. Senator Anwar addressed an article by Mary Mundinger and talked about diploma mills in 15 to 85% administrative versus clinical degree. I can definitely give you some more background on that and clarify that. Mary Mundinger actually in the same article very much references that there is robust evidence that APRNs have comparable outcomes with physicians. In addition, in terms of diploma mills, I want to stress there are not diploma mills regarding APRN degrees. The Higher Education Opportunity Act that was initially passed in 1965 and then reauthorized again in 2008 clearly defines diploma mills. All of the programs for APRNs are thoroughly vetted and accredited. The oversight of that accreditation is overseen by the Higher Education Opportunity Act. There is robust oversight. People are not graduating from places where they can get a license without having that oversight. They're not having that. So I'm happy to speak to that more, but I did want to make sure that we address that in some way. And I am happy to take questions. Those were my biggest components. Thank you.
Thank you for your testimony. Seeing no questions or comments, thank you so much. Moving to the next person on our list, here is Hannah Granfield Horton.
Hi, everybody. Happy night. I know it's been a long day. Hello, everyone. My name is Hannah Granfield Horton. I am actually a resident of Hartford, but I'm the Director of Strategic Engagement at the Governor's Prevention Partnership. Our statewide youth prevention organization is focused on supporting youth, families, providers, and communities with the best strategies and resources for young people across Connecticut to thrive. You heard many of them speak today. I am here today in support of SB 1, specifically Section 26, regarding personal opioid drug deactivation and disposal systems. This is a personal story. You've heard a lot from everybody else, but mine's personal. In 2017, my husband was diagnosed with an aggressive form of bladder cancer. Within weeks, he was prescribed his first opioid for pain. For the next 18 months, he was in and out of hospitals and treatments to allow him to live one more day. On September 29th, 2018, he entered home hospice. I went home from the hospital with over 50 fentanyl patches, liquid morphine, and a home comfort care kit to make him comfortable for his final days. He passed away on October 1st, 2018. My sons, when he was diagnosed, were 10. They were 12 when he passed away. Within hours, I knew that families, friends, and neighbors and community members would be at our house to pay respects. Our house was filled with those drugs that I mentioned. And I needed to ensure that they were removed from our home so there would be no access from my children or from my neighbors to get. When you have that volume of drugs in your home, you just can't bring them to a drug take back. So I had a local connection with the police department and they arrived at my home to take them. I'm not talking about a little, I'm talking about Whole Foods bags filled. This ensured that my sons and those paying the respects would have no access to these drugs. I know that my family was privileged that we could call the local police department and have them come. But put yourself in my shoes. In the early moments of grief, I had to stop comforting my sons and think about how do I dispose of these drugs? If an at-home drug deactivation system had been dispensed at that time with these medications, I could have just done this at my home, could have opened it up, added the drugs, added water, shake, 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 and throw in the garbage. Drug deactivation disposal systems are designed for personal use, and they enable a patient or caregiver to permanently deactivate and destroy opioids, safely destroying the unused or expired medications and making them unavailable for misuse, like the people who could have come to my house that day and had access. Something that we all need to think about with young people in our lives. So I thank you for spending the long day with all of us, but I ask that you support SB 1 and allow Connecticut residents to deactivate opioid drugs at home permanently when they are prescribed. Thank you very, very much.
Thank you so much, Hannah, for being here with us throughout the day, and thank you for your advocacy and sharing your information and personal story with us. Don't go away. We have questions. Representative Cook.
Hannah, thank you, and thank you for sharing your story. I'm so sorry for your family's loss. Your story is like many that we don't ever want to have to hear. I appreciate you coming to talk about something that's a simple fix in theory, right? But as like different towns give away like the small bags, right? But you would have to go pick those up. Are you recommending that it's something like much larger, or what are you referring to that we might need?
Yeah, so my colleague Kelly Juleson is actually gonna, I think, testify next, but I could have her come up and she can actually show you the pouches that we're discussing.
We should have let them go together.
Potentially, yeah. So Kelly, you can do your testimony right now too. We'll multitask. Thank you.
DIY app.
It's good to see you all. Thank you for your time tonight. Thank you for your question, Representative Cook. I'm Kelly Chulson. I'm the co-president of the Governor's Prevention Partnership, where I have the good fortune of working with my dear friend Hannah and many of the youth who you saw earlier today. We actually have partnered with Deterra, the drug deactivation kit and pouch maker, for an earmark. They're not called earmarks anymore, but congressionally directed spending project. We have 50,000 of these that we're giving out in Greater Hartford and Greater New Haven to take more than 6 million pills out of circulation here in the area. And so this is actually the kit that we're suggesting that would be giving out. Each of these kits, you could put 45 pills into, or 6 ounces of liquid. And I'll show you how it would work. And so our suggestion is that these go home with folks. It's not meant to take over or replace like drug take back days. It's supposed to be a complementary option. It's just, just ways that more people can access this important type of disposal. And I want to underscore too, that it's not just about throwing them out. As we heard earlier, you don't want to flush your medications down the toilet. You don't want to throw them out because of the threat of misuse. This actually is an adsorption process, so that the medicines themselves are fully rendered inactive and can't be retrieved for any practical purpose. So I have some medication here. I'm just going to throw one in. So again, this could be 45 pills could go in here. I'm going to add some water. Shake it a little bit to get the air out. You can hear the sizzle. And so then within just a few minutes, these are totally rendered inactive, and you can throw it directly in your trash. So the great thing about this for us is in terms of preventing any potential for misuse, it's just so critical. The thing that I would encourage the committee to think about is, yes, that there would be an out of pocket expense, or out of the general fund, out of the opioid settlement dollars, wherever. But until 1986, we did not have a seatbelt law here in our state. And now we have, I think last year, the number were 367 deaths in Connecticut from car accidents, whereas we had 1,452 overdose deaths from opioids. And so on our public health department's website in Connecticut, you're more likely to die from an unintentional overdose than you are in a car accident. So shouldn't we be taking proactive and preventative measures, such as something as simple as putting on your seatbelt, or properly disposing of your medications and deactivating them to prevent that from happening to begin with?
So I agree with you. Actually, I've given my kids those to take back to college. And I picked them up at one of the like the community activist fairs that we've done. But my question back to that was, do they make those larger?
Yeah.
So that would be the question. So like, if you have a situation like was just being discussed, or like with my mother-in-law, similar situation. So when she passed away, we had a good amount of medication. Same with my father-in-law. When my stepmom died, she had an insurmountable amount of medication that could have done a significant amount of damage had we not disposed of it in a different manner. But it would have not fit in that bag. Right?
Yes.
None of the 3 circumstances, and I'm feeling that the circumstance that was just shared as well would not fit in that bag. And I think that if we had that one large bag, and so could you explain that if it's out there, and where do we access that?
Yes, they are available through Deterra. They have larger pouches that will deactivate, I believe, up to 140. I will double check the numbers on that for you, Representative Cook. Or you could get like a larger container that would be almost more, I would liken it to like a milk jug. That you could put your medication in. It still has the carbon in the bottom, and then you add water. And so that would take a much larger quantity. Something like this would be coming home with your prescriptions, hoping that you would use it more regularly. And so that you wouldn't have that type of, and certainly understand at the end of life that there could potentially be several, that you might need to use several of these in those instances, or we could provide a larger pouch.
Thank you. And I wish that we would stop forcing people to get 90 days of medication, and we might not have this problem either. So
Amen.
thank you.
Rep. Carpino.
Thank you for being here. And I've used them, so I'm very familiar with the process and how helpful they could be. And thank you for sharing your personal story, because, right, that's what matters. Sadly, you've lived the experience. But I do get concerned when we talk about a single product by a single manufacturer. And I'm going to be very, very honest with you. So how do we bridge the gap by making them available and yet not forcing them on anybody who gets a 7-day prescription or a 14-day prescription. So an end of life or hospice when my uncle passed, and you're right, the volume of necessary meds in a home is very different than, because of the good work we've done here, right, is very different than the 5-day or the 7-day prescription. So where is the appropriate middle ground where we're making them available and yet we're also not running up costs and filling folks' bathroom medicine cabinets with things they may not use because it's there so often, right? It becomes commonplace versus hi, you have a very large prescription of something you need to really be aware, right? Because if it's anything stays on our counter or, in our kitchen drawer too long, it becomes common and we perhaps forget it's there. So where is the sweet spot so that we are having an impact, but being responsible?
I think that's a great question, especially looking at the numbers for opioid and benzodiazepine prescriptions here in the state, which I think is around 6 million. And to the earlier pharmacist point that, there's a difference between someone who's a chronic user versus an acute user, and that they're going to, in the case of chronic use, that they're going to go through those prescriptions. Our recommendation, and from best practice standpoint, is that everyone in Connecticut would receive one of these twice a year, because it's not just for opioids, it's for anything that we have left over. And so that would be something to pull back on. Certainly the number, it would expand the net in some way, but it would also reduce it too, because it would be fewer homes that, well, it would be all of the homes that would receive them, but there would be a fewer number of pouches distributed. And if I can go back to something that you mentioned initially, although you didn't ask a question on, in terms of the company and choosing this, for us, it was about deactivation. It wasn't about the company. It was just about the science. And to our knowledge, at this point, there's no other company that actually can fully deactivate what is the medication itself. Some can create like a congealed matter that you could actually pick apart the congealed matter and you could still access the substance. And so for us, the deactivation was what was so critical. It wasn't just the disposal.
Thank you. And I just want to make sure I understand. Initially, you said every person in the state get 2. Then you said household.
I'm sorry.
I just want to be clear that I'm understanding because there's a very big difference.
Yes. Our suggestion would be a household perspective. So about, I think it's 1.4-ish million households in Connecticut, that we could look at something like that just from a dollar perspective versus every individual.
All right. I will continue to listen. I'm a little more inclined to allocate X number to our towns. And I've always been a large proponent of, and I know you both are as well, otherwise you wouldn't be here, of sharing the message locally so it's not lost. And I struggle with whether or not we make them available like they are in my community, so that those who need them are willing to take them and use them with those who are using larger doses, perhaps given something on a more regular basis. But I do worry about the cost benefit analysis of having every household randomly getting 2. But I thank you. It is a great product. I know we've used it for antibiotics in my home because we don't want that in our groundwater. Thank you, ladies. Thank you, Mr. Chairman.
Thank you.
Thank you, Representative Zupkus, followed by Representative Claritas Teacher.
Thank you, Mr. Chair. Thank you for coming. I think it is a great idea. When my mother-in-law died, we had tons and tons of medicine, and they said put it in kitty litter or coffee grinds. I'm like, first of all, I can't drink that much coffee, and I don't have a cat. So what are you supposed to do? And that's seriously what they told me. And so what do you do, right? So I get it, but following Representative Carpino, those were my thoughts exactly. Like, I think every household getting 2 is a little much. Maybe we can think about when, and again, to Representative Cooks, I think the bigger issue, or one of it coincides with it, is the amount of prescriptions that are going out. So to me, it's kind of a 2-prong. We need to look at both of that. But I do, as Representative Carpino said, I do have a problem putting in law something that one person, one company does. I mean, it's like us we're putting a monopoly and this company's going to make millions. Now, saving lives is important and there's no value. I mean, that's priceless to save a life. However, I think maybe if you get a prescription and maybe somehow that goes with you, or if it's end of life, maybe somehow that can be, shown you or something. I'm just not, I do share the concerns that they both have. So I just wanted to say that, but thank you.
Thank you.
Representative Claire Teacher.
Thank you, Mr. Chair. Thank you, ladies, for being here today and giving us a lot of really important information. My first question is, does this packet ever expire?
No.
Great. Second question, to go off what my two fellow legislators said, I think there's room to work with this as a compromise. Other options are when someone fills a prescription, you could ask them if they want it. Also, would I have the ability at some point to call the pharmacy and ask for one of them? That would still be, I could, if I get to the point like you mentioned, someone mentioned, if I need it, then I'll just call and go pick it up. But if we inform people that these are options they have, then I don't want to say the word waste, but I don't want to give it out if no one's going to use it. It's going to sit there, going to throw it out. So that would be wasteful. And I think it's important for us to just think of all those things moving forward. But thank you for the great work you do, ladies.
Thank you.
Thank you, Mr. Chair.
Thank you. There are four things that are coming to my mind. One is, of course, the education. That's always in the picture. The second part is working with DEMIS as a part of the harm reduction strategy, because they are already looking at a lot of harm reduction opportunities. The third one is that at any pharmacy, they should get the information how to order it if they choose to. And the fourth one is through the grant, whether it's from the federal or the state, to be able to identify individuals with specific prescriptions to be able to get it. So these are the four options to be able to fulfill this, at least I can think of. I have some of my colleagues online. We have Representative Parker, who has his hand up, followed by Senator Gordon. So Rep. Parker, you're on.
Thanks, Dr. Anwar. And thank you folks for being here, for sharing your stories. And Kelly, thank you for coming over here to speak about this. I know we had a chance to talk briefly. I think the question I have for tonight is, and I appreciate some of the concerns that some of my colleagues have raised. Is there evidence that shows that these disposal and destruction programs have a meaningful impact on lack of diversion, and then ultimately decrease opioid deaths on a broad scale? Has this happened in other places that we can look to see if it's effective? Or are we sort of at the front edge of this? It occurs to me that it seems to make follow logical sense that if there are less drugs in the home, as we heard about, there would be less chance for diversion. But does that actually, and I don't know the answer to this, is that what's leading to these hundreds of thousands of opioid overdose deaths that we're seeing every year, the 1,300 a year, the number that you mentioned? So I'm wondering, is there evidence yet that ties those two pieces together? Is this a good idea or one that's actually been proven to be impactful?
So there is data from Deterra, which of course is the company that we're talking about here for drug deactivation. And there's economic data. There is other information just in terms of how quickly someone will use the packet and how the propensity, if you have the packet, if you're going to use it. But I don't want to get too far out over my skis on that, Representative Parker, and would love to be able to get you with that. As you know, Jason Sunby, the Deterra CEO, was here earlier, and I think he could have answered those questions better. We are here as the Governor's Prevention Partnership, and our emphasis is on youth prevention here in Connecticut. So if you would allow for us to follow back up with that information, I just don't want to overstep or overspeak.
I appreciate that. Yeah, I'd asked him to send along that information as well. So it sounds like that will be the good point to look to for it. So I'll certainly do that and appreciate the work that y'all do. I'll just go ahead and say briefly that, the idea of using funds directly from the opioid settlement funds without going through the process that we set up would seem to be a real problem to me. So I look forward to finding other ways to think about funding this, but very grateful for the work that you both are doing and for the time you spent with us tonight. Thank you, Mr. Chair.
Thank you. Senator Gordon.
Thank you, Mr. Chairman, and I appreciate the testimony, and certainly trying to prevent drug diversion and improper use of drugs is something that's been talked about and tried to be dealt with for many, many years. I know it's been something that's those of us who prescribe narcotics, which I do as a cancer doctor on a daily basis appropriately, we're well aware of and try to educate our patients. But I have a logistical question. if one is going to be giving these out to households once or twice a year, if I heard the testimony correctly, what actually is a specific estimated dollar amount of doing that? I just want to make certain I'm understanding that, because certainly doing this, if one does it every year, there's going to be costs, and costs go up over time. And one has to think about the logistics of funding it, but making certain that if one's going to fund it, that one is aware of what rolling costs each year might be, to be making certain that there are funds available. Because if in 1 year the funds go away, then the pouches aren't given out to households. So that's my question, is what is the estimated dollar amount from what you're advising once or twice a year to households in Connecticut?
I think the estimated amount for that would be around $8 million annually.
Thank you. That's all. I just wanted to understand the dollar amount. Thank you, Mr. Chairman.
Thank you, Representative Wiehlander.
Thank you, Mr. Chair, and thank you for being here tonight. I also share many of my colleagues' concerns about using one particular company for however worthy a cause. We want to make sure that we are being responsible with taxpayer dollars. And I'm not suggesting that this wouldn't be, but I do think that we need to look further. But given that the fact that this is aimed specifically at youth right now, that you're testifying to, the youth prevention and the safety of our young adults, has there been any discussion or exploration of the idea of having a certain number of these packets available at either a school through the school nurses or through a youth services program in each municipality?
So that's actually some of the work that we're doing right now, Representative, with the Congressionally Directed Spending Project. We are working with community agencies to get those pouches out. And I'm sorry, I'm not sure if I'm supposed to be looking here, if I should be looking back at the committee, but so we have been working with the City of Middletown, for instance, or the Connecticut Business Industry Association, the Connecticut Realtors, to be bringing the pouches out through community means. And I know that one of the young women who spoke earlier, who is from the Sports and Medical Sciences Academy here in Hartford, she's planning to bring it to her school. So they are conversations that we are having, and we are actively in a community distribution approach. In the last 5 months, we've distributed more than 15,000 of these pouches. Most recently, yesterday, we were at the Hartford 5K with our partners with the Hartford Marathon Foundation. So we have been getting them out. We, in some cases, have had youth as the ones who are delivering the pouches. And so the short answer is yes, and the longer answer is there's a lot of ways that we've been doing it to date.
Thank you very much for that information and that answer. And thank you, Mr. Chair. I look forward to continuing this conversation.
Thank you, Representative Tersiak.
Thank you very much, Mr. Chair. Thanks, folks, for coming. It's great. I'm not particularly concerned about you're dealing with one company. Did I understand you correctly? These are the only people making a system like this?
To our knowledge, they're the only company that are making ones that are deactivated, and that's based on findings from NIDA and the DEA that actually can prove deactivation.
Great. Somebody's got to be an early adopter when new technology comes along. Early adopters help spur acceptance. They invite new players to compete in the marketplace for whatever it is that the early adopters have adopted. If Connecticut, pretty decent sized market, goes with these folks regularly, we're inviting other companies to see if they can get involved in this technology with whatever means they do it, and if they can charge less for it. If we don't do this, we're in the situation we are now, where there aren't any apparent companies working hard to be competition for this product, and nothing in particular other than wanting to do good and save lives, maybe, to spur one on to doing research in this product. So personally, sorry, it's not a question, but personally, I'm not afraid of the fact that there is no competition and we would be going to one provider. You know, we have electric cars because one company started making electric cars. It's the way it's what do I know? I believe it's the way, it's one of the ways business works. So thank you very much for your good ideas. How many a person gets and where, those are details. The big idea is you've brought us something that will make the meds unusable, not just hide them, not just make them untasty. But thank you very much. Looks like a good thing to me. Thank you, Mr. Chair.
Thank you. That was more of a comment. Thank you for your comment. And I have Rep. Mara online. Thank you. Remote.
Thank you so much, Mr. Chair. And I really appreciate your testimony, and I'm trying to look into more to understand these deactivation bags a little bit better. It looks to me like it's proven to deactivate opioids. But do you have any studies on deactivating something like Ritalin or any other drugs?
Want to take it? So yes, they are they are able to deactivate pretty much anything that's over the counter, prescription, illicit. I will say that things that have minerals from the earth, such as iron, they would not be able to be deactivated in a product such as this.
Okay, and can
Certainly
you
share
make
that with you?
Okay, yeah, if you can share that, that would be great. And I guess I have some reservations. I mean, it's not like this is the first time that we've thought about drug takebacks and stuff, and we clearly have drug take-back boxes in spots in all municipalities. Most police stations, I think, have it. A lot of pharmacies have drug takebacks, because I can't imagine that this is going to be the answer when you have huge amounts of drugs that you have to take back. This seems like something better for small amounts, really. I mean, I know you said you had a bigger bag. And then I guess I have some questions about handing them out to kids, because kids really shouldn't be in charge of their medication. And then lastly, I know I know we have to take a multi-pronged approach for drug addiction and opioids, but really when it comes down to it, most of our opioid deaths are from fentanyl and illicit drugs. So they're not necessarily, I mean, I know we have drug deaths that would be from pharmacy stuff, but most of them are from the illicit drugs, which I'm guessing people are not going to have bags for. So, just some thoughts and where my head is. So if you have any comments on that, I would appreciate it.
I would just make one comment over youth substance misuse. Of those who are going to misuse prescription drugs, 50% of those get those from within their own home or someone that they know. So I think that that's an important, it's a gateway, if you will, for prescription drugs to turn into other things. And I think that that's important to note in considering that high statistic of just young people who misuse right now.
No, thank you. I appreciate that. And which is why I think that probably needs to come out probably still through the pharmacy and not really at the youth level, because they're not really, I mean, it should be the parents that keep their drugs away from their kids. Okay. Anyway, thank you very much, Mr. Chair. Appreciate.
Thank you. Wow. Quite a bit of a conversation. We're going to be up all night. I don't see any more questions and comments. We have exhausted this except for the formula, which I will not ask online right now. We're going to try to make our own in the state, and then we would save some money. But thank you for your testimony. We appreciate you guys being here.
Thank you very much. Have a good night.
Thank you. Next is Jamie Rodriguez.
Hello, thank you for staying with me. Chairman Anwar, Chairman McCarthy Vahey, ranking members Summers and Clarisdichia, and members of the Public Health Committee. My name is Jamie Rodriguez.
a licensed marriage and family therapist, and the advocacy chair of Connecticut Association of Marriage and Family Therapy. Thank you for the opportunity to submit testimony on behalf of CTMFT in support of HB 5488, specifically Section 4 of the bill with the technical revision to the MFT licensing statute. CTMFT represents over 2,000 marriage and family therapists employed in various clinical settings throughout the state. MFT treat residents with private insurance, Medicaid, and as of January of this year, I'm very happy to say the addition of Medicare. After many years of advocacy on the federal level, last year, Congress passed legislation permitting MFTs to be enrolled as Medicare providers effective January 1, 2024. Yet MFTs in Connecticut are still experiencing roadblocks to enrolling as Medicare providers because of the requirements in the Connecticut licensing statutes. To serve patients, Medicare requires that all licensed MFTs must have at least 2 years post-graduation experience or 3,000 hours of clinical supervised experience. The current Connecticut MFT Practice Act states that licensed MFTs are required to complete 12 months of postgraduate experience, including a minimum of 1,000 direct client contact hours. CTMFT supports the change in Section 4 of HB 5488 from 12 months to 24 months work experience. Changing Connecticut statute requiring a minimum of 2 years experience versus 1 year will place Connecticut in line with other states and CMS requirements. Connecticut is the only state that requires only 1 year of supervised experience that doesn't also meet the CMS hour standard. Marriage and family therapists count their clinical hours differently than other mental health providers. 1,000 client contact hours for an MFT is basically 1,000 sessions. Other mental health providers acquire 3,000 clinical work hours that can include sessions, but also include non-direct client care such as documentation, phone calls, work team meetings, etc. In order for an MFT to complete 1,000 client contact hours in a 1-year time frame, an MFT would have to see a very high number of patients per week with little to no missed appointments, sick days, vacation days, etc. The average MFT completes 1,000 clinical hours in approximately 18 to 22 months. The passage of HB 5488 would have minimal, if any, impact on MFTs seeking licensure while ensuring that all Connecticut MFTs can enroll to be Medicare providers. Some Connecticut MFTs are currently being denied recognition as Medicare providers due to the Connecticut work experience requirement. The current proposed language in HB 5488 would satisfy CMS regulations for any Connecticut future MFT to be licensed as a Medicare provider after the passage of this bill. However, over 2,000 currently licensed MFTs would still be held to the standard of providing additional verifying documentation to be considered Medicare eligible. CTMFT respectfully asks the committee to add the additional language in my written testimony to grandfather all currently licensed MFTs in the new changes of the bill and to set the effective date of upon passage to Section 4 of the bill. These changes will ensure that there are no further delays to MFTs seeking Medicare enrollment and will quickly increase the mental health workforce for Connecticut Medicare patients. Thank you for your time and patience on this long day to this very important matter, and I'm open to any questions you have.
Thank you so much for your testimony, and thank you for giving us a written testimony because there are some specific recommendations that you have made, which we will look at critically. So,
Thank you.
seeing no questions or comments, we want to thank you for being here.
Absolutely. Thank you for having me.
Next person on our list is number 67, Dinesh Kapoor. Dr. Kapoor, sorry we had you wait. Welcome.
Well, thank you. Thank you, Dr. Anwar, Senator Anwar, Representative McCarthy Vahey, and members of the committee. My name is Dinesh Kapoor. I'm a physician, a board-certified hematologist and oncologist, and I've been in practice for the last 25 years. I've been in Connecticut for 35 years. I've taught at University of Connecticut. I'm the president of the Connecticut Oncology Association, as well as president of my independent medical practice in Eastern Connecticut, known as Eastern Connecticut Hematology and Oncology Associates. And we care for thousands of patients in any given year. I'm testifying today because I'm very concerned about two bills specifically, and I'm testifying in opposition of Senate Bill 440 and House Bill 5316. The bills threaten practices like mine, smaller practices, to continue providing cutting-edge care in their own communities. I I'm very impressed by what I heard all morning and all afternoon as well as evening about your concerns in light of what happened with Prospect Medical Group and their private equity venture that went bad. But I feel that not every private equity venture is like that. And we should not be using a broad brush to paint everybody in the same. And that's why I urge you to reconsider Senate Bill 5319 that was just discussed last week. And you heard last week about looking at and studying the impact of private equity in the state of Connecticut when it comes to delivering healthcare in the state of Connecticut, and not just look at what management services organizations or MSOs, which are private equity backed, are doing, which may be detrimental to the state. And rather, from what I'm hearing with multiple groups, it has been very positive experience in the state. My practice partnered with OneOncology, which is an MSO, 5 years ago. And the reason was we were seeing all kind of consolidation happening in and around us between the two networks. And by the way, we are the only private and independent practice in North and Southeastern Connecticut. As we partnered with them, COVID hit. And we would not have been able to survive COVID because of supply chain disruption. We would not have had steady flow of PPEs and other vital supplies, like simple things like normal saline, which was in shortage at that time. But we were able to get all these things for our patients. Our patients' treatment could not stop. And it did not stop in our practices. Even now, after the pandemic, a simple medication like cisplatin, which is curative for patients with testicular cancer, we had a hard time getting it because there was a national backlog and national shortage. We were able to get those medications for our patients. These are medicines for young patients, and they are curative. Our patients also benefit from OneOncology's physician-led research network known as OneR, and we are able to adopt the latest software technologies, latest clinical trial software management program in our practice that would be very expensive to afford for a practice as our size. And I'll just also give you one example, or two examples actually, of two just-in-time trials that happened. When COVID hit, Dana-Farber could not open clinical trials in Boston. They sent patients to our practice because we could open just-in-time clinical trials since we have a robust research department, and we could open those trials in 2 weeks. Once they opened their trials, the patients were transferred back to them.
Dr. Kapoor, I'm sorry, but your time is up. Thank you.
Okay, I just would like to conclude a couple of things, which is we would not be able to recruit physicians if it was not for OneOncology's recruiting arm as well. I would also like to say that in order to deliver cutting-edge cancer care, you don't need to be in a big network. You can do it in a community at 1/3 the cost of care that is being charged at the bigger institutions. This was demonstrated in the New England Journal of Medicine study that was published in January 26th of 2024. So in summary, I believe that Senate Bill 440 and House Bill 5316 will result in many more independent medical groups either closing shop or being acquired by hospital networks or insurance companies or what else is available. Right step would be to look at this, study this issue before jumping the gun and saying that this is what we think can be done. Let's not take everybody in the same group, and let's really study this issue like we have done with everything else. And I'm really very thankful to each and every one of you. This has been a long process for you because I can see it sitting through the meetings. It has been very enlightening for me. So thank you for your time.
Thank you, Dr. Kapoor. Now you know where I spend my days, right?
I absolutely do. I have a new appreciation for all that you all do. This is truly an eye-opening experience for me.
And then we share a lot of patients. I want to thank you for the care that you provide in the rural part of our state, which is very critical. So if I understand you correctly, what you're saying is that for oncologic medication, there is significant investment that is needed And some of these companies allow you to be able to have those medications and also specific tests and capacity to be able to provide care?
Absolutely. So we are the only practice, and I know it for a fact, we are the only practice, only independent practice in Connecticut that is providing bispecific antibodies in their practice. These are medications that are done in tertiary institutions, whether it's Yale or bigger hospitals, Hartford Hospital, etc. They're not done in smaller locations. Along with that, some of the new testing modalities that are provided to us, we would not have access to those either.
So the question comes down to is that these companies, their main purpose is to be able to make money. So what would happen to the Medicare and Medicaid patient? The same questions we've asked everybody else.
So OneOncology is a physician driven organization, and it is throughout the country. In our practice, we are treating something like 12% of our population is Medicaid. We do not turn patients away. In our practice, we have been caring for these patients for the last 35. Actually, the practice started in 1985. So for the last 39 years, we do not turn patients away. And in fact, if anything, the Medicaid population in the state that we are seeing in our neck of the woods, North and Southeastern Connecticut, has been going up every year.
Okay, thank you. I see Representative Denning has a question.
Hi, good evening.
Good evening.
So explain to me how your practice works when you have basically a venture capitalist group that has come in and has decided to invest in your practice, that they believe that you are providing such a great quality service and you are making profit at a higher rate because you're smaller, and they believe that they can take some of that profit and take it off the top and still provide the same level of care. Am I correct?
Well, there are multiple aspects to that question. And the first one is it's synergies of scale. I am able to get supplies because of the volume of OneOncology. We're able to reduce our cost there. We are able to reduce the cost of employee healthcare. We are able to reduce the cost of medical malpractice for our physicians, and everything else that comes along with it. And that's how you are able to benefit with a management services organization.
So, but you're part of that management services organization, correct?
Yes, I am. No. My practice is independent. So my practice is still independent. We have an affiliation with a management services organization.
So you collect a salary from your individual practice our
practice is comprised of 6 physicians, and the practice pays the 6 physicians. OneOncology does not pay the physicians.
No, but you collect an additional fee for being part of that management services.
No, the fee is we pay OneOncology a fee for getting the services back from OneOncology.
So you don't make anything from the management company at all?
We do not make anything from the management company. In fact, the one thing that we make from the management company is we're able to get our supplies, our insurances, and benefits for our employees at a much cheaper rate than we would as a small 6-physician practice.
Right, but I thought you said you were part of the management.
No. The management services organization is OneOncology. The private equity group is funding OneOncology. OneOncology is managing the services that they're providing us.
And you get no gain from this at all?
No, we get the gains. I already said we get.
Other than your regular practice.
We get the regular management. We get the regular benefits of this. We have a small equity portion in OneOncology.
Aha. So you have an equity portion in the group.
Mm-hmm.
May I ask you how much that is?
Cannot disclose that in this forum, but independently, yes. I mean, I'm bound by legal issues.
Okay, I understand. So you're collecting your fee as a provider, which I don't deny you, as well as being part of the private equity group that came in that allowed you to buy and scale. And your reward for signing on to this was to become part of the management fee benefit. I mean, you can't tell me how much, but you're making some profit over the fact that you signed on to this management.
No. So that's what I'm saying. So the profit that you're making is on the savings that you're getting from all the purchasing that you're doing and reducing your overhead for your employees, whether it comes to health insurance, whether it's come to malpractice. So every little piece, you're reducing the cost of care, cost to the practice, not cost of care, but cost to the practice.
Right. The cost of care is not going down at all. You're still charging the patients the exact same amount, correct?
That is by law, you have to do it. I can't, it's not like what I'm doing. It's everybody has the same fee schedule. So I cannot charge over the fee schedule, or I cannot charge under the fee schedule. Because if we charge under the fee schedule, that'll be construed as inducement. If I charge over, that'll be charged overage. And both of those would be very illegal things to do.
Right.
So nobody in the state of Connecticut can overcharge, undercharge. Now, what the difference is, in the state of Connecticut, currently, we have two big networks that are charging a heck of a lot more, which is 3 times what we do in our infusion centers with chemotherapies, infusional medications. And on top of that, we are giving them facility fees. We're giving them 340B incentives. We're giving them total monopoly in their neck of the woods. And I think that's where the problem is in healthcare delivery.
Well, I understand the lack of competition can be part of the problem. What I see is I'm not financial. I'm a nurse. That we don't know that much, but I do know that people who come in to give money to build these kind of institutions don't do it without the gain of gaining the profit of these institutions. And what they've done is they're saying, we'll take some of it, but they're also giving some of it to you, but you can't disclose that amount. And my question is, if I really want to reduce healthcare, I want to figure out how I can get you the same goods, services, insurance, and scale without having somebody take that profit and return it to somebody who's an investor and put it back into patient care without, like you said, being illegal. And so this is my problem with having people whose goal is to take money out of the system, which was meant for patient care, and instead is being paid to either physician providers, administrators, investors, in return, instead of going towards patient care. Does that make sense to you?
No, it doesn't, because you're not taking money out of patient care at all. What you're doing is you are actually buying, just simple example, you're buying normal saline. Instead of buying maybe 100 that we buy, OneOncology buys 10,000, let's say, hypothetically. The discount that I get on buying 100 will be maybe a buck. Discount that OneOncology for buying 10,000 might be $3 that they're getting. They can't charge anything more by giving IV infusion. So that part is absolutely a fallacy, that you're charging patients more or you're charging somebody else more. No, you're actually reducing the cost of care by doing all these things at a community level. You're making the practices stronger by providing more services in the community so that now you don't have to send the patients to the hospital.
So great, you're reducing the cost of care, but you're not giving the money back to the people who are paying for the cost of care. You're keeping it for yourself and for those people who are making the investment in those particular.
No. Hang on, no. You're actually getting it completely wrong, partly because savings that you're getting are on various different things that you are buying from, let's say, whatever distributor that you're buying it from. You're not charging the patients anymore, right? You're not charging the patient even a cent more. You're not charging anybody anymore. What you have done is you're reducing your overheads that you were paying a lot more for. And consequently, now you're able to provide more services for the patient. You're able to recruit more doctors. In fact, we are recruiting 2 doctors this year. And one of them is going to be an Ivy League trained doctor that we have not been able to recruit for 5 years in the state of Connecticut.
And they will also get an unknown percentage of the savings. Like
these are going to be doctors who are going to be employed by our practice. And we have a practice which is a PC. And these are
So Dr. Kapoor, do you think, I'm just going to have to intervene a little bit.
Sure.
Do you think you and Representative Denning can have a conversation after this hearing? The two of you can figure this out a little bit?
Absolutely. I have no problem. I would love to, because I think the more we learn about everything that we are doing, the more educated we are, the better prepared we are.
I agree. Let's figure out how we can connect.
Absolutely. Would be more than happy to sit down with you.
Thank you, Mr. Chair.
Thank you, Rep. Denning. Senator Gordon.
Thank you, Mr. Chairman, and Dr. Kapoor. It's nice to see you, albeit virtual. It's been a long time since I last saw you, so you're looking well.
So are you.
Thank you. And I understand your situation and the arrangement you have very well. So I'm not going to ask you any questions about what you're doing in that arrangement, because I do understand all the details of how those types of things work. My question is more, your situation, in fact, is different than what one of my big concerns about is when we're dealing with hospitals being bought out by private equity firms. For example, what happened to, Rockville Hospital, Manchester Hospital, the whole situation that's going down there by Prospect. That's a different situation than what you actually have, in your arrangement with your group. And I'm glad it's working well for you. Clearly, it's disastrous with what Prospect's done and what we're seeing with Stewart's system up in Massachusetts, for example. So there's clearly some bad actors when they buy hospitals. And from your point of view, if one were to be looking at what to do to better control these situations to prevent harm when private equity firms want to buy hospitals, not private practices, for example, would you view that as differently than a broad brush approach overall for private equity?
Absolutely.
For all different situations?
I would absolutely view that very differently. First of all, the management services organization that we are partnering with, OneOncology, they do not own my practice. So that's the first big change. The problem with Prospect and Stewart has been exactly that problem, that they own the practice, they own the whole systems. In our case, we are a community-based practice. And we've been, providing care to our patients for, like I said, 39 years now. There is no reason for us to be selling out to anybody. That's why we did not join one of the bigger networks. And we did not want to be sold to anyone. And that is the distinction that I want to make in this meeting, so that everybody understands that our goal is to remain independent, because we can make all the decisions independently right in Eastern Connecticut. Nobody tells me what to do. There is no interference in any clinical management. What I get is the business expertise that I did not have as a small practice, the technology expertise that I did not have as a small practice, access to more clinical trials. We were doing clinical trials very well to begin with, but we have more clinical trials now. And to be able to have all the expertise along with what I do. And that's the difference between our arrangement with our management services agreement versus a place like Prospect. I don't know what their arrangement was, but it was a total buy the whole hospital system. And when they ran into trouble, they really ran into trouble. I
appreciate that. And that's the difference I'm trying to make, is a different situation where you have contracted, but yet the private equity is not controlling you or owning you.
Absolutely not.
The concern I have from patient care is when these private equities come in, for example, and they want to buy hospitals, or they want to buy a large physician network. Those are big things that I think we do need to act upon and do need to see what to do. But I agree with you, we should not necessarily lump everything into the same situation, because a situation like yours and others I know who have situations similar to yours are indeed very different because you're not owned and controlled by the private equity firm. So that's all the questions I have, Mr. Chairman. And thank you again, Dr. Kapur. It's nice to see you. And
Nice to
hopefully
see you,
we'll be
Dr.
able to
Gordon.
see each other in person.
Absolutely. Looking forward to it. Thank you.
Thank you. Thank you, Dr. Kapoor, for your testimony. I think there are about 10 other people who have questions. So what I've suggested is you would have to take each and every one of them out for coffee or something later.
More than happy to. I would. This is as you know, Dr. Anwar. This is a passion of mine, and I am absolutely invested in this passion. And I'll keep on doing whatever I can for patient care in the state of Connecticut.
All right. Thank you so much. Seeing no other questions or comments, we'll move to the next person on our list, which is Coco Selman. Welcome. Sorry we had you wait.
No problem. Thank you so much. Chairs Anwar and McCarthy Vahey, ranking members Sommers and Clarides Ditria, and distinguished members of the Public Health Committee. My name is Coco Selman, co-owner of All Point Home Care, a Connecticut licensed and Medicare accredited home health agency, specializing in around-the-clock in-home nursing care of medically fragile children and adults. 90% of our patients receive care through Medicaid. I am also the board chair of the Connecticut Association for Healthcare at Home, and my stepdaughter, Amelia, is a home health beneficiary receiving 16 hours a day of continuous skilled nursing in our home. I am here regarding Senate Bill 1 and Senate Bill 369 regarding safety of home care workers. The tragic murder of home health nurse Joyce Grayson in October has forced all home care providers to review and improve our safety and workplace violence prevention programs, including risk screening tools, interventions to mitigate risk, and staff safety training. I am grateful that workplace safety has become a legislative priority. We are united in our commitment to care for our team members and patients safely. It is also important to see the complexities of community-based care and not to jump to quick conclusions about the best path forward. I do not support the mandates outlined in Section 1 of these bills without further collaboration of how home health providers can better access the outlined information. I fear that until we address the root cause, the inadequate access to information, we will be set up to fail our community workers. This will both be ineffective and have unintended consequences of limiting access to patient care. I do, however, strongly support Section 8, charging a work group to make thoughtful, well-considered recommendations to a very set of complex challenges to safely serve a community with a diverse set of needs. For example, my agency serves medically fragile children and adults in their homes in 90 towns. Our nurses provide continuous skilled nursing around the clock. Each nurse provides 8 to 12-hour shifts in a single home. While most of our patient population is very low risk to inflict any harm or violence upon our employees, the larger risk comes from the other family members or household visitors in the home. Other than the patient, we have no information about who lives in the home or who might frequent the home. As a provider, we have policies in place to support our nurses should they feel threatened in any way. However, it is important for the members of the Public Health Committee to understand the complexity of keeping our employees safe goes beyond just the patients. I strongly support a fee increasing and insurance coverage for escorts. I also support training, enhanced safety mechanisms, and grant funding through DPH, and ask these funds cover the full cost of staff safety technology. This is our chance to get it right for home and community-based workers while ensuring every patient continues to have timely access to the care they need. I thank you for this opportunity to provide testimony and invite any questions. Thank you.
Thank you so much for your testimony. We hear you. I think there may be areas of opportunity. I believe you have a written testimony as well.
I do have written testimony, but I haven't submitted it yet. So I apologize for that.
No, it's okay. You can always send that to us. So we'll appreciate that.
Okay, thank you.
Seeing no questions or comments, we'll move on to the next person on the list, which is Dr. Scott Gray. Welcome, Dr. Gray.
Thank you, Senator Anwar. I'm happy to be here and distinguished members of the Public Health Committee. I'm testifying on behalf of the orthopedic surgeons in the state of Connecticut. I practice in Danbury, Connecticut. I'm a foot and ankle surgeon, and I have a lot of experience with the fluoroscopy. The problem with this bill, House Bill 5488, is that I believe, and so does the orthopedic community, that this issue should go through the scope committees. We believe that the language as it states would expand the scope of practice for the APRN community without really knowing what they're going to be doing. There's no language in the bill that specifies what APRNs wish to do fluoroscopically when they practice independently. For instance, there's no language in this bill that outlines what amount of training hours that should be required that, for instance, physician assistants have to have. There's also no signing off on proficiency. There's no language that discusses who's going to certify who's qualified. And the real concern is that it would allow an APRN in an independent office outside a hospital setting where there's no radiologist present, as we heard testimony from a radiology APRN, there wouldn't be one available. So what procedures can they really want to do? Because this would allow them to utilize fluoroscopy in an outpatient office setting, unsupervised. Again, like in the OR for me, I utilize physician assistants who have been trained, passed the certification, had numerous hours of doing it before I felt comfortable allowing them to assist me in the OR managing a mini C-arm, which is a form of fluoroscopy. All large C-arms are really primarily in the hands of hospital settings where the radiology department manages it, or occasionally in pain management offices where, again, they have a radiology technician who's properly certified. Some of the procedures, and again, this is a privileges to utilize fluoroscopy are procedurally based. Interventional radiologists use it, cardiovascular departments use it, gastrointestinal departments use it, and orthopedic surgeons, of course, use it in the hospital setting in an outpatient surgery to manage fractures, either closed or open. So I have serious concerns about what APRNs would really want to do with this privilege in an independent setting, because none of the procedures that I just discussed with you are within their scope of practice. So that's a bit of a conundrum I have. So we'd like to join the orthopedic community in opposing this Section 10 of House Bill 5488 until some of the questions that I outlined are really answered and looked into, and the questions for the APRN as well, particularly what they would do with this when they can't, within their scope of practice, currently do. And I thank you for your time. I'd be happy to answer any questions.
Thank you so much for your testimony, Dr. Gray, and thank you for being with us for a significant part of your day. We hear you. Do you have a written testimony too?
Yes, I believe it's being submitted or already submitted.
Okay, we appreciate your testimony and we'll take that into consideration. Seeing no question, we'll move to the next person on our list. But before we do that, we will have to recess the public hearing for a short time. This is being shown live on YouTube, and YouTube has informed us this has been too long, so they're running out of space. So we're gonna have to go on another channel to live stream it. So we will pause for a short duration, so bear with us. This is the time you can stretch your legs and move those clots out of the way.